Hello, and welcome to the first day of PHONOCON 2020.
Anil, I will start. It's already.
Nipur ma'am, good morning. This is Anil.
Good morning.
Event organizer.
Yes.
We will
Yes. When should I start?
Yeah, we will let you know. So we will inform you on top. Yeah.
So should I stay on mute till then, till you let me know?
Yes, ma'am. Yes. Ma'am, I will be telling you. So Hasni, I'll be telling you over to you, ma'am. Is when you'll be starting.
Okay, perfect. Okay, so I'll put my video off also till then.
Yes, yes.
When can I start the video?
Yes, Anil.
I'm going to be saying a few words before the video. So Hasni has to tell me when to start that.
Yes, yes, ma'am. Shall do that.
A very good morning to all the delegates. On behalf of APSI and the Department of ENT KIMS, I welcome you all to a cornucopia of knowledge, experiences, and surgical innovation, PHONOCON 2022. So over to our coordinators, Dr. Suhasini and Dr. Aditi, who will take you all through the sessions for today. Thank you.
ये हंसी वादियाँ ये खुला आसमां या गए हम कहाँ ऐ मेरे साजना इन बहारों में खिलती खुली खिल गई मुझको तुम जो मिले हर खुशी मिल गई ये मेरे वतन के लोगों जरा आँख में भर लो पानी जो शहीद हुए हैं उनकी जरा याद करो कुर्बानी.
Thank you, Dr. Suhasini, for relishing the evergreen melodies of the legendary singers Lata Mangeshkar ma'am and S.P. Balasubramaniam sir, whose recent demise has left the country in tears. Their voices shall forever echo over the cultural fabric of India. We, as phonosurgeons, on a platform that celebrates the beauty and intricacies of the voice box, will forever be in awe of the miracles created by these legends.
With that, we welcome you all to PHONOCON 2022. We have set the perfect platform for us to explore what the best of the brains think about this dynamic and ever-evolving field of ENT, that is laryngology and phonosurgery. We start the day with instructional courses in both Hall A and Hall B. In Hall A, we have Dr. Nupur Nerurkar ma'am discussing about the use of lasers in laryngology. Dr. Nupur ma'am is a laryngologist and voice surgeon at Bombay Hospital and Medical Research Center. Delegates are requested to post their queries during the session in the chat box, which will be addressed by ma'am at the end of the session. Over to you, ma'am.
Thank you so much, Dr. Suhasini. Welcome everybody to the first day of PHONOCON 2022. First and foremost, I must compliment Dr. Sanjay Subaya and his team on this academic feast that they've put together for us. It's really brilliant. And I think we have a record-breaking number of award presentations which have come here this year in PHONOCON. So that's really great. And secondly, please do, as Dr. Suhasini mentioned, put in your questions in the chat box because we do have time for a live Q&A. And with that, I request the IT team to please play my video. Thank you. This, of course, is an acronym for light amplification by stimulated emission of radiation. And I work in Bombay Hospital, where I've been using a laser in my laryngology practice for over 16 years now. However, every year we do conduct a phonosurgery workshop and laser training at my alma mater, which is St. J.S. Medical College and KEM Hospital. The first laser was discovered in 1960, which was a ruby laser by Memon, and the CO2 laser was discovered in 1964 by Kumar Patel. And it was in 1967 that Yako and Poliani for the first time used the CO2 on a cadaver larynx, but it was only because of the Bradmer's endoscopic delivery system, which was the micro manipulator, which was introduced in 1968, that Yako was able to use it in vitro on canine models. And so what is the basic components of any laser system? There has to be a laser medium, which is a variable medium. It could be gas, like a CO2 laser is gas. It could be liquid, a solid, a semiconductor even. And then you have to have an excitation energy source and the laser resonator chamber. Why would we want to use lasers in laryngeal lesions? Well, a laser is a tool. Just like an artist has a paintbrush as one of his or her tools to create beautiful paintings, a laser is a tool which can be used by laryngeal surgeons to create the operative result which they want to create. The specific advantages of using lasers in laryngology would be that a laser is a precise tool. So it allows not only for precision, but a sharp cutting with some amount of hemostasis. You can consider it to be a hemostatic scalpel. The depth of lesion of penetration can be controlled by you by the laser specifications. So you can be only in the epithelium, in the SLP, ligament, even muscle. So therefore, it's very useful in submucosal lesions, especially lesions which don't have any margin, which have diffuse margins, where you want to cut through and create your own margin without having too much of bleeding. Once again, it's simply a tool, and we need to know that every tool needs to be used in certain situations and in a certain manner. So there are various lasers with different wavelengths available, because changing the lasing medium changes the wavelength. But typically what is used in laryngology currently are the true blue laser, the KTP YAG laser, the pulse dye laser, and the CO2 laser. So we're going to discuss a little bit about these lasers, because not all of us can buy all these lasers. So maybe you need to first choose one laser for your practice and decide what specifications suit you. So how are you going to go shopping for a laser? Depending on the laser you select, the absorption length in the tissue varies. For example, a CO2 has a very superficial absorption length and is absorbed. Also, different lasers are absorbed by different materials depending on their absorption coefficient. So a CO2 laser has a wavelength of 10,600 nanometers, and it's particularly well absorbed within water. Most tissue has water, and it also has a short absorption length. Nowadays, the CO2 laser is available not only as a free beam laser and articulated arm, but also as a fiber laser. But of course, the wavelength remains the same. The various fiber lasers which are present in the market today are the 445 nanometer true blue laser, the 532 nanometer KTP laser, and the 585 nanometer pulse dye laser. And these are all fiber lasers which are well absorbed by oxyhemoglobin, which can prove to be a great advantage, and we will discuss that. CO2 laser is considered by many to be the workhorse of laryngeal practice, and I do believe so myself. I'm using the CO2 laser. What are some of the advantages? It's got a depth of penetration which could be as small as 250 microns, a spot size which can be as small as 0.02 millimeters, heat dissipation less than 500 mu with a shallow thermal damage zone. And all of this is actually most efficient when you use the CO2 laser in the scanning mode. And what is a scanning mode? I'll come to in a bit, which allows you to use what we call an AccuBlade. Now, the CO2 laser earlier was only available with an articulated arm, free beam, but since the last 4 or 5 years, is available also as a fiber delivery system. But the fiber delivery system has the same wavelength of 10,600 nanometer. The hemostasis, which is provided by a CO2 laser, is only up to a certain extent. So it can only maybe get vessels, blood vessels, which have 0.5 millimeter diameter, not more than that. So sometimes in surgery, and very often in surgeries like Kashima or TLMC, one does need to have cautery available with the insulated suction or insulated forceps also. So as I mentioned, the CO2 laser can be in a free beam form, or what's available now is with the fiber, which is known as the duo laser. And so basically, you have a micro manipulator, which gets paired onto your microscope. So this is what's come in the circle, is the micro manipulator. And then you have the articulated arm of the CO2 laser, which gets attached to this micro manipulator over here. Here we have the micro manipulator mirror. Then you have the joystick over here, which is what you actually hold to move the beam around, which is the Henny beam. And you have the laser light, which collimated bright light, which comes out over here through the center of the microscope. So when one has connected the CO2 laser onto the microscope, you need to decide what are the specifications you're going to be working with. Now, if you are going to be using if you're not going to be using the scanning system, then what you get is a spot, which can be called an AccuSpot. But if you're going to be using the scanning system, then you get what is known as an AccuBlade, which could be a straight line or a concave or a convex line. And this concave convex line can rotate by 360 degrees. The control is in the joystick, which we saw earlier. So what's the big deal about this scanning and non-scanning system? So the first thing you select on the touch screen of the laser is, are you working on non-scan or scan? So when you say a scanning system, basically the beam is going to be scanning the surface of that entire blade very quickly, zzz, like that. So at a given moment of time, it's not going to be present at a spot for more than a split second. It's going to be moving constantly, and therefore one can use much higher powers than you would if you were in a non-scan system. So typically you'd use 2 watts with an AccuSpot and 10 watts with an AccuBlade. However, power is not the only factor which matters. This is very important to understand. It's the fluence of the laser which matters, and we are going to just talk about that. So first of all, in laryngology, especially in phonomicrosurgery, I would always recommend the use of a scanning system. And what you need to decide then is by, pressing the buttons over here, whether you want a straight AccuBlade or you want concave, convex. Secondly, you can change the shape size from 1 millimeter to 2, 3, 4, 5. You can change the depth from 1 to 2 to 3. Now, this is not millimeters. 1 is 250 microns. 2 would be 500 microns. So that's superficial at depth. And here is something very important, the time on and the time off, which has already kind of been pre-decided by the system, and you can play around with it. So the time on, as you can notice here, is 0.03 seconds, and the time off is 0.45 seconds. So that means a cooling period after every pulse is more than 10 times. So there is adequate time for the tissue to come back to at least 50% of the original level at which it was. Here you have the power, which is 10 watts in the scanning system ideally. And then you can decide whether you want to use a beam which is in a pulse mode, like a super pulse or even an ultra pulse, or you want to use it in a continuous mode. Finally, you can decide whether you want your foot control to be single. That means your foot may stay on the foot pedal, but you'll only get one single pulse. Or it could be continuous, bzzz, or it could be in repeat mode. And typically what I prefer to use is repeat, super pulse, 10 watts, 1 millimeter shape size, depth is 1 to 2 to maybe even 3. And I usually decrease the time off to about 0.3. So we're doing all this to minimize thermal damage and still get efficient cutting. What are the other ways you can minimize thermal damage? besides using the AccuBlade system, you can make sure that you are cutting with the laser at 90 degrees to the tissue rather than tangential cutting. The depth of the cut can be controlled by you. You have to work at a correct focal length, because if the beam is not a crisp, sharp beam, you're going to have increased charring. And again, if you decrease the time off a lot, then you would get more heat dissipation, maybe more charring too. Using super pulse, ultra pulse are great modalities to get quick heat generation and a lot of cooling time also. One should have controlled, precise movement, of course, which the joystick allows you to have. And maybe using something like a sub-epithelial infiltration technique provides for a heat sink, a buffer in the SLP area when you're using the laser. In addition to this, one can keep mopping the vocal folds with wet cottonoids, even ice cold saline if you want to help cool down the tissue. I like to use laryngeal wash occasionally to clear the char if it's developing, definitely at the end of the surgery actually. And don't use the laser over char. That would cause even chances of a laser fire. Don't use the laser when there's active bleeding, because you'll get that, that much more charring then. When one is using a fiber laser, I'm not talking about the free beam, then the ideal spot you want to achieve is a round circle. This could be acceptable, but you don't want a dot with a tail. That's unacceptable. And the distance you keep the fiber away from the tissue would determine the cutting effect. So 1 millimeter away would be ideal for a good cutting effect with a good spot size like this. If you kept the fiber tip, let's say 5 millimeters away, you would get more of a ablation and hemostatic effect, and the trough and the beam would become wider. Let's talk a little bit about the fiber hemoangiolytic lasers. All of these, whether it's the True Blue or the KTP or the pulse dye, they're all precise for targeting oxyhemoglobin, which has a wavelength of about 571 nanometers. Now, one achieves a selective photothermolysis because there is a full penetration of the intraluminal blood vessels. And this fiber laser allows for office procedures, which is such a fantastic advantage that it possesses. Particularly in the case of KTP laser, the fiber is 50% the width of the pulse dye. So it allows for better suction effect, and it also has a smaller thermal damage zone. And anyway, the pulse dye laser is not available in India, and neither is the KTP. And I believe the KTP is probably just getting phased out. Now, the True Blue laser, which is a new kid on the block, not so new even. I mean, it's been there for about 4 or 5 years. It's supposed to have a CO2 plus KTP-like laser action with 10 times higher absorption in hemoglobin. It's also a very compact machine. It's got a low maintenance, and it can tackle blood vessels from 1 to 3 millimeters in diameter, unlike the CO2, which was 0.5 millimeter in diameter. So these are great advantages. There are lots of advantages of in-office lasers. One is that when you're doing, in-office procedures with a laser, you're not giving general anesthesia. Therefore, you're not admitting the patient necessarily, so which reduces the cost of treatment. And for vascular lesions, these lasers are extremely efficient and useful. The True Blue can vaporize the blood vessels beneath the epithelium without damaging it also. There are a few disadvantages. That the first would be, of course, a learning curve, but with any new technology, there is a learning curve. And cost of equipment is probably an issue, but as I mentioned, in laryngology, most of it is all about a lot of expensive equipment, actually. Patient cooperation whenever you're doing any office procedure, of course, is important. Indians, I think, are quite a cooperative lot, actually. And then you have to be hitting a moving target. The vocal folds are adducting and abducting, so you kind of have to practice to get to the right spot. So we're going to talk a little bit more about the laser specifications, because I think this is so important to understand. So basically, as a physician, you can control 3 variables. And every year when we conduct a phonosurgery workshop, one of the questions asked by the delegate is, so what what is the power you're using when you're operating with a laser? And my answer always is that power is not the be-all and end-all of everything. So what one really needs to ask is what is the fluence of the system? There are three things which are important. Yes, power, which is measured in watts. The spot size is very important. Are you working at 1 millimeter, 5 millimeters? And thirdly, the time on and the time off. So the exposure time, which is measured in seconds. So the power, so this exposure time, as we spoke about, could be a continuous beam or a pulsed beam. Now the power with the spot size gives what is known as the irradiance. And a time in seconds that a laser beam irradiates a unit area of tissue is the fluence of the system. So this fluence is what is the most important thing in any laser machine. We can change the power, spot size, and exposure time. We cannot change the wavelength of a laser. We cannot change the target chromophore. If you halve the spot size, if you decrease the spot size by half, you don't double the laser energy, it gets 4 times more increased. If you double the spot size, you don't halfen the laser energy, it gets 1/4 of the laser energy density. So it's not a linear equation. And 5 joules per centimeter square delivered in less than 1 millisecond is the necessary fluence for an efficient vaporization. This is referred to as a thermal ablation threshold. What is thermal relaxation time? We did touch upon this earlier, but we didn't mention TRT. It's a time required by an object to cool down to 50% of the initial temperature which had been achieved. And once again, to highlight on the focus, to get that crisp laser beam of the acute blade, if you have, so we are operating in the larynx at 400 millimeters, the microscope, then you have to focus the laser beam also at 400. If it is unfocused, then this is the first exposure, you get a cut with a lot of char. When you focus the beam, you will get a crisp line such as here, and then your cut would be with almost zero char. So the focusing of the beam is essential. So I'm just making the talk interesting. This is such an exciting looking picture. This is the Adam's apple. We know what is the Adam's apple, but did you know that the word Adam's apple came from a notion that it was caused by the forbidden fruit sticking from Adam's throat as he swallowed? We do get exposed to surgery on the Adam's apple when we have patients, trans women, who want a tracheal shave or a thyroid shave, more correctly said. Anyway, let's forget about Adam. I really want to talk about the apple. If you take an apple and you use the laser on it with different laser specifications, so you can keep the power the same, but you can use it either in continuous or in super pulse or ultra pulse. You can decide to keep the power the same and super pulse the same, but you can change the time on and off. So you change the variables and you use the laser for yourself on, let's say, the apple, and then you cut it very thin slices and you see the depth of penetration and the charring. And you will get an idea how the laser specifications are so important to tissue interaction and what is going to actually happen on the vocal folds or whatever part of the larynx you're operating upon. Similarly, with a fiber laser, if you're to use it over here on a glass, and you see the depth of penetration of the fiber beam depending on the changed laser specifications which you have used. Let's now come to a little bit of the practical applications of a laser, and I'm going to now talk about CO2 laser specifically because that's what is available to me and that's what I'm using. I would say malignancy of the vocal folds is something which one can tackle so well and efficiently with the laser. And then diffuse subepithelial lesions like amyloidosis, anterior glottic webs, papilloma. I do use a lot of microdebrider, and when it's a carpet of lesion, I also like to use the laser. Kashima surgery, when you're operating for immobile vocal folds, when you're operating on vascular polyps or varices. In the case of Rinke's edema, even in benign glottic lesions like cyst sulcus contact granuloma, but you have to make sure you're using the laser with the best fluence possible and the AccuBlade system. And then you can use the laser for airway, swallowing issues like subglottic stenosis, Zenkers, even in spasmodic dysphonia for thyroid myoneurectomy, when you're creating a web, anterior glottic web in Wendler surgery. So there are lots of applications. And time permitting, I'm going to just share some with you. So let's start with an example of a transoral laser microlaryngeal cordectomy in a patient who's got a right vocal fold lesion, which is an invasive squamous cell carcinoma. So first we perform a palpation of both the vocal folds, following which this is a subepithelial infiltration when 1 in 10,000 saline adrenaline. Now we're using the AccuBlade laser, as you can see, to excise simply the lesion, no margins currently, simply excising the lesion, which we are holding with a Boucher or heart-shaped forceps pointing to the right-hand side. We're holding this in our left hand, and we're holding the joystick in our right hand, and we are excising the epithelium and separating it from the SLP and the underlying ligament, of course. What I like to do is send this tissue in for frozen histopathology. Now, there is a little suspicious area you see posteriorly. So what I prefer to do is excise all the suspicious area so that once I've got a confirmation of invasive squamous cell, then I like to send the margin from the patient's side. So you see the cut was made in the ligament anteriorly. Now it's being made laterally in the ligament. So what we are doing is a type 2 cordectomy. We are excising the complete right vocal ligament along with the periphery of margin of 1 to 2 millimeters. And this entire carpet of tissue, which is a margin in depth and all around periphery, is going to be sent once again for frozen, or you can directly send it for histopathology. This is the posterior cut. We're holding the ligament and with a Boucher forceps and retracting it medially. And you can see how we are cutting the plane between the ligament and the muscle. So what you are left with eventually at the end of surgery is simply the entire thyroarytenoid muscle, and what you see is the vocalis. This is the infraglottic epithelium which is being laserized, and this is the post-operative view of a type 2 cordectomy. So this is the first, I would say, great use of a laser, whether you're doing a type 1, type 2, type 3, type 4, all the way up to type 6 cordectomies. I think a laser is very efficient for that. Second, I'd like to share with you vascular polyps. I think this is also a great use of a laser. This particular patient is a singer, very famous singer, and he has developed a hemorrhagic polyp on the left striking zone. There are a few what seem to be possible feeding blood vessels also. So we always palpate first, always make sure there's no other lesion like a focal pit, etc., or a mucosal bridge. Now we're performing the subepithelial infiltration in the SLP of the left focal fold. And we are going to excise the polyp using the AccuBlade by making the epithelial chordotomy bang on the lateralmost extent of the polyp, as you saw here. This is the mini microflap. Then we're holding the polyp with a Boucher forceps and pulling it gently medially. What are we trying to do? We're trying to excise the polyp, not by preserving its overlying epithelium. There's no need. There's so much redundant epithelium, but by preserving the infraglottic epithelium, which is the white area, this area of the epithelium, which you see now. This is the infraglottic epithelium, which is going to be used to cover the medial vibrating edge, as you saw. So I'm kind of trying to measure how much is redundant and where I need to make a cut on this epithelium so as to cover the medial vibrating edge, and always have a little bit of excess if possible rather than less. Now, there is a very small irregularity over there, which I am not going to laserize. What I am laserizing are the varices or dilated blood vessels on the right vocal fold. And here we use the laser in a little defocused mode. So when it is defocused, it has a better hemostatic ability. So all the feeding blood vessels or varices on the left focal fold now are being ablated. It would be very easy to ablate that little irregularity, which I'm not doing. And the specific reason is singers in particular are you have to be very careful in terms of the character of their voice. So if they have got a voice which people are used to with a little bit of a roughness to it, you can't suddenly give them an extremely high-pitched feminine kind of a voice. So it's better to keep a little bit of the graininess of the voice, to keep a little bit of this irregularity rather than overdo the laser excision. And I'll show you the post-operative stroboscopy of this is the patient.
अभी नीचे सुर में जाइए, अभी ऊंचे सुर में, एक बार गलत
एक पल चैन न आवे, सानू एक पल चैन न आवे, सजना तेरे बिना है, सजना तेरे बिना। रे हिचकी आवे रे हिचकी आवे रे हिचकी रे।
And let's move on to a condition which is one of my favorites, which is sulcus. So of late, we've been performing a surgery which we have termed as LASR, or the laser surgery, which is a laser-assisted sulcus release, which is based on the principles of two surgeries. One is Ponte's technique, Ponte's and Bellau technique of slicing mucosa for sulcus, and the second is the triradiate laser incisions, which one can take for subglottic stenosis. Based on these two surgeries, we came up with this laser. Over here, the patient has got two sulci on the right vocal fold and two sulci on the left vocal fold also. Both of these are type A sulcus. Now, the classification I'm using, type A, is our own classification, which we've published in the Association Journal. So here we performed an infiltration on the left vocal fold, and using the laser beam with a length of 0.5 millimeter, we are making cuts at right angles to the sulci. The medial lip and the lateral lip of both the sulci on the left side, and we'll do the same thing on the right side as well. Now, the idea behind this surgery is that the new epithelium which grows in this shallow sulcus should hopefully grow not dipping down, but in the same plane, which would take about 4 to 6 weeks. And then the patients receive quite an aggressive and exhaustive 2 to 3 months of voice therapy following the surgery. There is voice rest for 7 days. And the final outcomes we see typically at 3 months. And we've had pretty promising results with this surgery. So we use the laser over here. And I think a lot of us use laser for performing Kashima chordotomy. Of course, a coblation system can also be used for this surgery. Now, Kashima surgery is a very simple, a very quick surgery to create an airway in a patient who has bilateral vocal fold paralysis. Basically, you're separating the vocal fold from the vocal process by a cut which is horizontal, going from the medial edge of the vocal fold all the way up to the thyroid inner perichondria, which can be achieved by retracting the false vocal fold, as you see right now, or you can even cut the false vocal fold so as to see that 1/3 of the true vocal fold, which is lying beneath the false vocal fold, which is being done now. Because of the tensile strength of the thyroid muscle, there is a retraction anteriorly, and you've made a linear cut, but what you get is a triangular cut. In post-radiated patients, the surgery may not be so effective. So again, a great use of the laser. I want to show you one of the complications I had following Kashima surgery. This was a patient who had had a total thyroidectomy done outside of Bombay Hospital and got stridor and a tracheostomy done. As we can see, there is hardly any glottic chink. And so I performed a Kashima chordotomy on him. And when he came for his 1-month follow-up, this was the laryngoscopy. I had done a left Kashima chordotomy, And what you'll see is a granuloma right where I had operated. So there was, you can call it a carbon granuloma or a contact granuloma, or it may be because of exposure of the cartilage vocal process that there was a granuloma which was actually blocking the airway. So what we did in this particular patient is we injected botulinum toxin into the left vocal fold, and this was his healing. Following maybe a month after the botulinum toxin injection, the granuloma resolved completely, and we were able to then successfully decannulate the patient. So I will show you, time permitting, the last surgery, Rinke's edema. Over here we see a type 3 Rinke's edema where you have multiple polyps on both the vocal folds. Patient is a smoker. You have to make sure that they stop smoking before you do the surgery, or recurrence is almost always going to happen. Now, with Rinke's edema, you would imagine there shouldn't be too much bleeding because there's just increase in SLP, but that's not so. They can be quite vascular. As you can see over here, we have quite a bit of bleeding, even though we're using the CO2 laser. And therefore, in the blood, one shouldn't lose the layers which you're operating on. So you have to keep mopping and seeing that you are not excising an excess. If you excise too much of the epithelium, of course the SLP is an excess, but if you excise too much of the epithelium and even the SLP, you may land up with a situation, one, where the vocal folds are very thin. And for a male patient, that can result in a very high-pitched voice, which would be very peculiar and unusual. Secondly, if you lose epithelium on both the vocal folds, especially at the anterior commissure, then you would result in a massive web, and that would be horrific. So here now you see, we have just a small area anteriorly where we make a small cut on the superior surface and just squeeze out the SLP. We don't want to make anything raw on the right vocal fold because we've made a linear cut on the left vocal fold. So at the end of surgery, we have no loss of epithelium on the right side. And even on the left side, actually, we just have a little loss of epithelium on the superior surface. What are the possible sort of complications of using laser? Well, with the CO2 laser, one can get what is known as a healing carbon granuloma, which was first described by Betelgeuse in 2005. These are granulomatous lesions which can develop at the operating site. And the problem is that you're concerned during follow-up as to whether this is any kind of recurrence or is it just a healing granuloma. It typically is more likely the deeper you go into a tissue, like with the type 3 or the 4 codectomies, and maybe more when there was more char, or if you left cotton fibrils behind even, or when you used cautery excessively. It could also be related to poor wound healing factors like diabetes mellitus, not necessarily affluence of the laser. We've published in detail our findings of carbon granuloma in lasers and medicine in 2019. So you could sort of read that article. And I do like to always give a laryngeal wash to clean up all the char, even cotton fibrils at the end of surgery. And I mentioned this earlier also, I think. So basically, with increased power does come increased responsibility. So we need to have our safety measures in place. Eye protection is important, not only for the patient, but even for the OT personnel. So depending on what laser you're using, you'd be using colored glasses or transparent ones. Anesthesia precautions in terms of using laser safe tubes. But even then, even if you have a Mallinckrodt with double cuff, the cuff itself is not made of material which is laser safe, so you need to cover it with a patty. Nitrous oxide should not be used. Any inflammable gas should not be used, and you want to keep the FiO2 less than 25%. Keep the laser in the standby mode when it's not being used. Keep a moist, large, subglottic patty in place. Have good suctions in place for the laser plumes. Keep a bucket of water ready in the OR in case of a laser fire. Have an indicator outside your OR that laser is in use. You don't want people walking in and out without the eyewear, etc. And the laser fire is a very dreaded complication. Fortunately, it's a rare complication, but you want to avoid it at all costs. This typically happens when the laser beam directly hits a gas-enriched environment and it hits on the endotracheal tube, especially the cuff. So what happens within 1 to 2 seconds is that first it is a fire which is external, and then the fire is because it enters through the tube and becomes a blowtorch kind of a fire, which then goes right, you've got the fire going into your lungs. So it can cause significant burn injuries to the pulmonary tissue, subglottis, trachea, and it seemed to happen more with the contact lasers. And what you need to do is immediately remove the tube. Immediately means in less than a second, if you can. This disconnects it from the anesthetic circuit. You need to just dump it in a bucket of water and have yourself and the anesthetist kind of ventilates a patient, and then you kind of assess the damage and decide whether you want to reintubate, you want to do a tracheostomy, do have the patient in the ICU for observation after such a complication. And I'd like to end with this saying, which I have seen in a lot of presentations, and I just love it, so I can't resist, that a fool with a tool is still a fool. The more powerful the tool, the more dangerous the fool. With due respect to Ron Atkinson, I love Mr. Bean, and thank you very much for this opportunity. And I would be more than happy to answer any questions which may come up. Thank you.
Thank you, ma'am. Thank you for the wonderful and informative session.
Dr. Sanjay has informed me that I have 9 to 10 minutes still available to me. So I'm back. I will be spending the next 9 minutes discussing laser surgery for papilloma and amyloidosis, which is what I wasn't able to show as yet. Do remember that if you have any queries, please do type them into the chat box so that one may reply. Also, I'm happy to answer queries on my email, which is nupurkapoor@yahoo.com. You may also want to check out my YouTube channel, which has quite a few edited surgeries. So we are going to be seeing a representative surgery for papilloma and amyloidosis using the CO2 laser now. The first patient is a case of papilloma. He has a history of just one surgery in the past, about 15 years back. He's about a 55-year-old adult male. And at that time, the diagnosis was papilloma. So we presume what he has is a recurrence of the papilloma. However, there is a carpet-like growth on the right vocal fold, one can see over here, which may be dysplastic too. And then we have what looks like a papillomatous lesion in the anterior commissure with some overlying thick skin, leukoplakia, maybe keratosis. So the plan that we make for this particular gentleman is to excise completely the right side lesion and the anterior lesion, having discussed with him that possibly he would develop a web. So in order to prevent that, we would probably take him under general anesthesia in 7 to 10 days and clean off the slough, which develops at the anterior commissure. He has consented to this. So now this is palpation followed by subepithelial infiltration being performed in the right vocal fold, where we see a good blanching and lifting up of the epithelium. No donut effect. We don't really expect one. Following which we are performing the CO2 AccuBlade laser excision. Now here in papillomas, when it's a great example of papilloma because in the same patient we have both a carpet-like growth and a cauliflower growth. So for these carpet-like growths, which are very often seen in adult onset recurrent respiratory papillomas, what I prefer to do is a laser microflap in excision of the lesion. So the subepithelial infiltration was performed, and then using the same principles of creating a flap under the microscope, a microflap, the entire epithelial flap is elevated away from the superficial lamina propria. We do want this flap to be of complete thickness, including the basement membrane, because typically the virus, the HPV virus, is supposed to be living or indolent in the basement membrane of the epithelium. What we see over here is that the ligament is nice and free with the overlying SLP, and we have held the epithelial flap with the left hand with a Boucher forceps, and the AccuBlade is being used to elevate the flap, but not so that we reposit it. Here we're elevating the flap, and of course we're going to excise the complete epithelial flap because we know papillomatous disease is epithelial in nature. While performing the surgery, it's important not to be going into the ligament, because then you may introduce a papillomavirus into the ligament and deeper tissues, and one definitely doesn't want that. Having excised that carpet-like growth, now we're proceeding to the excision of the anterior commissure, granulomatous or cauliflower-shaped lesion. Now, there are two ways of tackling this. One is one can use a microdebrider and simply debulk the entire papillomatous lesion using a blade, which is not a skimmer necessarily, but a tri-cut blade. And the other way is to excise it with a laser. There is a third way, of course, using co-ablation technique. And if it was a situation where the lesion was developing more than 5 to 6 times in a year, there would be some role of injection of maybe Avastin or cidofovir also, if available, and if the patient consents to the same. Now, here we have used only the laser in the excision of both this cauliflower lesion as well as the previous carpet-shaped lesion. And at the completion of the surgery, it does not mean that every little bit of papilloma has been excised. One does aim for that, to remove as much of papillomas as possible. This is the laryngeal wash. So one does aim to remove as much of the papillomas as possible if you can do it in a safe manner without causing permanent cynical damage, etc., to the patient. So this is the demonstration of use of laser in papilloma. And now I'll move on to the second situation which I want to discuss, which is amyloidosis. As I mentioned, amyloidosis is a condition where there aren't very clear planes. There is no cyst wall. You are creating your own margins during surgery. So let us see the stroboscopy of this lady who came to me with hoarseness of voice. And it's very interesting because in her case, you will see it appears to be 3 vocal folds on either side. One, of course, is the false vocal fold. One then is the true vocal fold. And then what you see below the true vocal fold is appearing to be like a third vocal fold. And this is what we call a pseudosulcus, when there's an infraglottic swelling or infraglottic bulge, which could be because of acidity. It could be because of, in this particular situation, the subepithelial lesion, which is amyloidosis. It could even be malignancy. So not every pseudosulcus should be thought of as only because of reflux and ignored. If one does a CT scan with contrast, you would get in this situation some amount of enhancement in the infraglottic area of both the vocal folds. Let's hear the voice of the patient.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
We'll move on now with the surgery. We've already told the lady that we are planning a stage surgery. We obviously don't want to excise both the infraglottic lesions and land up with this huge web. This is palpation of the left infraglottic lesion, which is quite firm. The right posterior infraglottic area is quite okay, but the lesion is more present in the anterior infraglottis on the right side. So the plan is to first remove the left complete infraglottic lesion. Let the healing take place of the infraglottic epithelium for 4 to 6 weeks minimum. Have a stroboscopy look at the patient once again, and then decide to go on to the right side. All this in an attempt not to cause a large glottic web, possibility of even stridor, besides the hoarseness which that would create. So as you can see, the AccuBlade laser is being used to make an incision or to create an incision at what is felt to be the medial vibrating edge. So here we have to decide our cutting planes by palpation, by magnification, and also when we cut through the tissue, to see that typical yellow-gray kind of firm appearance of amyloid as compared to normal soft tissue within the vocal folds. So here the heart-shaped forceps is being held in my right hand, and we're gently retracting part of the amyloid tissue posteriorly, because when you sort of retract tissues, as we discussed earlier, you would get the best cut from the laser. And all through the surgery, you see there's hardly any charring which is taking place because of the scanning system and the AccuBlade which we're using. And over here, we are excising the posterior margin of the amyloid from almost the vocal ligament and the infraglottic surface, going a little into the subglottis also. We're trying to take the lesion out again like a carpet or a sheet. But of course, as I mentioned, as there's no plane, one would have to keep evaluating and seeing for leftover amyloid tissue, because you really do want to have as complete an excision as possible. There is no medical management of amyloidosis. So it's really an ideal treatment is the laser surgery which you're performing. So you do want a complete excision if possible. Laryngeal amyloidosis does grow very slowly. So at least in our series of patients, we've only had to do a revision in 1 or 2 patients. Now we've gone to the anterior part of the infraglottis. Again, it's like a carpet, the entire carpet being excised. We do see some amount of bleeding because amyloid is not a completely vascular lesion. It's not very vascular, but you would occasionally have some amount of bleeding with the surgery. So once we are going to the anterior commissure, we've already decided that we are going to only excise the left entire lesion, bang up to the anterior commissure, and go in for the second stage on the right side after 4 to 6 weeks. You see the lesion being excised. It's slightly out of focus because it's more gone into the subglottis now. You saw the yellowish lesion. Now we are retracting the left focal fold with a microflap elevator. And we are performing laser ablation now. This is not laser excision, but laser ablation of the amyloid, which was lying on the subglottis or all the way up to the cartilage, so that we have a complete excision. And let's hear the patient's voice 4 weeks after surgery.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So significant improvement, and we still have to operate on her right side to get a better mucosal wave. So with that, I come to the end finally of my talk. And I do hope that this instructional course in lasers and laryngology is a new beginning for some of you into this beautiful field. And with that, I'd like to thank you. And
thank you very much for the wonderful and informative session, ma'am. We do have a few questions for you. One of them has been asking, saying, how would you visualize the anterior commissure in a difficult case? Is there any specific way or a specific scopy blade or a position you would prefer in such cases, ma'am?
Thank you for the question. So this is not really related just to laser. It's just for a difficult exposure of a patient. And what I like to do in a stepwise fashion is go in first with the size of the scope, which is not too large, which is the largest which can comfortably fit. So if it's a difficult exposure, decrease the size of the scope could be the first thing. The second could be use an anterior commissure scope. And the one which I'm very fond of is the Dido laryngoscope. The third is in every patient, we start, typically the Boyce's position has been described. I use neutral position, but you can go to a Boyce's position. And for very difficult exposure, you can even go to a flexion position where the neck and head both are flexed. Of course, we would want to give anterior commissure pressure on the cricothyroid membrane. You can use it with a finger, or you can put a bandage around and tie it to the OT table. So the constant pressure with the general anesthesia also, the relaxation causes a bit of laryngeal drop in about 20 to 30 minutes. Something initially you thought was very difficult, after 20 minutes, you may feel, was it really that difficult? And finally, the scope position should not, you tend in the beginning to go closer to the vocal folds if you think it's difficult to see the anterior commissure. What you need to do is actually withdraw and go to the false vocal fold level so that there's place for the larynx to drop. And lastly, if all of this doesn't work, then you can just take a flexible laryngoscope with a side channel, go through the ML scope and see, or take a 70-degree telescope and flexible tip instruments through the scope and have a look. At least you'd get a biopsy. I hope that answers the question.
Yes, ma'am. Thank you, ma'am. And which is the lesion where you would consider laser an absolute essential, ma'am? There's another question.
Thank you. Like I mentioned, a type 2 onwards transoral laser microlaryngeal cordectomy, the name itself suggests, type 1 can be very effectively done even with cold steel. So yes, type 2 to type 6 cordectomies, I would feel the laser is essential. That is the one condition I feel it's essential.
Yes. And there's another budding surgeon who would like to know usually what would be the cost of these lasers? And is there any specific company or a brand that you would suggest that they would prefer to go by with?
I wouldn't ever want to promote any company, and definitely not on a national forum. Just to give you an idea, I'm not mentioning companies, but basically, I know that the compact system of the True Blue laser, which is the new laser available and made in Europe, we had got it for demo for 2 of our workshops. I think it comes to around 50 lakhs or so, or 50 to 60 lakhs. I may be off, but just to give an idea. But the AccuBlade systems, there are 2-3 companies available, and they are now from 1.2 to 1.6 CR, which is exorbitantly expensive for an individual to purchase. So maybe one should do it as a team of people in an institute where it's not just the laryngologist, but you can use it for stapes surgery, or you can use it for dermal procedures, because the costing is a bit exorbitant.
Okay. Ma'am, and then there's another question by Gauri Kapre, ma'am. She says, she asks, since amyloidosis is a diffuse lesion, how do you plan to find out the extent of the laser ablation part of the surgery, ma'am? How did you plan that?
Yes, very correct question. So one is, of course, one can do a contrast enhanced CT scan prior to the surgery, which gives you some idea as to the depth of penetration, because though it's not a very vascular lesion, there is some amount of enhancement. So you'd get an idea as to what is the extent in terms of the cartilage. But what is, I think, more important is, as I mentioned actually during the surgery, that when you actually palpate the lesion, amyloid is quite firm. So you excise, it's sometimes like a tip of the iceberg. You excise a bit and then you see there's more amyloid, which is firm, and it has a very classical color. It's very yellowish, grayish, yellowish in appearance. So you do have to see it under magnification and use palpation. Those would be the 2 techniques by which you decide when you have come to the normal tissue.
Thank you, ma'am. All the delegates, you can please keep posting a few more questions in the chat box, and the ones which are not answered, all of them will be replied via email to you. Thank you once again, ma'am.
Thank you so much.
A lot of us here have been trained and taught at various points in our careers by this illustrious and exceptional human being, as well as an outstanding doctor. Sir has been and continues to be an inspiration to all of us in the field for decades to come. He has been honored by the Government of India with the Padma Shri Award in 2014 for his contributions in the field of medicine. He was also awarded the prestigious Dr. B.C. Roy Award in 2005 by the President of India. Yes, we have none other than Dr. Milind Kirtane, sir. Sir, we request you to please give your valuable insights about where phonosurgery as a field is headed. Delegates, again, please kindly post your questions in the chat box, which will be addressed as soon as possible.
Advances in laryngology have been in the diagnostic field, surgery, and there have been technological advances as well, especially in the last decade. The advent of the chip-on-tip flexible video stroboscopy system has permitted for a very thin flexible scope, less than 3 millimeters in diameter, to be introduced into the professional voice user. And because the camera chip is on the tip of the scope, one gets a very nice, big, clear picture of the vibrations of the mucosal waves seen in slow motion. So this allows us not only a good look at the vocal folds, but also hidden areas like the anterior commissure, the laryngeal ventricle, and even the infraglottic surface of the vocal fold. The advent in the NBI, that is the narrow band imaging, has permitted us to pick up very early cancer and is also very useful in the post-operative surveillance after cordectomy for cancer. As a matter of fact, it has been advocated by the European Laryngological Society that NBI should be included as a part of the management of post-operative surveillance after podectomy. Basically, in the NBI, the narrowband imaging, what you're doing is using a light where the red part of the spectrum is taken away. You're using only the blue and the green. And this allows a clear visualization of the blood vessels, which pick up the blue light and are reflected back in brown color. So it shows you the pattern of the vasculature on the vocal folds. And there has been a classification advice from type 1 to type 5. And if you are closer to type 5, then you know that you're dealing with a malignancy. Type 4 would be a pre-malignant lesion. And there are very few false positives, except maybe in cases like laryngeal papillomatosis. But this feature has made early pickup of malignancy possible now. High-speed imaging is actually a real-time slow-motion mucosal wave, because we know that stroboscopy is simulated wave and high-speed gives you a real-time slow motion. However, the hard disk capacity requires to be very large to store high-speed imaging of even a few seconds. And that is why it has not come into play in a very big way in routine diagnosis and voice clinics. Optical coherence tomography is a radiological test which would probably be of great importance in not too distant a future, because this is a test by which one can assess the depth of penetration of a lesion, especially between the epithelial surfaces and the lamina propria. OCT is something that has been routinely used in ophthalmology, and it would really be an amazingly useful tool in the preoperative diagnosis of lesions, to decide the depth of invasion of cancer, and to decide, for example, whether a cyst is in the SLP or whether it's a ligamentous cyst. And even intraoperatively, one could do this if one was in difficulty. Lastly, we talk about artificial intelligence, and that's also coming in a big way in our day-to-day life. And it may be possible in future that using artificial intelligence, one can analyze a patient's voice. And by this voice analysis and the use of artificial intelligence, we may be able to make, or at least guess, a diagnosis of the patient even before examining him.
And I was asked to talk a little bit about how I have seen laryngology develop in the last 50 odd years that I have been doing ENT. You know, laryngology as a subspecialty is now firmly established. It's been shown to be a viable subspecialty, and there are a lot of people who are now practicing purely laryngology. But this is not a new concept. Dr. Horace Green from New York, way back in 1832, came back after training in France with Dr. Trousseau and started an exclusive practice of voice and larynx disorders. Remember that, 1832. And this was even before direct laryngoscopy was developed. And he used to try and apply medications to the larynx using flexible whalebone with a little brush or a little cottonoid attached to the tip, and try to apply medication to the larynx, such as silver nitrate. So this concept of laryngology as a viable subspecialty is quite good. Let me tell you that when I was asked to speak on this, I started perusing the literature on history of laryngoscopy, and it is exciting. Going back to the days when Emmanuel Garcia tried to look into his own larynx using pieces of mirror, or people who tried to develop even the use of candlelight and different types of pieces of glass or mirrors to look inside. And from there, we've come a long way. But let me not get into that kind of history here. Let me start off by saying that when I first joined ENT, that was way back in 1969-70, as a junior house surgeon, what is it that I saw? Let's talk about indirect laryngoscopy in the OPT. No flexible, no 70-degree laryngoscope. We had to do it with the laryngeal mirror, holding the patient's tongue out. And it was not uncommon to have difficulty in visualizing, one with the patient gagging away in the OPD, so we had to spray them quite thoroughly. And in spite of that, quite often we found that the anterior part of the vocal cords could not be visualized because of an overhanging epiglottis. And I'm sure many of you are not even aware of this instrument that we used to use. It used to be called an epiglottis tilter. It was a long curved instrument with a little blunt double hook at the tip. And in such patients, after giving them a good spray with xylocaine, we would ask the patient to hold out his tongue. Then with the left hand, we would put the laryngoscopy mirror inside and try to see the larynx as much as we could. And then with the right hand, we would introduce this sort of curved instrument which would go over the base of the tongue. And the blunt double hook would then press on the vallecula on either side of the median glossoepiglottic fold so that the epiglottis sort of would be tilted up and we could have a look at the larynx. Today, I don't see this instrument on any trolley, but that was my first experience of trying aided laryngoscopy, so to say. The second memory is that of our seniors using the Jackson's laryngoscope. It was a brass tube, which was about a little more than a centimeter in diameter. And it had a light carrier with a very tiny electric bulb at the end, which was connected to a transformer. And it would give a very dim light. And holding that with sort of one hand, they would do the laryngoscopy, then peer with one eye through that little small tube, and then use cup forceps to pull out nodules, cysts, or polyps from the vocal cord or take biopsies. And it was quite a feat not to remove anything more than just the lesion, doing that with one eye, one hand suspending the laryngoscope, and a light that sometimes flickered on and off. Things have changed a lot since then. And if you ask me, one of the biggest changes that I have seen is the availability of good light and good optics. The introduction of the fiber optic light source, bright light that was available now to look inside the oral cavity and even at the larynx, at the tip of your instrument, made a tremendous difference. And of course, the introduction of flexible laryngoscopes completely changed the game. So now you were sure that you had the instrumentation necessary to really look properly and study the larynx correctly, rather than struggle in the OPD with those funny gadgets. The other thing that changed was the popularization of suspension laryngoscopy. Of course, this was introduced by Killian way back in 1911. But it was Lynch and then Oscar Kleinsasser who really popularized it in the late 1960s. And the availability of these Kleinsasser laryngoscopes initially, and then a variety of different ones now, with specialized instruments and suspension so that you could use a binocular microscope to get a very clear view of the larynx and then use both hands to operate, really change the game. And today, of course, one would not dream of doing any surgery on the larynx without having a suspension laryngoscope, whether you use a microscope or whether you use an endoscope at the tip of the laryngoscope. So the suspension laryngoscopy and development of special instruments really changed the game. The third thing that I think has made a tremendous difference is better understanding of the physiology of the larynx, of the mucosal wave, the development of things like stroboscope, the NBI light, which allows you a very good look at the vocal cords in slow motion or some mucosal structures and allows you to make an early diagnosis and therefore institute treatment at a much earlier stage. The concept of good voice therapy and the importance of voice therapy voice therapy has also been instrumental in getting much better outcomes after whatever surgery you do. Another big addition to our armamentarium is the introduction of lasers. And today, the lasers have completely changed the quality of surgery that one can offer for benign as well as endolaryngal surgery for malignant lesions. I am going to be talking a little bit about what the future holds. I would just like to say that even with these past changes and where we've come, there are certain things that still offer us a challenge. Things like laryngeal papillomatosis, especially the juvenile laryngeal papillomatosis. I mean, a lot of research has gone into it and so much work has gone into the virology of it that hopefully one day we'll come to a medical cure for this problem. But otherwise, surgically, although we've got sophisticated techniques now to tackle it, the amount of recurrence has not really been adequately taken care of. Similarly, laryngeal reinnervation in paralyzed vocal cords. Again, there is a lot of work going on. A lot of new techniques have been described, but the last word is yet to be said on this. We have managed to reduce the problems of chronic laryngitis, even laryngeal malignancies, with the understanding of what leads to the irritants that could be responsible for these kind of conditions. But we have not been able to eliminate them. So we have made a lot of progress. Much work needs to be done. And there are some exciting prospects available to us, which are already existing or which may come into the near future. And my talk now will relate to some of these recent advances and futuristic ideas.
Thank you, sir, for that wonderful talk. Questions by the delegates will be taken by sir, and he will get back to them at the earliest via email. Sound produced by a person's larynx is voice, and expression of thoughts and feelings by articulating sound is speech. We have Dr. Unnikrishnan Menon, sir, to help us understand why it is voice and not speech. Hello, sir. Delegates, questions posted in the chat box will be taken by sir at the end of the session. Over to you, sir.
Good morning, everybody. So we'll start off with an audio sample. Just please listen to this.
തെങ്ങ് മനുഷ്യർക്ക് സഹായം ചെയ്യുന്ന മരങ്ങളിൽ ഒന്നാണ് തെങ്ങ്. പലതരം തെങ്ങിൻ കായകൾ ഉണ്ട്. ഇവയിൽ ചിലത് നീണ്ടതും ചിലത് ഉരുണ്ടതും ആണ്. ഇവ ഇളപ്പം ആയിരിക്കുമ്പോൾ.
So that was in Malayalam. Sorry about that, but you would have recognized that there's something off with the voice. Or was it voice? Let's see this other audio sample.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 50, 60, 70, 80, 90, 20, January, February, March, April, May, June, July.
So yet again, you would have perceived that there is something wrong with the voice. So here were two examples of something going wrong with that most important human faculty of communication, that is voice and speech. And that's precisely the topic on which I'll be speaking. Why is it voice and not speech? I am Dr. Unnikrishnan, Professor in Amrita School of Medicine,
And I would like to acknowledge my audiology speech therapy department for the audio sample clips. I'm also thrilled, and it's my utmost pleasure to be speaking after my guru and teacher, Kirtane sir. So that's a first for me. So without much ado, moving on to the talk, greetings from Amrita Hospital, Cochin, from where I come. The objectives of my talk are these: a brief description of the basic science of voice and speech production and main modalities of assessment and treatment of the same. And all of these with a view to bring out the distinction between the two entities of voice and speech. So I hope in my given time of 12 to 13 minutes, I'll be able to achieve these objectives. So phonation. This has been designed as the physical act of sound production by means of passive vocal fold interaction with the exhale airstream. So underlined words are important because it represents what actually happens here. So even airflow coming down from the lungs and moving upwards, and something that is pure physics happening at the level of the vocal folds, which creates sound. It's like a transducer effect of the larynx, which creates the sound. And this is where phonation has happened. Okay. And the parameters regulating vocal fold vibration, neuromuscular control, which means the vocal folds have to abduct and adduct. For phonation, they adduct. The respiratory muscles have to give the expiratory force. And then we have the laryngeal muscle, which have to be, that means the vocal fold position, the shape, the size, elasticity, viscosity, all are important for vocal fold vibration. And these are all important then for normal phonation. That means all these factors are needed for normal phonation. And when we say phonation, we mean the voice that is produced at the level of the larynx, the level of the vocal folds. Okay? So any factor that affects any of the above leads to what is medically called dysphonia, hoarseness, or when the patient presents, it's change of voice. But this should not be confused with other things that can also happen with voice and speech. So this phonation process, which as we saw is a mere mechanical process, produces what? Produces the fundamental vibratory sound, which has got a pitch and loudness, that is frequency intensity, but it is not particularly human and is not particularly identifiable. Okay, so any larynx can produce just that sort of sound. This then goes through some processes which adds color to the voice and makes it identifiable, recognizable, and speech. Okay? And that is the next process which we'll be looking at. So speech is the most complex sequential motor task performed by humans. Now, if one slide were to encapsulate the essence of my talk, it would be this slide. It shows like an equation that speech is equal to phonation plus two more words have come in now, resonance plus articulation. That itself tells you that voice or phonation is not equal to speech, because speech is a sum of two more processes happening, which adds on to the phonation and creates speech. So that itself shows, by simple maths logic, we now know that speech is not equal to voice. Resonance. This is the process by which the basic product of phonation. So to remind you again, the basic product of phonation was just the fundamental frequency voice noise that was produced. This is enhanced in timbre and or intensity by the air-filled cavities through which it passes to give resonance. And which are the air-filled cavities? We'll see that. But first, looking from above downwards, the fundamental frequency at the vocal folds changes to first O-tone, second O-tone, third O-tone as it goes through the air cavities of hypopharynx, oropharynx, oral cavity, nose, paranasal cavity. So all of these are air-filled cavities, and all of these then adds, as we saw, the word color to the voice and creates resonance. A good oral nasal balance is important for what we call a good voice. And dysfunction of any of these air cavities leads to a hypo or hypernasality. So patient may say change of voice. The doctor, ENT doctor may perceive a change of voice, but it's not dysphonia now, because there's nothing wrong at the level of the vocal folds. There's something wrong at the level of these air cavities, leading to a faulty resonance, which is not a voice problem. Next is articulation, that magical process which is defined as a configuration of the vocal tract resulting from positioning of the mobile organs of the vocal tract in relation to the not so mobile organs. So we'll see this in the next slide. Yeah. So we have this wonderful thing happening at this level. So we have the lips. The mobile parts will be, of course, the tongue, the soft palate, and the uvula. We also have the lips, the teeth, and the hard palate. All of these, the fascinating interplay happens between all of these. And we have different types of articulation, bilabial, labial, etc., etc. I'm not reading the whole thing. but we know that all of these or some of these are required as per the language of the person. So a whole spectrum of articulation is now created, which is separate from what has happened below. At the level of the glottis, you will see vocal cords right below. That's where phonation happened, then the resonance of the air cavities, and now articulation, which converts this into vowels and consonants. Vowels are the sounds in which there is no obstruction to the flow of air, and consonant in which there is a definite obstruction, but of different patterns, which creates the various words, and then which adds up to human speech and then language. So there's a source filter theory of speech production, which says that speech is a product of passage of acoustic source, which was phonation, generated by the vibrating vocal folds through the filter of the vocal tract. That means the fundamental frequency has now passed through resonance chambers and the articulation tracts to create speech. A little complicated looking diagram, but you will understand if you look below that the lowermost point is the vocal fold. So this entire thing is happening above the vocal fold. So what happens to that fundamental frequency voice, which has now come above the level of the vocal, which is moving up from the vocal fold level, is that we talk of various distances. So distance from the plane of vocal fold to the anterior lips, distance to the plane of vocal fold to the posterior nasal spine, distance to the anterior lips to pharyngeal wall. So there are various distances, and this all consists of movable and fixed components. And the flexibility of changing shape creates the desired resonance and, more importantly, articulation. So any structural functional change in any of these, which means in the lip, in the palate, in the soft palate, hard palate, tongue, anything, would result in disarticulation or unclear speech. The easiest examples which come to mind would be cleft lip palate and hypoglossal tongue paralysis. Okay? So this is unclear speech, which means the phonation is good, nothing wrong with the level of the vocal folds, the resonating chambers are fine, but still there's a problem in speech now, the speech disorder and not a voice disorder. Okay. So when the patient says change of voice, please do not interpret directly as hoarseness dysphonia. It could very well not be dysphonia, it could be a problem with resonance or articulation. And hence, therefore, when we say management of this problem, voice management is not equal to speech management. So evaluation and therapy would differ for the two. And what are these? Let's see in the coming slides. So yeah, voice and speech are not a product of single area. When something goes wrong, this is an instruction for all of us, laryngologists and our speech pathologists and voice pathologists, that to look at all the parts of this machine, starting from lungs to the lips, and see what goes wrong where and what can be corrected. So investigations. So voice evaluation, what do? First things first, take a detailed history, because here itself is the first clue. If a patient is a voice user, that tells you that this could be a voice problem. Then perception. It's said that the laryngologist's best tool is his or her own ears. Learn to listen to the voice. That itself gives you a clue whether it is a voice problem or a resonance or a speech problem. And then something that I've put in red, which I consider is very important, maximum phonation duration. If done properly, it gives very good and important information about the status of the lungs and vocal fold closure, which means that if someone has come with a so-called voice problem, but if the MPD is good, it tells you that there is nothing wrong at the level of lungs and vocal fold closure. And therefore, this may not be dysphonia, but the other one of the other two. Then, of course, as ENT doctors, we do our most familiar and routine thing, that is the laryngeal examination. We have the whole spectrum, indirect laryngoscopy, laryngoscopy, stroboscopy, whatever is needed as per the case may be. And for completion's sake, there is pulmonary function test for the lung capacity, and the voice handicap index questionnaire can be used. So this is another audio. Let's listen to this.
Types of drug action. Stimulation. Some drugs act by increasing the activity of specific organ systems. Example, adrenaline stimulates the heart, resulting in an increase in heart rate and force of contraction. Depression. Some drugs act by decreasing the activity of specific organ systems. Example, alcohol, barbiturates, general anesthetics, etc.
Okay, so what you heard was a passage from a pharmacology textbook page. This was because this voice is of the son. You heard it correctly, son, S-O-N, son of a pharmacology professor. So when I say it so clearly, you would recognize the diagnosis. It's a case of pubophonia. Male who's speaking in this is pubophonia. So when you hear it and you see the patient, you know that's a voice problem, pubophonia. Then the patient moves on to audiology department. So I do not have personal exposure to these modalities. Voice recording is done where the voice pathologist prefers a normal conversation because it gives spontaneous speech. Then there's perceptual and objective software evaluation. We in Amrita have doctor speech, but there is also Wagmi and Pratt, each with its own advantages and disadvantages. So these can be are used for the voice evaluation. Now, what if the speech is the problem? That means the person has come with a so-called change in voice, but the ENT doctor tells that I've looked at the larynx, vocal folds are fine, the MPD is fine, all the other parameters which we just saw are all fine, but still there is a problem. So that means it's a speech evaluation needed. And here there's an entire spectrum available. It begins with oral peripheral mechanism examination. Then there is speech sample recording, which contains of both spontaneous speech and reading samples. For illiterate people or children, there is a picture description task. And then these are transcribed and analysis of the sample using certain given parameters. And then the perceptual and instrumental method. Now this is a whole couple of busy slides coming up. We don't need to focus on all these things, but the idea that I want to convey is that there can be so many types of speech disorders, and accordingly the speech pathologist would apply the evaluating modality. So it could be articulatory or phonologic disorders, it could be neurogenic speech disorders, it could be fluency disorders, it could be resonance disorders, it could be prosodic problems. So accordingly, this would be picked up by the modality used, which would then tell the speech pathologist that this is not a voice problem, but a speech problem, and therefore needs speech therapy and not voice therapy. So what are the treatment options? Well, laryngologist, ENT surgeon, we know some benign vocal fold pathology or something else on the vocal folds. Some of those cases would need surgery. That would be phonosurgery or directly on the vocal folds, microphonosurgery. But many others would need therapy. Now again, to come to the same point, that not to confuse the two terms, voice therapy is not the same as speech therapy. Why? Now by now you would have realized why. Some problem with the vocal folds, at the level of the vocal folds causing dysphonia, needs voice therapy. Problems with the resonating chambers or the articulators would need speech therapy. And these would have or should have been picked up by the laryngologist, the ENT surgeon, doctor, and the voice speech pathologist. Okay. Voice therapy, again, these lists are not exhaustive, but just to give few examples. So one would be correction of hypofunctioning. The best example would be the voice abuse spectrum, muscle tension dysphonia, nodules, etc. Then correction of the adduction problem, which means all cases resulting in phonatory gap. Best examples being a unilateral vocal fold palsy and a sulcus. And I've included pivophonia correction because I already showed you a case of, heard a case of pivophonia. And this is the same son of pharmacology professor after
January, February, March, April, May, June.
Yeah, so voice is still not perfect, but the pivophonia, that pitch correction has happened. So a successful voice therapy example. But now if it is a problem with the resonating chambers, as in best example, cleft palate, or some articulatory problems, cerebral palsy children being the example here, then different modalities are needed. That's blowing, sucking is one, strengthening articulatory muscles. Of course, as I said, this is not an exhaustive list by any means because an entire spectrum of corrective modalities are available, but these would all be speech therapy. So once again, this is different from voice therapy. Voice therapy is when there is a change in voice, there is MPD is reduced, you've examined the larynx and this problem at the level of the vocal folds, and so the voice evaluation is done, which tells that there is a problem with the voice, and the voice pathologist, either the ENT surgeon or the voice pathologist does something to correct it, and that would be voice therapy. That is voice problem, voice correction. But no, those are all perfectly fine. That means there is some problem with the resonating chambers. It could be as simple as rhinosinusitis, or there is a cleft palate. Incidentally, the first two slides which we heard, the first slide, the two audios which we heard was a cleft lip and a sulcus vocalis. So sulcus vocalis was a voice problem, cleft lip was a speech problem. Then the correction will be accordingly. So this was the focus of my talk, that the difference between voice and speech and the evaluation and treatment modalities thereof. I hope I've met my objectives, and thank you all for a patient listening.
Thank you for that wonderful talk, sir. We have a question for you from one of the delegates. Sir, for puberphonia, you did mention that voice therapy is the primary modality of treatment. Can you tell us a bit about exactly what is done during the voice therapy sessions or exercises that are done for puberphonia?
Sorry, could you just...
Yes, sir. Sir, for puberphonia, sir, so the voice therapy that is done in cases of puberphonia, can you just explain about what?
To be frank, I would not go into the details of that because that is by the voice pathologist, speech pathologist. So they have the techniques which should be done in, at least in Amrita, we have a totally separate unit. Of course, the concerned person would come to see the stroboscopy, and then we take the decision. The person is then sent to the voice pathology department, and they have their modality. And I'm sure the selfie talks, this hopefully would be aspect would be covered. So yeah, so my focus of the talk was basically to make out the difference between voice, because generally we tend to put the two together. We tend to put voice and speech together. So the whole idea of the talk was to know that there is a difference. Some things are genuinely dysphonia, voice problem. Some things are not a dysphonia, rather than speech problem. And so accordingly, to have the difference and not write speech therapy for everyone.
Thank you, sir.
Thank you, sir. Next, we would like to have Dr. Anjana Shivamani ma'am to simplify the complex sequential activation of the oropharyngolaryngeal musculature to help reach the food to one's stomach without aspiration. Ma'am, we welcome you to this platform and are eager to hear about your inputs on the subject. Over to you, ma'am.
Good morning and welcome to the talk on an ENT surgeon's perspective on swallowing problems. First of all, I would like to thank my mentor, Dr. Jaykumar R. Menon, and organizing committee PHONOCON 2022 for this wonderful opportunity. Pre-COVID time, good olden times, picture taken during PHONOCON. And I currently work as a registrar in Queen's Hospital, East of England, Romford, UK. We have started joint clinics to help voice and swallow patients. This is a Japanese maple tree. You can see that laryngology has three major subdivisions, airway, voice, and swallowing, and it tends to stand as a distinct specialty from the rest of ENT. Swallowing advances are remarkable in the past few decades. You can see the picture of 6 blind men trying to decipher an elephant. By feeling it, they seem quite lost, and it can be as frustrating as beginners when we're trying to understand a dysphagia patient, but with the time and effort, things will fall into place. So whom to suspect a swallowing problem, how to go about with history taking, clinical examination, and carry out functional swallow assessment, and whom to refer for further evaluation. That is all going to be covered in this talk. And we know that anything that alters the neurology, be it central, peripheral, acute, chronic, diffuse, or focal, anything altering the anatomy, mainly tumor, trauma, or surgical treatment. Other forms of treatment, chemotherapy, radiotherapy for cancers can also affect swallowing. Substance abuse like alcohol, medication, non-cancer chemotherapy medication like amitriptyline. Significant pain, as in tonsillitis, can disrupt swallowing, and not to forget the subset of patients with tracheostomy. So quickly running through the examples. Neurological insults can be acute or chronic, focal or diffuse. So bulbar palsy, cerebral palsy, CVAs, different types of strokes, traumatic concussion, all can contribute to dysphagia. Strokes involving the cortex can cause swallow apraxia. Strokes involving the brainstem cause pharyngeal dysphagia. Strokes involving the cerebellum can cause a lot of incoordination. Cervical spine fracture. That is a picture showing the structures of the roots of the nerves supplying the muscles of mastication emerging from the between the cervical spine. This is a patient with motor neuron disease. That is going to be the end. So patient will rapidly deteriorate, need peg feeds or nasopharyngeal, gastric tube feeds, tracheostomies, supports. Parkinson disease, can affect all the stages of swallow. Patient with tremors and other features as described. Myasthenia gravis can cause intermittent dysphagia. Foramen magnum decompression, Arnold Chiari malformation. Acoustic neuroma requiring posterior fossa, middle fossa surgery, causing retraction of the brain, affecting the nerves. Glomus jugulare, relation of the structures, lower cranial nerves to the tumor. Anterior cervical spine surgery, this can all impair the swallowing mechanism. Tongue resections, so it can be hemiglossectomy, subtotal or total glossectomy. We need to keep in mind that posterior of the resection, the more impact on the swallow. Chemotherapy, radiotherapies, varying severity of mucositis sometimes can result in osteoretinecrosis of the mandible that can also cause significant disruption of swallow. This is the famous Andy gum deformity. We have all heard about it, seen patients. Patient without mandible, higher mandibular excursion is going to be impaired and patient will have severe dysphagia. So tracheostomy and swallowing, couple of things. Tracheostomy, immediate postoperative period, patient can have a lot of pain. Tracheostomy tube is going to nail the skin to the trachea, impairing the upward movement of the larynx, which is very vital to safeguard the larynx. The larynx goes tucks in under the tongue for its safety mechanism. That is going to be impaired. And cuff tubes can pose additional mechanical impact on the swallowing. Now, this is a questionnaire, EAT-10 questionnaire. A patient is given a set of 10 questions. You can score it from 0 to 4 depending on the severity of the problem. Score more than 3 on 40 will require further dysphagia assessment. This is the questionnaire which not only highlights the physical disability but also the social disability patient is going to suffer. Coming to history taking. So patients say, I have got difficulty in swallowing. It can mean any of the above or all of the above. So spillage, it can be anterior spillage dribbling from the angle of the mouth or posterior spillage into the larynx, penetration aspiration. It can cause significant delays. So patients with masticatory problems, oral phase, delayed oral phase can have frustrating meal times. Obstruction, very typical in cricopharyngeal spasm or strictures involving the esophagus. Patient with misdirection at the level of the pharynx, it can be nasopharyngeal regurgitation or it can be misdirection into the larynx. Patients can also present with complications, repeated chest infections, and then you evaluate, you find our patient has got a dysphagia. So good history helps not only in establishing provisional diagnosis, it also gives us a clue on the prognosis of the patient and prioritizing the patients and how to plan the treatment. So patients with strokes, they have had the worst insult. Things will slowly improve. Chronic progressive diseases like motor neuron disease, multiple sclerosis, patient is going to have a rapid downward course. So you try and rehabilitate the patient and keep the intervention to the end, because if you give the patient PEG feeds in the first place, you might be difficult to wean off the PEG. History taking, salient features to be covered. So whether it is sudden in onset or gradual in onset or it is intermittent, whether the patient has dysphagia of solid versus liquids, whether it's having others associated symptoms like cough, any voice change, breathing difficulty or slurring. So you can see a couple of people jumping off the cliff. Similarly, dysphagia can be all of a sudden. Patients say, I woke up with dysphagia, I was fine till the previous night. Yeah. And sometimes it can be very, very gradual, like a skiing person on the slope. So slowly deteriorating course, or it can be intermittent. So intermittent, generally neurological conditions have like fatigue involving the muscles or the MND, myositis and conditions like that. Liquids, dysphagia for liquids generally indicate neurological problem. Dysphagia for solids indicate structural problem. Complications of dysphagia, most common we have said, is chest infection. Other events can be bronchospasm, airway obstruction in the acute events, or dehydration. Severe form of weight loss is called sarcopenia. Not to forget the social impact, embarrassment due to delay, cough, and regurgitation. So cough, if the patient does not cough, it is good, but not all the people who don't cough are healthy. Some people could be silently aspirating. If there is cough, we need to time the cough, whether it is immediate or delayed. Immediate is indicative of primary aspiration, delayed is indicative of secondary aspiration. And comorbidities, diabetes, alcoholism, smoking, connective tissue disorders can impair the treatment. So it is good to know during the history taking. Coming to clinical examination, we are going to focus on the structures, mainly oral cavity, oropharynx, neck, cranial nerves, not to forget the respiratory system examination. Oral cavity, we're going to look for lip seal and if anything is impairing mouth opening, it's called trismus. So here's a patient with lip commissure resection, going to have dysphagia. You can see the picture on the right shows floor of the mouth reconstruction with flap, taking up a lot of space. So the first flap result is good. Tongue resection with flap reconstruction, it is near normal. The picture on the second, you can see that it's got a very bulky and floppy and probably a useless reconstruction. Oral cavity, you look for the health of the mucosa. Chemotherapy, radiotherapy can have mucositis. We have seen that. Patient can have reduced salivation, delayed complication of radiotherapy. So xerostomia, dry mouth, impairing mastication, can have dental issues secondary to mucositis or due to removal of teeth. Oropharynx, you mainly look for tongue, palate, and look for any processes. So palatal palsy, the picture on the right shows palatal palsy on the right, indicating deviation of uvula to the left. This is the video showing nasal regurgitation. That is massive nasal regurgitation. This lady has got a hypernasal speech and poor lip seal. Listen to her speech. That is very typical of motor neuron disease. And this is another feature of motor neuron disease. Look for tongue fasciculation. Ask the patient to open the mouth and stick out the tongue. You can see that the tongue is moving at rest. So you also check for the tongue movements. Stick out the tongue, push the cheek up and down. So this patient has got left-sided weakness. The tongue is deviated to the left. Mobility of the neck is very, very important. This patient has got a woody neck, probably a result of chemotherapy, radiotherapy, and surgery, all the three of them together. We need to look for hyolaryngeal excursion. It's a very simple clinical test. Put the fingers in front of the neck of the patient, ask the patient to swallow. You can feel the larynx moving under your finger. Cranial nerve examination, we are all very familiar with it. We know that cranial nerve 5 and 7 are very, very important for elevation of the hyoid bone, which is the most important step in swallowing. Cranial nerve 9 is mainly to do with gag reflex and sensation in the posterior tongue. And sensation and motor innervation to the larynx is through vagus nerve. Vocal cord movement can be assessed using flexible nasal endoscopic examination. Cranial nerve 11, pharynx, and cranial nerve 12 mainly for the tongue. It's a purely motor nerve. So you can see varying degrees of vocal cord palsy. Respiratory system examination is very important. So ambulatory patients, you need to watch for basal crepitations, and bedridden patients, apical crepitations. Coming to the most important topic, bedside swallow or clinical swallow examination. So this is mainly done to see if a patient needs instrumental evaluation and to assess the urgency. So here we are not going to have a look in the patient's pharynx, but we feed the patient and see for the strategies and see for any special adaptation of swallowing. And we also look for different consistencies. So if the patient says that he generally has problem with solids, we tend to avoid solid or keep solid towards the end of the exam to avoid the stressing the patient. It also helps us in forming a treatment plan. Ideally, the treatment plan should incorporate all the 3 different types of treatment: direct, indirect, and interventional treatment. But we might find that some patients might be better off with one particular kind of treatment. So it's a good practice to auscultate the neck. Any high-pitched swallow or multiple swallow can be picked up, and this is indicative of dysphagia. The 3-minute test, administer 5 ml, 10 ml, or 15 ml of water, and observe the patient for 1 minute each with the help of a pulse oximeter. If the oxygen saturations are dropping less than 90, then probably we need to keep an eye on the patient. So we get 3 categories of patients. Category 1, normal swallow, no aspiration. So no discomfort, no cough, no desaturation. So they are safe patients. Category 2, doubtful aspiration. Not all swallows are same. In category 3, there are sure signs of aspiration. Patient coughs, vomits, and has a period of breathlessness. So these patients might require alternate methods of feeding and further instrumental assessment. So commonest is nasogastric tube, and you might have seen patients with that. And long-term patients might require PEG, and very ill patients might require total parenteral nutrition. So take-home messages: good history, use E10 questionnaire for beginners, focus on oropharyngeal, cranial nerve, respiratory system, examination and neck examination, preliminary swallow exam, categorize the patients. Hope that was useful. Thank you.
Thank you, ma'am, for such an informative session. Delegates, I request you to please post questions in the chat box. All the questions will be addressed by respective faculties via email, and all of them will be posted to you as soon as possible. Thank you.
Up next, we have an interesting and practical talk by Dr. Gautam Kulamarwa sir on setting up an airway clinic in Tier 2 and 3 cities. This talk is sure to help all the budding laryngologists out there in establishing a successful practice. Over to you, sir.
Good morning, everybody. Respected teachers, my dear colleagues and friends, welcome to PHONOCON 2022 online edition. At the outset, I would like to thank the organizers for giving me this opportunity to share some of my thoughts and views regarding setting up of an airway clinic in a Tier 2 or a Tier 3 city. I'm going to focus more upon the pediatric airway side of things, though it's going to be equally relevant for even for the adult side as well. And also I'll be touching upon a little bit about setting up an airway services and not just an airway clinic towards the end of the presentation. And why this topic? Because we are witnessing nearly 67,000 live births in our country. And if we take up the most common of the pathologies seen in the pediatric area, the laryngomalacia, that translates into approximately 20 children are being born in our country with laryngomalacia. And I'm not sure whether all of them are getting the care they need across the country at this present moment. And majority of these children, they are fit and well born, otherwise just with one small deformity inside within their larynx. And therefore, if we are able to correct them, they're going to be a very productive part of the population and the future generation as well. Just look at this child, for example. This child came to me at the age of about 8 months, and this is how the child was. Child was focusing purely on breathing and nothing else in his life. And when I saw inside, this is what I was seeing, and the child was actually sucking his own epiglottis rather than the air which each passing breath. Therefore, he could not get any air to survive. And see, just a very tiny procedure which almost looks very inadequate at this present moment. And as they say, the proof of the pudding is in eating it, isn't it? So this is the same child. This is the same child 2 months post-operative. You can even see the teeth, those are erupted at the age of 10 months of age. And that's how much of a difference we are able to make for these children or any other patient who is presenting with the airway if we are able to manage it well. Why do we choose this Tier 2 and Tier 3 city? It's mainly because if we look at the population distribution, nearly about 75% of our population is distributed in the drainage areas of this city, and therefore we'll be able to make a difference in care for these people who are residing in these cities. Also, the Tier 2 cities and Tier 3 cities, they have a reasonable post-operative and ICU care available already for various reasons as well. The cost of care can be minimized. They can be closer to their community. Disruptions to their income can be minimized because since they're very close to the hospital as well as a working environment as well. And many of them require prolonged follow-up, and therefore it's far easier for them to come over for the follow-up as well. We don't tend to lose them on the follow-up. And if you are looking at setting up, what are the most basic requirements? Obviously, we need the personnel. If you can see in this slide, I have emphasized more upon the good than the person itself, because it is very important person who is actually coming on board into this team of airway management should be focused as well as dedicated to the care of these airway related problems as such. Need a good intensivist, pediatrician, and pediatric anesthetists and radiologists and so many other people as well along with this. And when it comes to the equipment side, what would we like to have ideally? The most basic equipment, I would even dare to say that, because this one equipment has probably changed the face of the airway management itself, because that's the only thing which can give us a dynamic assessment of the airway. And that's what we are actually looking into. And if you look at the children who present us, majority of the children present like this referred over by a pediatrician who would say, please diagnose this and let us know what is going on inside, and expecting us to do an indirect laryngoscopy examination. Obviously, we are unable to do that, isn't it? We need to have a proper setup for evaluating this airway in place if we need to accept these kind of referrals in our system. And many things can be done in any part of the country or the world, because we don't need any rocket science or any other specialized equipment just to look at the positional variation, for example, because this child, you can see, had a bilateral phrenic nerve palsy following an extensive dissection of the mediastinum for a large lymphangioma which the child was born with. You can see how much of the child, how much of the distress is relieved just by elevating the head end of the bed for this child. Similarly, there are other things which we can easily pick up from the external examination itself. For example, the micrognathia, the excavation or scooping of the chest wall, and we can expect a glossoptosis in this Treacher-Collins syndromic child. What investigation do we need? It's airway endoscopy is the gold standard. And apart from that, we need some help from the radiologist side as well. Bear in mind, it's not just a routine radiology, because even the MRI room needs to be equipped to handle these kind of children, because there need to be an MRI safe anesthesia trolley inside the MRI room itself, or the CT scan room itself, for us to take a child for this evaluation. Therefore, we need to keep all these things in mind as well before we think of setting up. And what is the gold standard, as I said, is the airway endoscopy, and this is what is required. We just need a flexible endoscope and a couple of rigid endoscopes. And of course, I always keep a tracheostomy trolley ready, just in case, and touch wood, until today, I didn't have to use it in an emergency setting in an airway endoscopy child. I start the evaluation with an external video recording. Look at the child, how he is while at rest and while crying, so that we know as in what's actually something we need to anticipate inside the airway. Then I hand over the child to the anesthetist, where he's going to carefully and gently restrain the child. I'm going to go ahead with the dynamic assessment of the airway with a flexible endoscope, with the child being monitored and being safe, and we are just observing the dynamics which will be lost the moment we give a relaxant. Once this is done, I will hand over the child entirely to the anesthetist, who will see whether he can bag and mask the child without having a need for intubation, just to make sure that in case of an emergency, he is able to bail out himself as well as the child. Once he's sure that it can be done, then he hands over the child back to me. Look at the cooperation, how closely we need to interact with the anesthetist. With the anesthetist holding the laryngoscope, I pass the rigid endoscope and see what is going on inside. And with the right hand, I am using it, displaying in the arytenoids, interarytenoid area, just to evaluate that area to see for any cleft anomalies. All these things can only be done with a very close cooperation and understanding between the two professionals who are involved. We can even do bedside endoscopies in the ICUs. It's the same procedure, but of course it is done in an intensive care setting where all the facilities for an intubation just in case is available and ready. And of course, I don't go beyond the glottis if it is in ICU care setting alone. And once the evaluation is done, we should be recording all this data into a proforma, right, starting from the history to the examination to the airway endoscopy findings, so that we are able to audit our own reports, we are able to compare our notes, and we are able to discuss and learn from other colleagues' experience as well. And how do we choose which child goes into an outpatient endoscopy or which child needs an endoscopy in the theater? I generally carefully select these patients for an outpatient endoscopy, and I restrict myself to doing an endoscopy at the, and stop it at the level of glottis and above. Better to have some minimum basic resuscitation equipments ready, even in the outpatients, if you're handling these kind of small children, because even a small laryngospasm is enough to unsettle us as well as the parents who are actually onlooking these endoscopies at that time in the outpatients. When there is a need to go beyond the glottis, when there is a need to obtune the reflexes, when there is a need to palpate, apart from inspecting, to look into the hidden areas. Also, if the child is not cooperative, these are the indications where I take them into the operating room to do the airway endoscopy. When we set up an airway services, again, we can take our baby steps by starting the services for all the pathologies above the glottis, which can fairly be safely handled. The below the glottis, if we need to go, we need to have enough and robust experience with the entire team to dealing with the problems which are above the glottis. Foreign body services are a must right from the word go, because these are the things they can present in extremities. We won't be able to refer them over either. So this is what is required if you are setting up an airway services, because we need an entirely dedicated team of the pediatricians, the pediatric intensivists, the postgraduate students, and who are actually the workforce basic backbone of the entire service, as well as the nursing care team. You can see this centered to all these things is the patient himself and herself, and whom we are actually trying to help. And the services should be available 24/7, because otherwise we can't shut the shop at 9 in the evening and say, sorry, you need to come next morning. That is not possible in an airway services. We need to have a dedicated round-the-clock pediatric intensivist and the neonatal intensivist as well. There has to be a good auxiliary team with the swallowing therapy, the physiotherapy, the thoracic and vascular surgeons, the pediatric surgeons, neurologists, geneticists, counselors for the parents as well, all included in the setting of this airway services. And finally, what if we are unable to put in together all these people in one setup? Then probably what we can look at is that we can diagnose the child safely, we can stabilize the child or the adult, and then we can refer over to the tertiary or quaternary centers, as the case may be. And if we are really confident and having already a robust airway service established, what next? We can actually even think of setting up an exit program as well, which is the extracorporeal intrauterine therapy for the airways, because which is coming into the fore. And even there are a couple of centers in the entire country where it is already being done. For example, in Bangalore, the Manipal Hospital has actually started this program already. Finally, a word about tracheostomy, because the tracheostomy in a neonatal infant can be huge morbidity. Even when we try to teach the parents, many of them are scared to take this child with a tracheostomy out of even the ICU, forget about taking home, because some of them are confident within a week or 10 days they are able to go home and take care of the child, but not all of them are. Therefore, if possible, we should avoid the tracheostomy to the extent possible. And before I end my talk, I would like to thank two of my mentors in this field who actually helped me take the baby steps in this field. Dr. Jayakumar Menon, we all know, and so is Dr. Kishore Sandhu, again, we all know. And Dr. Kishore Sandhu was actually my mentor and my teacher, even during my postgraduate days. And we settled in Lausanne, conducting a dedicated airway clinic to the world, I would say. Finally, this is always my last slide in many of my presentations. Many of you would have seen this, simply because this is the kind of difference we are able to make for this child. is it not rewarding for us to see such a happy and smiling child at the end of 3 months? And from where the child was focusing only on breathing to the child which is focusing on the entire surroundings as well. So that's what we're looking at. Thank you for the patient hearing.
Thank you, sir, for that informative session. We have a question for you from one of the delegates, sir. How much would be the approximate investment that budding laryngologists would have to make in setting up an airway clinic in such a tier 2, 3 city?
Sir, you're on mute, sir.
Doctor, your voice is not audible, doctor. You have to connect with your computer audio.
Can you hear me?
Gautam sir, you have to connect with the computer audio.
Dr. Gautam, sir, you're not audible, sir.
Swasini ma'am, we will just call Gautam sir and we'll take him back after this talk. So we can go to the next talk.
Gautam, sir, sorry, but your voice was still not audible. But we will take this answer if you're available after the next session, sir. Thank you, sir. Now coming to the much awaited highlight of the day, we have our distinguished international faculty, Dr. Shigeru Hirano, with us speaking about the anatomical and surgical aspects regarding the superficial lamina propria. Chairing this session, we have Dr. Shankar Marikeri sir and Dr. Nupur Nerurkar ma'am. Delegates are encouraged to leave their doubts in the chat box provided so that they can be addressed at the end of the session. Over to you, sir and ma'am. Thank you.
Martha. Chestano.
Shankar sir, your turn.
Yeah. Can I have the first slide? Yeah, on behalf of the PHONOCON 2022, I welcome Dr. Shigeru Hirano, Japan. And at the outset, I would like to thank the organizers of PHONOCON 2022 for asking me to chair this very prestigious oration. So it is my great pleasure to introduce Dr. Shigeru Hirano from Japan, Kyoto University. Dr. Shigeru Hirano has received his MD from Kyoto University in 1990 and began his residency at Kyoto University Hospital. Following his residency, he became a clinical staff at Tenri Hospital until 1994 and attended the Graduate School of Medicine at Kyoto University once again to receive his PhD with a focus on otolaryngology and head and neck surgery. In 1998, he began his career as an assistant professor in Kyoto University, while also contributing in research as a research fellow in the University of California and the University of Wisconsin, USA. After his successive role as an assistant professor in 2005, he received the title of the associate professor at the Kyoto University. In 2015, due to his hard work as an associate professor, he became the chairman of the Department of Otolaryngology and Head and Neck Surgery at Kyoto Prefectural University of Medicine. And at presently, he is continuing to chair and head the Department of Otolaryngology and Head and Neck Surgery at Kyoto University of Medicine. Thank you. Over to Nupur to introduce the subject, and then over to Shigeru Hirano. for his talk.
Thank you, sir, Dr. Medicari. I think most phonosurgeons would agree that excising a polyp or a cyst, any lesion from the vocal fold is relatively simple. But to reconstruct a layer in the vocal fold, especially the superficial lamina propria, when there's a scar or there's a sulcus, that is, I think, one of the most challenging situations for a phonosurgeon. Therefore, Professor Shigeru Hirano's talk and his research work, which he's going to share with us, is so clinically relevant to us today, especially where voice is critically important and it matters to people if they have a hoarse voice. So it's going to be very interesting to know what is his experience with the basic fibroblast growth factor, and I've always enjoyed hearing his talk. So we welcome you, Professor Hirano, on behalf of the Association of Phonosurgeons. It's indeed an honor that you have joined us today. So we are going to be hearing your talk, and then hopefully we're going to be interacting with some question and answers. And also I want to mention over here that Professor Hirano is going to be conducting the International Association of Phonosurgeons meeting at Kyoto in October of this year. And I'm very excited about that. And I hope a lot of us manage to reach Kyoto in October. Thank you. And welcome.
Thank you very much, Nipiro and Dr. McCary, for the kind introduction of me. I'm really honored to be here and enjoying the time with you. So I think I have submitted my pre-recorded presentation, and could you run it?
Yes, doctor, it's ready. We'll play.
Hello, everybody. I'd like to talk about understanding and reconstruction of superficial lamina propria, SLP. This is a structure of the larynx which consists of a framework, muscle, and mucosa. This is very composite organs. And mucosa is tiny structure, but this is the center of voice. This is a vocal fold, which is located between the anterior macular flavor and posterior macular flavor. It's about 2 centimeters in length, but this tiny structure is very important for voicing. Vocal fold is kind of string of mucosa, which allows very high speed vibration from 100 hertz or less up to 800 hertz or more. This is a high speed digital imaging of the vocal vibration. This is dynamic 3-dimensional vibration. There's no mucosa that can vibrate like this in other organs. This function is supported by the sophisticated layer structure of the human vocal fold. This is the coronal section of the vocal fold of the human, and most of the part is occupied by the TA muscle, and then we have very thin mucosa on it. But this mucosa has a layer structure which consists of a superficial layer of lamina propria, SLP, and intermediate and deep layers forms the vocal ligament. Vocal ligament is only seen in the human vocal fold. There's no vocal ligament in the mammals. And cover consists of epithelium and SLP. This is the portion of the vibration. And body is a TA muscle which provide a firm scaffold on which the cover vibrates. So this layer structure is very important. The function of the vocal ligament is thought to be tension control or pitch control, and there's no vocal ligament except the human, and no vocal ligament even in children of human. This is created during puberty. If you damage the vocal ligament during the surgery, it causes severe scar postoperatively, and that's a big problem. This is canine vocal fold. There is no vocal ligament, no layer structure. This is very specific in the human vocal folds. Now we need to understand the superstructure of the SLP. This is basement membrane film which connect the epithelium and the SLP. So this is a very important portion to create the cover. And collagen type 4 and collagen type 7 are really important to maintain the structure. Type 3 collagen exists in the SLP. This is slender fiber and it maintains architecture of the SLP and never hamper the vibration of the SLP. There are collagen network in the vocal fold, but SLP contains collagen 4, 7, and 3. This is important portion. And collagen type 1 forms a vocal ligament. So if you know this, we need to avoid the damage to the basement membrane as well as SLP, and we have to preserve this structure as much as possible when we perform phonomicrosurgery. Hyaluronic acid is another very important molecule, which is mucopolysaccharide proteoglycan. This is the key molecule for vocal fold tissue properly and maintaining the ideal vibration of the vocal mucosa. Microvasculature is also important. This runs parallel to the vocal fold axis, and the microvasculature and the SLP is thin. This is reasonable, not to hamper, not to disturb the vocal fold vibration in the SLP. Cells in the lamina propria, most of them is a fibroblast. And fibroblasts mostly exist in the anterior macular flavor and posterior macular flavor, and a little bit in the membranous portion of the vocal fold mucosa. This is the main provider of every extracellular matrix, including collagen or hyaluronic acid and everything. So this function is very important to maintain the vocal fold mucosa as a vibratory properly. There are different types of fibroblasts in the vocal fold in terms of the morphology, such as oval shape, spindle shape, and stellate shape. So SLP is a critical area for vibration of the vocal fold. It has sophisticated microstructure, including basement membranes, collagen 3, hyaluronic acid, microvasculature, and fibroblasts is very important to maintain SLP. Now, based on this knowledge, we need to consider about the disruption of the SLP, which can be caused by scar or sulcus, or even with atrophy in aged people. This is atrophy. Glottal gap, reduction of the mucosal vibration. Hoarse voice, some hoarse voice. This is a scar. The vocal fold is very stiff and vibration is very limited, and the voice is very bad. So scar is the most problematic dysphonia. And there are a difference between three diseases: atrophy, scar, and sulcus. And in atrophy, epithelium is nearly normal, but the SLP is atrophied more or less with fibrosis. TA muscle is also atrophied. In scar, epithelium is nearly normal or some kind of thickness, but SLP is contracted with fibrosis, and TA is basically normal. Sulcus cases, epithelium is altered with thin and tense mucosa, thin and tense epithelium, and it is reported that the epithelium of the sulcus often contains hyperkeratosis or dysplasia. This is a problematic thing. SLP also disappeared. TA muscle is normal. The common portion of the pathology is the SOP. So the main concept of the treatment is concentrated on the SOP. This is the histology of the age atrophy. This is not human. This is rat. It's very difficult to obtain the age atrophy vocal fold of a human. But in the case of rat, with ages, collagen accumulate more and more, and the hyaluronic acid is decreased with age. Vocal fold scar occurs following injury, inflammation, or even after phonomicrosurgery. We have to be very careful and disrupts the layer structure of the lamina propria, increased tissue stiffness, and severe dysphonia occur. There's no optimal treatment right now. There was a very shocking news that Billy Andrews lost her singing voice after a voice operation around 2000. Because of the vocal fold scar after the phonomicrosurgery for the polyp. This is a histology of a human sulcus or scar. And in sulcus, the histology is very weird. The SOP is gone at the sulcus, and then the epithelium of the sulcus directly attached to the vocal ligament, and the vibrations stop at this portion. This is human vocal fold scar. The layer structure is gone, and the whole lamina propria is occupied by a bunch of collagen fibers, and hyaluronic acid is gone. We have to address this histological alteration to treat these pathologies. Indeed, we have developed many surgical treatments for reconstruction of SOP for vocal fold scar, including excision of sulcus or scar, fat implant into the superficial portion of the lamina propria, slicing technique, fascia implant. But the results are not consistent, and nowadays tissue engineering or regenerative surgery has been received widespread attention because we have to regenerate the SOP. Back to the 1990s, this is a resection or dissection technique of sulcus or scar developed by Dr. Boucher. This surgery just removed the tissues of the scars or sulcus and then put a fibrin glue on it. This case is a 42 years female with moderate scar. Moderate was severe. Very few vibration. In this case, we performed dissection surgery for the scar. So just to make a superficial cordotomy and then dissect the scar tissues beneath the epithelium little by little. And after the thorough dissection, the surgery is over. That's it. This is a very simple surgery. And 3 months post-op, the vibration is a little bit better, but still limited. But we can expect some good outcomes even with the surgery for some cases, but not for others. Slicing technique is a very unique technique. Make a superficial cordotomy first, and then make a vertical incision for some portions. This was developed by Dr. Pontes in Brazil for sulcus. This is very severe scar cases. We have done several surgeries, but there was no improvement. And then we tried slicing technique, superficial cordotomy first, and then dissect the scar tissues as much as possible, but scar tissue is so terrible. And finally, we made a vertical incision like this. Oh, sorry. In fact, this surgery didn't work for this case. Now, tissue engineering approach consists of three important elements: cells, scaffolds, and regulation. To tell the truth, cell therapy is the most effective tool, but still has some difficulties. Scaffolding is most feasible for the human cases, and we have a lot of experiences about regulatory factors. I'd like to show you the scaffolding first. This is to provide appropriate temporal space for regeneration. So the scar tissue is removed as much as possible, and then scaffold is implanted into the space after the scar tissues, and which provide appropriate environment for cells to grow and work inside the scaffold. This should be biodegradable and biocompatible. There are many materials as the scaffolding materials, such as collagen sponge or collagen gelatin composites, HA derivatives, and bioscaffolds, which is made by decellularization of some tissues. For example, this is athercollagen sheet, pterodermis made in Japan, which has micropore. Many micropore attract the cell influx, and this was developed as a skin regeneration first, and then we applied to the vocal fold first. 72-year male sulcus. This is type 2 sulcus. Bloody gap, force void, limit of the vibration. Scaffolding surgery with pterodermis. Here is the bottom of the sulcus. This epithelium is very thin and tense. So we first made superficial cordotomy and carefully dissect the bottom of the sulcus from the underlying vocal ligament. We have to be very careful not to tear the bottom of the sulcus. Once we tear, we cannot implant anything anymore. Careful dissection, and we finally make a pocket between the epithelium of the bottom of the sulcus and the vocal ligament and implant the materials. We can suture, but we can fix by fibrin glue as well. 6 months post-op. The vibration seems a little bit better. The voice became stronger. So this can work for some patients. And this is the short early summary of our scaffolding surgeries. In some cases shows improvement of the maximum phonatory time, but the others didn't show any change. It's also the case for mean flow rate. So it really depends on the individual. Scaffolding surgery has a regenerative effect, more or less, but outcomes still vary due to individuals. So we need ideal material, but it's not so easy to find it. An additional element is needed for induction of regeneration. In this sense, stem cells has a strong inducer of regeneration of tissues. And cell therapy for vocal scar has been researched using animal models since 2001 or 2003. And nowadays, the mesenchymal stem cells has been most favorable cell sources for the vocal scar. It can be harvested from bone marrow or adipose fat tissues. They are autologous tissues, so there is no concern of rejection. Multipotency of differentiation has been confirmed, and they also produce a lot of growth factors, which has a good inducement of regeneration. This is the first animal experiments performed by Dr. Kanemaru in Japan. This is the first experiment in the world, and they made injury to the canine vocals, and they injected the mesenchymal stem cells from bone marrow, and then they found a good regeneration of the treated site. At this time, they confirmed the differentiation of the implanted mesenchymal stem cells into epithelial cells or muscle cells or mesenchymal cells as well. Another work shows that this is adipose-derived mesenchymal stem cells, which produce a lot of growth factors, including HGF or IGF or whatever else. HGF is a very important growth factor. I'd like to talk to you later. We have done a comparative study of treatment of scalp vocals of rats with adipose-derived or bone marrow-derived mesenchymal stem cells. We injected those stem cells into the scalp vocals of a rat 2 months after the scar, and then check what happens 1 month later or 3 months later. We have found recovery of hyaluronic acid in both treated vocal folds. These are not perfect as compared to the normal hyaluronic acid distribution, but it's much better than sham. And the effect was almost normal between the both cell sources. But this is the gene expression in treated vocal folds, which shows significant upregulation of hyaluronic acid synthase only in adipose-derived cell treatment groups. HGF is more upregulated in the adipose-derived mesenchymal stem cells. So at this portion, so it looks that adipose-derived mesenchymal stem cells has some advantage to the bone marrow-derived mesenchymal stem cells, but it's not clear which is better in terms of the regenerative effects. Now, there are 2 clinical trials using mesenchymal stem cells. This is Swedish trial. They use bone marrow-derived MSC to 60 cases with a vocal scar. The results shows improvement of vibration and PGP in 60% to 70% of the patients. Improvement of VHI was 50%. There was no severe adverse events. Another trial is the French trial. They used adipose-derived mesenchymal stem cells for 8 cases with vocal scar. And improvement of VHI was observed in mostly 90% of the populations. But there are no description of an improvement of the vibration or other parameters of the voice. So the results is still controversial about the mesenchymal stem cell therapy. So I'd like to talk about the effects of growth factor therapy for the vocal scar in terms of the reconstruction of SLP. Growth factor is naturally occurring protein. It stimulates cell growth, proliferation, and differentiation. At the meantime, what is most important is that it regulates cell function, including extracellular matrix production. If we apply the growth factor from outside the body, this exogenous growth factor can jumpstart the healing process, or they can work as a trigger to change phenotype of cells and its function. This is a mechanism on the gene expression of the vocal fold treated by hepatocyte growth factor, which is the HGF, or basic fibroblast growth factor, basic FGF. Here is the summary. Both growth factors significantly upregulated MMP gene expression. This is collagenase, which means they can reduce the collagen deposition. And also, in meantime, they significantly upregulate HAS, which is hyaluronic acid synthase. So if they work correctly, they can reduce the deposition of collagen in the scar tissues, and they can increase hyaluronic acid. This is good for recovery of the COP. We have commercially available drug of basic fibroblast growth factor in Japan since 2001. This is approved by the Japanese FDA for the skin regeneration, and we have confirmed that this stimulates growth of vocal fibroblasts and then increase production of hyaluronic acid from the cells. After several in vitro studies and animal studies, we have set up intracaudal injection of basic FGF for human skull sulcus atrophy patients. The protocol is weekly 4 times injection, 10 microgram for each vocal fold under topical anesthesia. We have just published our experience of 100 cases of intracaudal injection of basic fibroblast growth factor in the laryngoscope. We have 43 cases of atrophy, 41 scars, and 16 sulcus. The mean follow-up was about 1 year. I'd like to show you some results, some cases. This is 77 years female atrophy with age. Okay, this is myoatrophy with slightly reduced vibration with a small glottic gap, but the voice is weak and hoarse. 19 months, her voice became much stronger, much tense. 24 years male, he has myo scar. Okay. Hyperfunctional gesture. Oops. Glottic gap with reduced mucosal vibration. So this is myo scar. 3 months after the injection. The voice became stronger and lower, and the glottic gap is improved, and the vibration is improved. Still a very small gap, but the voice became much better. This female has moderate scar after right vocal folds after phonomicrosurgery for vocal fold cysts in an institution, and 1 year has passed and there is no improvement. Her voice is very bad, hoarse, and right vocal fold has a little vibration with a glottic gap. 6 months after injection, her voice is much better, or almost normal. Vibration is good with complete glottic closure. This is severe scar after left vocal fold cordectomy for leukoplakia. No vibration. Very bad voice. 8 months after injection. The vibration came back and the voice became better. This is sulcus case in 77 years male. Big gap. 6 months after injection. complete glottic closure in the brain. But better vibration. So this is the summary of 43 cases with atrophy, which shows significant improvement of maximum phonotory time, VHI-10 and Gerber's. And this is also the case for 41 cases with the scar, and also the case in 16 cases of sulcus. But important point is that there is still variation depending on the individuals. If we determine the success rates by the rates of improvement of VHI-10 more than 5, which is recommended or suggested by the Pittsburgh group, the success rate of atrophy is good as 80%, but scar and sulcus is a little bit lower, 60%, 70%. And if we classify the scar and by the severity of the scar using University of Wisconsin score of vocal vibration, in which 0 is for normal, 5 for absent vibration, we can classify into mild, moderate, and severe scar. If we use it, the success rate of a mild or moderate scar is very good, as 90%, but severe scar is down to 50%, sulcus 60%. So severe scar and sulcus are still problematic pathologies, even with growth factor therapy. But we achieve a good success of treatment for 50% to 60% of severe scar and sulcus. This seems to be good enough, but we have to improve more. Now, hepatic growth factor, HGF, has the strongest anti-fibrotic activity, and therapeutic effects for fibrotic diseases has been confirmed in animal studies for liver cirrhosis or lung and kidney fibrosis. And also confirmed HGF stimulate hyaluronic acid production from vocal fibroblasts and improve canine vocal scar by local injection of HGF. This is a canine study. The scar, the canine vocal force shows contraction of the lana propria with deposition of collagen, decrease of hyaluronic acid. But after HGF treatment, the contraction is improved with fewer collagen deposition and increase of hyaluronic acid. Based on these experiments of data, we have done clinical trial of HGF for human patients with a vocal scar using GMP-compatible HGF made in Japan. This drug is not approved, but this can be used only for clinical trial. This is phase 1-2 open trial. We had 18 cases with a scar or sulcus, and local injection was done 4 times weekly. We have 3 groups depending on the dose of the growth factor from low dose to high dose, and we use curved needle to directly inject the growth factor to the vocal. This is the results of a mild scar. He is a pop professional singer. He had chronic inflammation after this by the long-term singing. This is pre-treatment status. This is a mild scar. Pitch phonation. He cannot sing in a high pitch. This is problem for the singer. And treatment. VHI-10 was 0. This is a moderate score after bilateral codectomy. Determination is very difficult. 6 months. The happy explanation became available. Severe scar with a sulcus pre-treatment.
で高い声で
6 months post-op, post-injection. There is an improvement, but her voice is still bad. So there is no improvement in the VHA10. Severe scar seems to be still difficult even with this growth factor. This is a summary of 18 cases which show significant improvement of VHA10 and vibratory amplitude on the stroboscopic findings at the time of 6 months after the treatment. Still, HGF has some effects on the VHA10 vibration global scale. There is no dose-dependent difference, but severe scar seems to have less effect, which is still problematic. But anyway, we are now on the phase 3 trial with a multi-center format. We are now preparing for the phase 3 trial. Now, what we can do for severe scar is maybe more aggressive treatment with growth factor or stem cells. And we have set up 2 ways. One is a flap operation with growth factor injection. And another one is the implant of a gelatin sponge together with growth factor. Gelatin can retain the growth factor for a while, so they can work as a drug delivery system, the growth factor, in which the growth factor is released gradually from the gelatin sponge. This is the flap operation with a growth factor injection. Our right side is very mild scar, and left side is the problem. We made superficial cordotomy first and dissect the scar tissue, and then inject the growth factor at this point, and continued the release of the scar as much as possible. This is a case with moderate scar after flap operation with basic UGF injection. The vibration is hampered. And 6 months after the operation, the vibration seems better. But still, this is not perfect there. PHA10 became 32 down to 19. So there are some effects. Implant of a sponge with a growth factor is indicated for severe scar. This is very severe scar, and we have to dissect the scar first, superficial cordotomy first. And the tissue of the scar is very firm, and we need a scalpel, sharp dissection, to dissect the scar little by little. And after sufficient dissection, we have a pocket between the epithelium and the vocal ligament. There's a pocket in the COP, and then implant gelatin sponge and fixed with fiber and glue. This lady underwent very long-term intubation just after the birth, and then the vocal cord was scarred, and she cannot make voice to sound, so she never sound good voice from her birth for 19 years. Very hoarse voice, severely scarred. And 6 months after bilateral surgery of the gelatin sponge, her voice is normal, is almost normal. There's still a very little bit gap but her voice is normal. PHA-10 is now 0. This is another case with severe scar after cordectomy. No vibration in the left vocal cord. 1 year after the operation. The vibration came back. And his voice is not back. This is a little bit early reports in 9 cases after regenerative surgery, which shows significant improvement of MPT, PHA-10, and Gerber's. So we have now several treatment options for scar, and ordinary surgery is still available for mild scar or moderate scar, but it's very tough for severe scar. And if we have growth factors, we can have many options, including injection of growth factors, flap operation with growth factors, or implant of gelatin sponge with growth factors. Now, this is a final slide, which indicates the future direction. Even though we have more improvement with tissue engineering approach with the vocal scar, there still remains problematic patients, especially in the severe scar or sulcus, and the future direction should be drug delivery system or combination therapy by growth factor plus growth factor, or hybrid therapy with a stem cell plus growth factor, or if we have ideal scaffold which contains stem cells and growth factors, it will be the best bet. So, thank you for attention.
Thank you so much, Professor Hirano.
Thank you for attention.
That was indeed a wonderful talk. We do have a few questions for you.
Sure.
The first question is, how much time post-operatively does it take for regeneration of the superficial lamina propria? And what precautions need to be taken other than voice rest?
Mm-hmm. Yes, it depends on the surgery, but if we inject a growth factor, it would take 1 month or 3 months at most. So 3 months is the one limitation of the effects of the growth factor. The growth factor effects reach plateau around 3 months. And in some cases, quick regenerative effects can be observed within 1 month, and some cases takes 3 months. But of course, severe scar doesn't show perfect results with the 3 months post-operative period. And precaution to take rather than voice. Okay. So after the regenerative treatment, we recommend voicing as much as earlier. So we instruct the patient no voice rest after the injection. So they can start voice just after the injection, because the growth factor changes the phenotype of the cells, and they need appropriate environment, appropriate stimulation. So they need to vibrate the vocal, which causes a good regenerative effects. But if they mute, there will be nothing, I think. There's nothing occurs. After the surgery, after the regenerative
That's a very interesting point.
Oh, yes. After the regenerative surgery, the vocal is damaged by the procedure of the operations. So we recommend them 3 days voice rest. That's a usual voice rest after any phonomicrosurgery. But after the 3 days, we recommend them to start voicing.
All right. There is another question. Post-scaffolding of the sulcus, what will be the kind of vocal quality seen usually? And will that improve the underlying hoarseness, which which will usually be seen as a result of sulcus vocalis?
Yes. To tell the truth, sulcus is one of the most difficult cases, as well as a severe scar, because they have 2 points. One is the CLP, and another is the epithelium. Epithelium is also altered histologically. So if we do scaffolding surgery using collagen scaffold or even fascia implant, the results vary. So some cases show a little bit improvement, but the others never show improvement. And because we need more induction of regeneration, scaffolding only has less effects to induce regeneration of the underlying tissues in the SLP. If you see a good results after the scaffolding surgery for sulcus cases, the underlying tissue should be improved to normal or near normal. But it's not consistent in my experience.
Thank you. And another question is, what is the architecture of the collagen fiber of vocal folds in a type 4 glottic web? I don't know if that's something which is...
Type 4 glottic web.
It's not really within the purview of the lecture you took, but do you want to share something in that?
Yeah, I have had some histology from the vocal fold scar, but maybe not. I don't have the histology of the type 4 web, but general concept is that the scar tissue is formed by type 1 collagen. Type 1 collagen is the typical collagen which causes fibrosis.
All right. And I have a question from me now. Just one question. You did show us a patient who was following transoral laser microlaryngeal cordectomy and scar formation. And then there was an injection of basic fibroblast growth factor. So my question really is, in such a patient, if one postulates that there's a little bit of residual malignant tissue, what would happen if one injected the BFGF? I mean, would there be a growth of the tumor cells also then? You know?
Yeah, that's a caution from many people. But basically, growth factor doesn't cause malignant transformation from the normal tissues, unless we apply too much growth factors. So the amount of the growth factor I apply is very minimal dose. It never causes transformation from normal tissues to malignant tissues. And if I apply the growth factor to the malignant tissues, it can cause growth, but it also depends on the dose, because the malignant tumor also produce the growth factor by themselves, the dose of which is much more than the exogenous growth factor we apply. So I don't believe the growth factor causes growth of malignant tumors, and even after the cordectomy for cancer of the vocal fold. So finally, I don't think there is concern about it.
Professor Medicary, would you like to ask the other questions which have come up, sir? We can't hear you, so I think you're on mute.
No, you can continue, I think.
Okay, sir. Sure. There's one question by Dr. Gautam. Are the results long-lasting, or do they recur to follow the growth factor injection? So do you need to keep doing the growth? I mean, you do 4 injections, you mentioned to us, but then do you repeat it the next year?
Yeah, it depends on the pathology. Theoretically, in case of scar, the effects of the growth factor should be permanent because we change the function of the cells. So once the tissue is recovered, there's no cause, how to say, no rationale
No
of
reason.
the recurrent. But in the case of atrophy with age, the vocal function can be improved after the growth factor, but the people get age after that. So it's a balance between aging and the effect of the growth factor. And probably the effects of growth factor maintains for a few years. In some cases, return to me by the re-atrophy with age. But in that case, we can apply another growth factors, and then we can expect some more effects.
Thank you. Another question is, what, in your opinion, regarding the use of regenerative surgery in treating post-radiation scar of the larynx?
Yes, that's the biggest problem because radiation and burn is the enemy of regenerative medicine because they killed whole cells in the organ. So I have had several cases treated by growth factor after radiation, but effect is so limited as compared to the other scars. So, but we can try regenerative surgeries even for the post-radiation scar or post-burn scar, and we expect some effects. But probably my concept is that we need cells in such cases because there are few cells. So we need to implant some cells, and stem cells should be ideal. But it's not still difficult to apply stem cells to the human patients for dysphonia.
Thank you. And I think we have time for a last question, which is, what is the prognosis for recurrent sulcus, which has previously been operated, let's say, by a modified Ponte's? Is there any prophylactic management?
Yes, yeah, that's a good point, because sulcus is a weird pathology, and we don't know why sulcus occurs. They can be congenital and they can be acquired or both. And if they occur congenitally, they can go back to the sulcus even after improvement by every surgeries or every treatment. And indeed, I have some cases we treated by growth factor, and the initial effect seems good. But they return to the original status 1 year later or 2 years later. Probably there is some congenital or genetic cause to sulcus. So it's really difficult to avoid the recurrence of the sulcus so far. And one idea is to repeat some therapy. And I have a couple of cases in which we repeat growth factor injection every 1 year because the patients want, and it seems good to maintain the effects much longer. But there's still difficult to avoid the sulcus again.
Thank you. Well, thank you so much, Professor Hirano, for trying to take us through the latest possible managements in this very challenging condition. And also, before we say bye-bye, I'd like you to mention the dates of your meeting in Kyoto, if you don't mind.
Yeah, yes, you are really welcome, and everybody are welcome to Kyoto.
What are the dates in October? What are the dates which have been set?
October 13 and 14. 13 and 14.
Okay. All right. Professor Medicari, would you like to say anything?
No. Thank you, Professor Hirano, for a wonderful lecture and taking us deep into the superficial lamina propria.
Thank you very much.
Thank
Thank
you.
you.
Thank you.
Thank you, Professor Shigeru Hirano, sir, for taking time off from your very busy schedule to be with us today and impart your words of wisdom. Thank you, Shankar Madkeri, sir, and Nupur Nerurkar, ma'am, also for chairing the session. Thank you, sir. Thank you.
Okay, thank you. Bye.
Up next, we have a talk by the dynamic personality who is sometimes referred to as the Bhishmacharya of laryngology, that is Dr. Jaikumar Menon, sir. Sir will be sharing with us his experience with management of the arytenoids in cases of unilateral vocal fold paralysis. Questions from the delegates will be taken at the end of the session. Over to you, sir.
Good morning, all. I would have loved to see you all in person, but unfortunately, because of the COVID, this time also we are forced to conduct our PHONOCON online. Anyhow, it is important to continue our endeavor in propagating our chosen specialty of laryngology. Today, I am going to talk about the importance of arytenoid in unilateral vocal fold palsy, how to assess it, and how to manage. That's a question what we are going to deal with. The conventional teaching in laryngoscopy has been always with the emphasis on the anterior commissure. The teachers always used to tell us the most important part in the larynx is the anterior commissure. So go till you see the anterior commissure. Naturally, the posterior glottis got relatively neglected. Even though we could see it properly, nobody really gave that much of importance, I say, when compared to the anterior commissure. So everybody was looking more concentratedly on the anterior commissure. So once you saw the anterior commissure, the concept was that we have seen the larynx completely. But with the result that we actually forgot to pay the real attention to the posterior glottis, which it deserved. Because that's very important. Larynx is a very, very dynamic organ. It keeps on adjusting. If there is a pathology, it is not just going to lie down and accept it, but it is trying to correct it. Sometimes the correction may be worse than the original disease, but that doesn't matter. What is important is that the larynx always tried to compensate, and arytenoids always have played a major role. So we are going to look at how the arytenoids do in unilateral vocal fold palsy, and has it got any significance in the management we plan. Now, if you take the posterior glottis, before going to the pathology detail, we will just look at the anatomy and physiology. If you go and look at the posterior glottis, you will see that there are three parts: the arytenoid, the cuneiform, the corniculate. So it's actually a complex, arytenoid cuneiform corniculate complex. You can see here, this is the cuneiform, and the posterior is the corniculate. You can see the two corniculate, the right here, the left here, and the cuneiform here. Obviously, arytenoid cannot be seen because arytenoid can be seen only during complete abduction. The corniculate will be seen over it's like a hat over the body of the apex of the body of the arytenoid. Now, we go into detail in each one of them. Now, we first look into the arytenoid. And we know that the arytenoid has the body, the muscular process, and the vocal process. Obviously, you can't see the muscular process there. Muscular process is immersed, is deep inside the soft tissue, so you can't see that. But vocal process and body, you can actually see. And if it is a properly done scopy in a normal larynx, both body and vocal process are completely visible during abduction. So that's very important. You can see here itself, before I play the video, This is actually the conical body, and this is the vocal process. Here again, you can see this is the right vocal process, and you can see upward and posteriorly slanting body of the arytenoid. And see, both of them are very, very submucosal. You can see the white color of the cartilage even. So hardly any tissue there. So very, very likely to get damaged with any contact to that area. So we'll see that again. You can see very clearly, see this is a big body of the arytenoid, the apex, and over which is the corniculate connected. And this is the vocal process. Here again, the right side, the body, the left side, the body, and the vocal process. Now, we all know that the trichoarytenoid joint is a synovial joint, saddle type, and there are two types of movements are allowed, the rocking movement and the gliding movement. The rocking movement causes the vocal process to medialize or rotate medially during phonation and rotate laterally during abduction. While the gliding movement is of the body of the arytenoid on the cricoid, so that the posterior most part of the glottis, that is the arytenoid part between the body of the two arytenoid, that part is closed. Here again, you can see very well the rocking movement of the vocal process on the left side. Just watch. Now coming to the cuneiform. Cuneiform is right in front of the arytenoid. It is actually in the aryepiglottic fold. It's actually elongated vertical strut with a globular head. Sometimes the shape may change. So this is a laryngectomy specimen, obviously done for a cancer. You can see the growth here, but what we are bothered about is the anatomy. So I will orient you. We have actually split open the posterior part. This is the right side, this is the left side. This is the epiglottis. This is the ventricle, this is a ventricular band, this is a vocal cord. You can see that. So this is the aryepiglottic fold, and posterior most part is actually the coniculate, and this is the cuneiform. So you can see that it's an elongated strut here in the aryepiglottic fold, but projecting above the level of the aryepiglottic fold as a globular head. This might be different in different persons. Sometimes it may be globular, sometimes it may be even like a very sharp pointed sickle-like thing. So we can see two types here. That's a globular thing, especially in pediatric age group, while in an adult, more sharply pointed conical structure. So it can assume different shape. What is more important is that it is actually in the aryepiglottic fold. An elongated strut, it goes down into the aryepiglottic fold, well into the lowermost part, but the upper part projects well above the aryepiglottic fold. Many books will say that this is meant for preventing the aryepiglottic fold to prevent aryepiglottic fold from collapsing during inspiration. I think hardly there is any evidence to suggest that. Most probably this kind of additional fortification is more likely for swallowing rather than for breathing, because you can see that's very important area. If there is enough height, if there isn't enough height, there is chance that the food may go into the larynx, causing penetration and aspiration. Anyway, that's not our topic today, but what is more important is that the understanding the importance and position of the cuneiform. Now coming coniculate. Coniculate is slightly L-shaped. Sometimes the people have written it as a comma shape or a triangular shape, but it is probably slightly L-shaped, boomerang shape. It has got a postromedial and anterolateral crura. Anterior crus articulates with the apex of the body, and most of the time it is a synovial joint. Here again you can see that In a laryngectomy specimen, the cricoid has been split completely in the midline. You can see the arytenoid here, and over the body of the arytenoid is the corniculate. So this is the corniculate cartilage, which has got a posterior and anterior crust. The posterior crust is more medial, anterior is slightly more lateral. It opens up actually during the abduction. Here you can see that is the posterior crust. This is the anterior crust. So when patient is, again, that is closing very well. Now, what is the normative data? Arytenoid cuneiform corniculate complex in normal adduction, what happens? There are many papers we ourselves have published recently in JLO. And what we have seen is that in normophonic speakers, in 70%, the arytenoid corniculate cuneiform complex adducts symmetrically, something like this. So you can see that the corniculate, the posterior crust corresponds to the posterior crust, anterior crust corresponds to the anterior crust, cuneiform corresponds to corresponding cuneiform. But 30% of normophonic people, they don't have any voice-related complaint. There is arytenoid adduction asymmetry, means one arytenoid override, with the result that the corresponding cuneiform, the concerned cuneiform. So if there is an overriding arytenoid on the right side, that cuneiform will be slightly more in front. And more than 80% of them, of this, that is the asymmetry group, occur on the right side. Left side, it is much less. Probably it is related to the handedness. I am not very sure about it. You can see this is the right overriding arytenoid. You can see very clearly here the right cuneiform is more in front, the corniculate comes too much anteriorly and meet the opposite cuneiform. So this is an overriding arytenoid. Patient doesn't have any symptom. So this is a benign override arytenoid asymmetry. Sometimes minority can have it on the left side too. Again, you can see the left is overriding. So 30%, nearly 1/3 of normophonic speakers will have overriding arytenoid or adduction asymmetry, arytenoid adduction asymmetry. Now, with that background, we will go into the unilateral vocal fold palsy and see what happens, both paralysis and paresis. It is almost inevitable that compensatory behavior happens on the normal side, unaffected side. Yes, this is especially useful in a vocal cord paresis. Sometimes the vocal cord paresis is so subtle. There are a lot of signs described like deep ventricle, opposite side ventricular band adduction, all these things. But I think one of the most definitive signs, this again we are about to, the paper is about to be published. We have seen that in almost all cases, it is the unaffected the arytenoid which overrides. So we can see here this is a paralysis. Again, you can see the left is paralyzed and you can see the right is overriding here. The cuneiform is right in front, corniculate has come here. So overriding happens on the normal side and more difficult case of paresis. Again, you can see the cuneiform, the right is overriding, so left is the paresis side. Partially paralyzed side, the right cuneiform comes slightly in front and there is overriding of that node. That's a very definite sign to help in the diagnosis of paresis. Now, vocal process adduction is brought about by the lateral cricoid node. So in a paralysis, if the vocal cords are meeting, however bad may be the voice, however big may be the phonatory gap, I don't think arytenoid node need to be addressed, because by doing arytenoid node adduction, what you are doing is actually rotating the lateral the vocal process, simulating the action of the lateral cricoarytenoid. If that is already done, there is no point. So first important point is that if the vocal process are meeting very well against each other, there is no question of addressing the arytenoid node. Like this case, it's a very interesting case. Look, very bad case. There is a lot of bowing of the left vocal cord. The tone is less, but see the vocal process is meeting. So obviously, no point in addressing the arytenoid node here. You can even see the arytenoid node is reasonably symmetrical. So this is purely an anterior to the thyroarytenoid function. Poor bulk, poor tone. Maybe the patient will require some kind of medialization plus most probably a non-selective reinnervation so that the tone is retained. But there is no point in addressing the arytenoid node here. Arytenoid node is doing very well, no problem. So if the vocal process is meeting, I think we can actually safely leave the arytenoid node. Now, if there is a big gap between the vocal process, then that is certainly an indication for addressing the arytenoid node. And obviously, the most popularly done case, surgical procedure is arytenoid node adduction or arytenoid node rotation. You can see this case, a patient who underwent thyroidectomy and postoperatively, unfortunately, developed a vocal cord paralysis. And massive overriding of the right side. But there is a big gap. Despite all the overriding, the vocal process level is far apart. So no way thyroplasty or anything is going to correct that. This is the condition, this is the classical indication where we need to reposition, adjust the arytenoid node muscular process. So the classical Ishiki arytenoid node rotation, arytenoid node adduction procedure should be good enough. And this is after the surgery. Now, arytenoid adduction asymmetry and arytenoid rotation. Again, there have been a lot of indications like wide posterior phonatory gap, vertical level incompatibility, and even MPD less than 3 seconds, which I think is MPD is probably a very controversial thing because many people's MPD will depend upon the attitude, the compensatory strategy adopted by the patient. So I think that has got very minimal role. We again have published our fairly big data last year in JLO, and from our inference, it is that the most important thing is the angle, the arytenoid asymmetry. So if the glottic axis, we have created 2 axes, glottic means between the 2 vocal cord, and the interarytenoid axis between the 2 arytenoid. If the angle is more than 30, actually the correct value is 33 degrees, then arytenoid rotation is likely to be required. So this is again suggests that the arytenoid asymmetry, when there is an arytenoid asymmetry, chances are that you will require arytenoid rotation. If you think little in detail into it, most probably the reason for arytenoid asymmetry is that when the vocal process are not meeting adequately, the normal arytenoid will try its best. So that means it will override too much, resulting in a big angle between the glottic axis and the interarytenoid axis. That might be the reason for having that kind of a reasoning. Again, you can see this is the glottic axis, the interarytenoid axis is actually tilted because the right arytenoid is too much trying to come medially and meet. Still, that is not possible. So when the angle is too big, it is better to go for arytenoid rotation. Now, arytenoid body approximation, luckily, is a rare condition when the interarytenoid, transverse arytenoid, oblique arytenoid is both are gone. You can see that here, that is the transverse arytenoid and interarytenoid. And as you all know, that transverse arytenoid has got bilateral innervation. So chance of it getting paralyzed, it is not very common in a unilateral vocal fold paralysis. But occasionally you come across patients where the body of the arytenoid doesn't actually meet at all. Look, watch this case, very interesting case. The vocal process is medializing. The anterior tooth head is trying to medialize, but the left arytenoid is far too away from the midline. You can see the vocal process is medializing fairly well. Anterior tooth-head is medializing, but the arytenoid, interarytenoid region is not coming. It's a very difficult condition to tell. There is no history of any trauma. We don't know whether it is dislocation or subluxation, nothing like that in the history. Is there a condition known as unilateral interarytenoid palsy? Is it possible with its bilateral supply? It is very, very difficult topic to address. But if it is unilateral, probably then adduction arytenoidopexy will be the answer. You described by Steven Settles. You open up the cricoarytenoid joint, take the arytenoid close to the medial part of the facet and fix it. And you may not even affect the movement, but you can actually close it. This was a traumatic case, and after adduction arytenoidopexy, do non-selective reinnervation has got a role in arytenoid malposition? That's a controversial question yet to be answered, because when we are actually doing the non-selective reinnervation, we are taking ancestor cervicalis to the recurrent laryngeal nerve to give some tone to the muscle. So it is quite possible it might work, but we need long-time studies and longer number of cases. This is one of our case who had a vocal cord paralysis. Very feeble voice, and you can also see that left arytenoid was prolapsing, means the tone is very little. 6 months after non-selective reinnervation, the voice is much better and the arytenoid tone has recovered. So probably it might work. This is a preoperative voice, very, very feeble. And this is the postoperative 6 months later. Now, arytenoid body under approximation, it happens bilateral, even though not strictly unilateral. I just want to add few slides on that. So this has been described as posterior glottic diastasis, especially by Steven Settles. And posterior cricoid split can occur. That's fine, because in posterior cricoid split surgery, we intentionally cut the interarytenoid. So like this case, there is no audio in it, don't worry about it. So but you can see this was a case who underwent posterior cricoid split for a posterior glottic stenosis. Naturally, there will be posterior body, the arytenoid body will not be coming together. That is understandable. But the problem is that without any history, we get some cases where there is a gap between the posterior, between the arytenoid. To call it diastasis is, I think it is really unfair, because there is no separation between the interarytenoid. There is no trauma. So it has to be neurological in origin, and they are not that rare. We have got few cases. I will just show 2 or 3 cases here. See that? This is a progressive vocal cord palsy. First it affected on one side, then it other side, and then started affecting the interarytenoid too. Another case. You can see the interarytenoid gap. Another case. Again, you see that posterior arytenoid big gap is there. So it's really difficult to call it posterior glottic diastasis. We cannot really accept. I really don't accept that theory, because there is nothing to call diastasis. The muscle has to separate. Probably posterior glottic incompetence is a better terminology. We don't know why it happens. Management is very difficult. Steven Settles has described something known as cricoid laminar reduction. You open up the posterior lamina, remove a segment so that the arytenoids come closer to each other. But not enough material is as of now available. So finally, you can get rare conditions like arytenoid corniculate subluxation dislocation. We have seen that arytenoid corniculate is a synovial joint. Sometimes in trauma, occasionally idiopathic can actually result in dislocation. Usually, they don't require a corrective surgery because the effect of the voice is very minimal. You can see here, this was a fisherman who had a blunt injury in neck, and you could see that the right arytenoid, body of the arytenoid has slipped from the arytenoid corniculate joint. It has slipped underneath and gone to herniate into the pyriform fossa. If you watch here, you can see that arytenoid body actually slips here underneath the corniculate. The normal corniculate on the left side is very well seen. Here the corniculate has gone down because the support of the body of the arytenoid has gone and it is herniating here. With the result that there is mild bowing of the right vocal cord. There is a small phonatory gap in a singer, in a professional voice user, it may be a problem. But he being a manual laborer, he didn't bother much about it. Occasionally, you might even see idiopathic cases where the arytenoid and corniculate, there is some kind of dislocation or subluxation. So that's in a nutshell about the concept of identifying the arytenoid issue in a unilateral vocal fold paralysis and how best to manage it. I think it's an evolving subject, lot of understanding in the physiology and anatomy, and especially of the neuroanatomy and neurophysiology of the larynx is coming. So hopefully we will see more and more of them, and hopefully in the future, again, we all will be together physically rather than online. Thank you.
15 minutes later.
Thank you for that wonderful and highly conceptual talk, sir. We have a few questions for you by the delegates.
Please.
So what is the difference between selective and non-selective reinnervation?
Selective reinnervation means you give nerve fibers destined for the abductors. Say like only a nerve which fire during inhalation to the abductor group and a nerve which fire during exhalation to the adductors. Say like you are giving phrenic nerve to the posterior thoracic node because phrenic acts only during inspiration and answer to the adductors. In non-selective means you give mainly an adductor fiber to the entire nerve. So you do the non-selective in unilateral vocal cord palsy because you are not bothered about the airway. The other cord is opening up very well. So your only aim is to give good adductor tone to the paralyzed muscle. So then you are not bothered about the selective reinnervation. You just take a nerve like answer which has got 10% exhalation fiber which fire during exhalation or phonation, so that that patient get excellent tone, adductor tone on the paralyzed side. It is just like thyroplasty, medializing. You get a medialized tone. You are not bothered about the abduction there because the other cord will do.
Thank you, sir. So we now have another international acclaimed stalwart in the field of laryngology, Dr. Tanya Meyer, speaking to us about neuromuscular pathologies such as laryngeal dystonia and tremors. Sharing the session, we have Dr. Vishwanath sir and Dr. Phanindra Kumar sir. Over to you, sir.
Hello, can you hear me?
Yes, sir. Yes, sir.
Okay. I would like to give an introduction about Dr. Tanya Meyer. Dr. Tanya Meyer is a surgeon in UW Medicine Head and Neck Surgery Center and a UW Associate Professor. Dr. Meyer feels that cultivating personal connection with each patient is the most rewarding aspect of her vocation. She enters a partnership with her patients to guide them through today's complicated health system with goal of treating each individual with respect, compassion, and patience. Dr. Meyer trained at a medical college of Fincazin, Milwaukee. Her clinical interests include voice disorder, swallowing disorder, neurological diseases of the throat, upper airway disorder, laryngeal cancer, vocal cord paralysis, and spasmodic dysphonia. Dr. Meyer's main research interests are in outcome of evaluation with regard to occupational voice disorder. She is also involved with development of tracheal tissue engineered replacement for complex airway defects. Her specialties includes otolaryngology, head and neck surgery, and telehealth services. She received education and training as a fellow in 2005 in laryngology in New York Center for Voice and Swallowing Disorders. And she did a residency in 2004 in otolaryngology in Medical College of Inquisition Medical Center. Thank you.
Doctor, you can talk about the topic so that after that we'll play the video.
Oh, no, I had to conclude,
Okay, doctor.
The topic only I had to conclude, not now.
Okay, doctor. Thank you.
Somebody welcome her. Already, Dr. Viswanath, you welcome. So we shot that audio.
Sir, it's done, doctor.
Thank you for the invitation to present at this esteemed meeting. I thank Dr. Roy Chowdhury and Dr. Subiyaya for this opportunity. I'm Tanya Meyer. My interest is in neurolaryngology, and I'm speaking from the University of Washington in Seattle, Washington. And I hope that all of you get a chance to visit us here in the Pacific Northwest when you're in North America, and please look me up. I know this is a very educated audience with an interest in laryngology, and we'll review some of the background and details of evaluation diagnosis, but I do want to concentrate on some injection techniques, and hopefully you will find some interesting tips and tricks there. We'll also touch on dosing considerations and on some of my research and outcomes. So we're talking today about spasmodic dysphonia and vocal tremor, two of my favorite subjects. So these are neurologic disorders of central motor processing. And although this is an older population and there may be some age-related changes, in general, the structure of the larynx is normal for these patients. This can be a regional or generalized process, but most often it's sporadic. So for spasmodic dysphonia, again, this is a task-specific dystonia. So dystonias are sustained contractions, and in this case, it would be the intrinsic laryngeal musculature. So it gives a strained, effortful speaking pattern. In general, aside from speech, other swallowing and breathing tasks of the larynx are normal. So for adductor spasmodic dysphonia, the adductor musculature is the one, the set of muscles with the abnormal spasms, and it gives a strained, strangled speaking pattern. For adductor dystonia, it's the opening or the posterior cricoarytenoid muscle that gives the breathy voice breaks. There is respiratory dystonia. That's more rare, and generally the voice is normal, but when patients are sniffing in, the vocal folds adduct. And with all of these tremors, there can be an associated, with all these dystonias, there can be associated tremor, either a central tremor or a dystonic tremor. Vocal tremor is felt to be distinct from dystonia, although these disorders probably are in a continuum. The tremor is usually described in the adductor musculature, and rather than these irregular sustained contractions, what we see is a rhythmical oscillation of the laryngeal musculature, and breathing and swallowing in vocal tremor are usually not affected. This is a study on focal dystonia for both spasmodic dysphonia and writer's cramp. And we see abnormalities in sensory feedback and motor processing within basal ganglia and cerebellar pathways. And there's similar circuitry that's involved in tremor. And these are the areas that are targeted for deep brain stimulation in these disorders. This is a busy slide, but what I want to point out is that there's similarities and differences between these various neurologic disorders. One thing that's interesting maybe a little daunting is that for many of the voice-specific dystonias or the dystonias of the head and neck, spasmodic dysphonia, vocal tremor, MEJ, and cervical dystonia, there is a female preponderance. The onset tends to be in the late Middle Ages. There's other focal dystonias that are not. For instance, hand dystonia or musician dystonia has a male preponderance. And for essential tremor, which is the most common movement disorder in the population, that is equal between men and women. What is important, though, is that all of these movement disorders do have a low rate, but a positive rate of other associated neurologic disorders. And that's why I feel it's important at some point to have all these individuals see a neurologist. In general, aside from essential tremor, these are rare disorders. Evaluation and diagnosis follow our traditional paradigm. But what I want to point out is that perceptual voice evaluation, so our clinician's ear and laryngoscopy are critical, in my opinion, to the diagnosis. And that's why often these people are diagnosed by laryngologists or speech-language pathologists. So history, I think it's important to know if there was antecedent trauma or if there was any medication use so that patients can stay away from those medications in the future. And then there's very characteristic historical factors, mostly revolving around alleviating or exacerbating factors. So singing, laughing, yawning, response to alcohol, those are all things that if the patient reports an improvement does imply a dystonia. There's also an entity called a just antagonist, and we'll go over that in the next slide, where patients can have a relieving maneuver that is also highly suggestive of dystonia. Factors that make dystonia more difficult are telephone, stress, public speaking, and fatigue. Aside from the just antagonist, these are also factors that are seen in tremor. The just antagonist or sensory trick or alleviating maneuver is something that is seen in dystonia, but not seen in tremor. And it's a voluntary maneuver that can temporarily reduce the severity of the dystonic posturing. And this is a sensory trick for this individual. Here, you'll see the characteristic strained, strangled voicing of adductor spasmodic dysphonia with vocal breaks.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And can you say the sentence, we eat eels every day?
We eat eels every day.
And now go ahead and do your maneuver where you hold your throat and count from 1 to 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And we eat eels every day?
We eat eels every day.
And can you giggle for me? I know that's kind of hard to do on the podcast. Okay. Great, thanks. The physical exam is important. This is more to rule out other associated neurologic disorders. So I do look for things like tongue fasciculations, which might imply ALS, palatal pharyngeal myoclonus, which might imply history of a stroke, motor rigidity, cogwheel rigidity, which may imply Parkinson's, or change in handwriting or gait. And finally, we get to the linchpin of the diagnosis, which is the perceptual voice evaluation. And these are fairly commonly known, but we'll go over them briefly. For adductor spasmodic dysphonia, you're looking at vowels that bring the vocal folds together, and individuals have hyperfunction of the adductor musculature which then causes the voice breaks. For abductor spasmodic dysphonia, you want to give sentences that demonstrate vowels following a voiceless consonant, such as D, H, T, or S. And we'll all choose specific sentences that you begin to understand the vocal signature of. So I like the sentence, the puppy bit the tape. It's an unusual sentence, but that it's unusual actually causes a slight amount of stress and may bring out that abductor spasms for a patient. So puppy, the vocal folds are open with the P sound because it's voiceless, but they have to bring the vocal folds together for the U sound, then back open for the P and back together for the Y. So instead of a smooth puppy, someone with abductor spasmodic dysphonia might say, hit the tape. And so you'll start to hear those abductor spasms in the sentence, and you'll start to recognize those patterns. Dystonic tremor will have the adductor or the abductor spasms, but also with an associated tremor, but the tremor will be somewhat erratic, as opposed to an essential tremor, where you'll see tremor across all voice tasks, mostly pronounced with prolonged vowels, but the tremor will be much more rhythmical. And I have examples of all these. So this is our characteristic adductor spasmodic dysphonia with vocal breaks on vowels.
We mow our lawn all year.
Please pass the peas and potatoes.
Please pass the peas and potatoes.
Excellent. So now I'm just going to have you say Aaron eats apples and eggs.
Aaron eats apples and eggs.
This is abductor spasmodic dysphonia.
The puppy bit the tape.
Hard.
Harry hit the hammer hard.
Here's spasmodic dystonia with tremor.
Go get a bigger egg. We now mow our lawns all year. She wears blue shoes on Sunday.
There's also a variant of spasmodic dysphonia that I call chronic constriction, where you just hear a consistently strained, strangled voice pattern. And this is a type of SD that's often confused with muscle tension dysphonia.
Good afternoon. Today is ontogeny recapitulates the phylogeny. That means
And this is somebody that had muscle tension dysphonia. Again, this could sound like chronic constriction, but this individual was able to respond to speech therapy and have vocal improvement.
1, 2, 3, 4, 5.
And finally, this is vocal tremor. So you'll hear a very rhythmical oscillation, but not a lot of strain. And laryngoscopy. I find this is critical in my practice. It rules out other lesions. It allows me to view the glottic closure pattern. Recall, this is an older population, so there may be underlying glottic insufficiency that will add additional strain that may not be due to dystonia. We also want to look for the patterns of hyperfunction. Look for abnormal motions at rest. So tremor at rest, again, you wouldn't hear that in the voice. You may see it, and it will sway you towards a diagnosis of essential tremor. And then it helps to choose a treatment target. So I want to talk a little bit about the spasmodic dysphonia vocal tremor continuum. These, as we saw at the beginning of the talk, have similar brain circuitry involved, although they're not the same disorder at the very ends of the spectrum, but they likely overlap somewhere in the middle. Individuals with spasmodic dysphonia can have a dystonic tremor, but the issue is that these may be treated with botulinum toxin chemodenervation, but they have very different outcomes. Spasmodic dysphonia and dystonic tremor can have a near normalization of the voice with botulinum toxin therapy, whereas vocal tremor will have a dampening of the amplitude of the tremor, but won't have complete alleviation of the vocal tremor with Botox therapy. And this is important to counsel the patients. Often a referring physician will be very excited and send a patient over with a diagnosis of SD. The patient will read on the internet and be very excited and anticipating a very good result with Botox therapy. But if they have tremor, you have to counsel them right away not to expect as significant of a result as they might have if they had SD. And this is an example of the irregular tremor versus the regular tremor that differentiates dystonic tremor from essential voice tremor. So this is a dystonic irregular tremor.
Go get a bigger egg. We now mow our lawn all year.
And this is more the regular tremor of essential voice tremor.
Alrighty, deep breath, say E as long as you can. Okay. What about a whoo?
Who?
And here we're not seeing a lot of supraglottic hyperfunction with this tremor versus with the dystonic tremor. Quite a bit of supraglottic hyperfunction. So important things to evaluate on laryngoscopy to counsel your patients on outcome. And again, looking at the history, the exam, the laryngoscopy will make our diagnosis of muscle tension dysphonia, spasmodic dysphonia, vocal tremor. And then finally, we can use as clues response to treatment. Do they respond to medications or alcohol, speech intervention, other therapies, and chemodenervation? Sometimes it's hard to know exactly what the disorder is, and you just have to give a trial of treatment and see how they respond. So let's move into looking at treatment patterns. Again, another busy slide, and we're mostly going to talk about chemodenervation, but there are other treatments for both spasmodic dysphonia and tremor. Speech therapy is mostly for education of the patient regarding the disease process and their response to botulinum toxin therapy and what to do if they have the side effect of breathiness or difficulty swallowing. There are some medications. Some vocal tremor patients respond, many do not. There's a new medication for spasmodic dysphonia. Unfortunately, it's difficult, at least in the United States, to get covered with insurance. And it also has a short duration of effect and requires frequent redosing. Laryngeal surgery has a variable success. There's issues with the long-term results, and there's centers of excellence here in the United States for the surgical procedures. And deep brain stimulation is the same, but does have some very favorable preliminary results. And deep brain stimulation can be used for both SD and tremor. So let's move towards botulinum toxin chemodenervation. This is our standard slide. We know there's multiple types of botulinum toxin. In the United States, I use Botox and Xeomin fairly interchangeably. They seem to have a very similar effect, and it's driven by insurance company in my clinic. And then MyoBlock for patients that are not having a good effect. MyoBlock tends to have a shorter duration of action and more side effects of dry mouth. And I actually use MyoBlock a little bit more frequently for ultrasound-guided carotid and submandibular gland injections to take advantage of that drying effect. Looking at the adductor musculature, I initially start with the thyroarytenoid in almost all patients for adductor spasmodic dysphonia. And I start at a half a unit to 1 unit bilaterally. I generally start bilaterally unless it's a very elderly patient or I have a concern for underlying dysphagia. And then we monitor for effects, and I look for 3 major effects: the percent of vocal improvement or percent of normal function that's regained, 0 being no voice, 100% being completely normal voice. I ask them about their initial side effects, whether they get vocal weakness or breathiness, a high-pitched compensatory voicing. For some of my older patients, we call it a Minnie Mouse voice. I'm not sure Minnie Mouse is as popular anymore, but it's just almost a paralytic falsetto. And then dysphagia, and this would be mostly to liquids. And we also want to ask what the duration of effect is, not just peak effect, but all effect. And then depending on the percent improvement, side effects, and duration, we'll adjust the dose. I think it's important to counsel the patients up front that we do expect some amount of initial side effect. Now, I usually tell patients that I accept up to 10 days of breathiness and compensatory high-pitched falsetto, and perhaps a few days of dysphagia to liquids. It's the intensity of those initial side effects that determines whether or not they're tolerable to the patient or not. And then with regard to the duration, our goal is an approximate 3-month duration. That will not all be peak voicing. Some patients get less, some patients get more. And this is how I adjust the dose. If we have insufficient vocal improvement, so I want patients to state they get somewhere 80+% if they have adductor SD in terms of their percent normal function. They do not get side effects, and they do not have a duration that's greater than 10 weeks. I would say that they have room to increase the dose. If their side effects are too intense, we can decrease the dose. But if the vocal improvement is acceptable and the duration is up to 3 months, I'll often tell patients we can try to increase the dose, but you likely won't get a longer response with an increased dose. So what happens when you don't get good voice, but you also have too many side effects? Well, the first thing I tell the patient is we hit the right spot, because that's important with chemodenervation is, did you actually get the Botox into the muscle you wanted to get it into? So if you have breathiness or dysphagia, you likely hit the right spot, but you're just not getting the effect that you want. So you can try a different muscle group. If you started with the thyroarytenoid, you can go to the lateral cricoarytenoid or the interarytenoid. Often for the chronic constrictor variant, we feel that the interarytenoid is important. And if there's a lot of tremor, we often feel that the lateral cricoarytenoid can be an important muscle group. If you're still having insufficient improvement, but too many breathiness or too much dysphagia, then we can start changing how we give the dose. So often I'll do a unilateral dose so that one side stays a little stronger, but I'm still giving this imbalanced Botox effect. And that can often relieve the dystonia with central feedback of the Botox to the motor functioning centers without causing excessive breathiness or excessive glottal insufficiency. You can also split the dose into high on one side and low on the other side. So I'll often give 2/3 of the dose on one side, 1/3 on the other side. And then when the patients come back for a subsequent dose, I'll flip either the side of the unilateral injection or flip the high-low dose. And finally, you can give false vocal fold injections, which tend to allow higher doses of Botox without the more extreme initial breathiness. So for tremor, we are really treating the same musculature as we are treating for spasmodic dysphonia, but it's a slightly different mechanism. Instead of centrally inhibiting the hyperfunctional behavior with the Botox, we're just actually dampening the tremor at the end organ. Also, tremor patients tend to be older, so there's more underlying glottal insufficiency, so they may have more pronounced breathiness initially, and I may be more prone to using lower doses because I'm concerned about dysphagia. I often start or very quickly go to LCA injections with tremor and also false vocal fold injections to avoid the breathiness. Finally, for abductor spasmodic dysphonia, we're treating the opening muscles of the larynx, which causes the breathy break, so we're treating the posterior cricoarytenoid. I usually perform unilateral injections, and I may stage them by 2 weeks. I rarely do bilateral injections for the fear of airway compromise due to bilateral abductor paralysis, which can give stridor. It can also give dysphagia. One thing I always tell the patients with abductor spasmodic dysphonia is I will always perform a laryngoscopy prior to giving an injection to assess airway adequacy. Sometimes they may have a prolonged paresis of a vocal fold. I've seen greater than 6 months. But even though the vocal fold doesn't move, they'll still have the breathy breaks. And so it's important to know that you have an adequate glottis before you give a contralateral dose of botulinum toxin so that you avoid bilateral paresis and dyspnea. So let's go to injection techniques themselves. We have 2 major innervation territories, the superior laryngeal nerve and the recurrent laryngeal nerve. And this slide is here. I know that these lectures are recorded. What I want to show you is that there are many ways to do these injections. And so if one way doesn't work for your patient, you can move on to another method. And we'll go over many of these today. This is also for the posterior cricoarytenoid. There's also many ways to get to the PCA. And this does not include going to the OR and doing the case by direct laryngoscopy for both the abductor and the adductor musculature. So let's talk about needle placement. And I thank Dr. Dingra for loaning me her slide. Let's start with the thyroarytenoid. And in general, for the thyroarytenoid, you can go midline, but I tend to go just off of midline, pierce through the cricothyroid membrane, stay submucosal, and then aim towards the ipsilateral ear, so superiorly and posteriorly, until I achieve motor unit potentials and an appropriate recruitment pattern. So we have, this is a diagram, and we have a video of this injection. Okay. The thyroid notch, the cricothyroid membrane. A little to the right of midline. And then angle up. E. Okay. As a variant, you can go midline and then hit air signal, and then angle up and insert transmucosally through and into the thyroarytenoid muscle. I tend to like to stay submucosal because I can do that without anesthetic, and I feel it's less stimulating for the patient. And finally, for the thyroarytenoid, you can also perform an endoscopic injection. I use a channel injector and a catheter needle. And these are fairly straightforward with topical mucosal anesthetic for the patients. This is a video describing the lateral cricoarytenoid injection. For the lateral cricoarytenoid or LCA injection, you want to palpate the inferior border of the thyroid cartilage, the superior border of the cricoid cartilage, and then that cricothyroid ligament. And right where the angle where those two cartilages overlap, at that angle, that's where you want to insert. You'll hear the motor unit potentials going through the cricothyroid muscle, and then you'll feel the puncture through the cricothyroid ligament. And then you would angle either just up slightly or superiorly and posteriorly, and you should hear the insertional potentials into the LCA and then recruitment with phonation. So in this video, I'll show both an LCA and an intra-arytenoid injection. So the first set of motor unit potentials was going through the cricothyroid muscle. The second set was the LCA, and then the recruitment with phonation. For this individual, I also give an intra-arytenoid injection. So it's a midline insertion. You'll hear air as we enter into the air column of the trachea, and then you go through the air column to the intra-arytenoid muscle. And for her, I had to readjust the needle somewhat, so you'll hear the recruitment pattern at the end as we finally hit the correct intra-arytenoid muscle target. Just like you're doing, nice and relaxed. This is air. Hit an E. 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 Here I'm adjusting. E. E. That was the proper recruitment pattern. And this is the intra-arytenoid injection with endoscopic guidance. And finally, these are false vocal fold injections. As described by Blake Simpson, it's critical that these injections are submucosal, otherwise the effect can be somewhat erratic. And again, the doses are 2 to 4 times higher than what you would give to the TA or the LCA. And this is given by the thyroid membrane of the hunch. So for the posterior cricoarytenoid, again, there's a variety of approaches. My standard approaches are to do a laryngeal rotation or an endoscopic technique, and I'll show both of those to you here. For the laryngeal rotation, you feel the landmark of the cricoid ring anteriorly, and then you can rotate the larynx by grasping the lateral posterior lamina of the thyroid cartilage, rotating the larynx, and then accessing the PCA transcutaneously through the piriform sinus with a confirmatory signal of sniffing on the EMG. And here's a video of that approach. So here's the cricoid, and I'm going to rotate his larynx. There it's rotated. Sniff.
And again. Okay.
With this approach, as you access the PCA laterally transcutaneously, you'll actually feel the needle of the EMG needle stop up against the posterior rostrum of the cricoid cartilage. And then this would be endoscopically with the catheter injector needle.
And again. Inject 10, keep going, inject 0.1. And this is good, relax. Okay.
So let's get to outcomes. Again, I want to mention about the continuum of SD versus vocal tremor. And we see this difference in the disease process in the outcomes. So for spasmodic dysphonia, for the adductor type, we see about a 90% return of normal function on average with adductor spasmodic dysphonia and approximately 70% return of normal function with abductor spasmodic dysphonia. I personally don't have any patients with abductor spasmodic dysphonia that say that their voice gets 100% normal for any durable amount of time after an injection. For tremor, it's similar to abductor spasmodic dysphonia. Patients can get significantly better, but they don't necessarily get to 100% normal if they have essential voice tremor. If it's a dystonic tremor, then that will respond more like pure adductor spasmodic dysphonia. One aspect of dysphonia in our patients is how the vocal disease affects them at work. Our ability to maintain gainful employment is critical to our well-being, both in terms of personally and also our ability to support our family and to be productive in society. And one of my research interests is evaluating the effects of dysphonia on an individual's work productivity. I looked at my SD population cross-sectionally, and what we see is that a quarter of a patients described reduced hours of responsibility due to their vocal dysfunction. 20% of them had to change jobs. 10% of them actually became unemployed. And nearly all patients stated that the Botox helped them at work. Last year, I published a prospective study looking at work productivity in my spasmodic dysphonia patients. Interestingly, a very common pattern arose that dysphonia patients describe their voice affects them more at work than it does in their other daily activities and in their home life. And this makes sense because when you're at home, your family knows you and you can use compensatory ways to communicate. But when you're at work, your communication must be clear, must be timely, professional, and you have the stress of a face-to-face or perhaps a Zoom interaction. And that stress brings out the spasms of both SD, tremor, or any other voice disorder. So in this group of patients with SD, their average vocal function increased from approximately 50% of normal function to 83%. And this brought back a very significant improvement in work productivity on average of 20%. So we've looked at other causes of dysphonia and work productivity, spasmodic dysphonia, respiratory papillomatosis, and muscle tension dysphonia. And these are all treated with either chemodenervation, ablation, or voice therapy. And interestingly, for the voice disorders, what we consistently see is that the dysphonia affects these individuals at work more than it affects them at home or in their other activities. And that's not the same pattern that we see for other disease processes. The second point I would like you to get from this table is that the work impairment that's caused by dysphonia is on par with work impairment caused by other disease processes. So dysphonia is significant and it causes significant work productivity impairment. And we really help our patients a lot when we treat their voice disorder and we provide them with better work productivity. So with that, I would like to sincerely thank you for the opportunity to discuss these disease processes with you and to show you some of the work we're doing at the University of Washington. I'm honored to present to this esteemed group. Please contact me if you have any questions, and please drop me a line if you're in the Pacific Northwest and come to the University of Washington for a visit. Thank you.
We are thankful to Dr. Thayer Mayer for her elaborative, educated talk on laryngeal dystonias. So, from this, we had to understand and conclude the term laryngeal dystonia is more appropriate than a spasmodysphonia. Laryngeal dystonia is a phenotypically complex and heterogeneous disorder that requires a multidisciplinary approach, clinical approach by neurology, otolaryngology, speech language pathology, neurosurgery, genetics, and neurosciences for accurate diagnosis. Perceptual evaluation and laryngoscopy are preferable tools for diagnosis. Less than 6% of the speech language pathologists and 2% of the otolaryngologists are only trained and specialized in laryngology and dystonia treatments. Standard treatment of dystonia is protoxin injection, which can provide temporary relief, but ineffective in about 40% of cases. Surgical procedures like laryngeal denervation or reinnervation, type 2 thyroplasty, laser thyroid myomectomy, and implanted peripheral nerve stimulators are giving variable results. Recently, sodium oxybate recommended as a treatment of choice for alcohol responsive laryngeal dystonias have become a ray of hope in these cases. Therapeutic approaches to laryngeal modulation using vibrotactile and electrical stimulation are also being explored treatment of these laryngeal dystonias. I am thankful to organizers for giving me this opportunity. As a founder, president, and chairman of the APSI, I also thank national, international faculty, delegates for your cooperation in making PHONOCON 2022 a great success. As the president of India chapter of Voice Foundation of United States, I welcome all of you to join as members of Voice Foundation. Thank you very much. Now over to moderators for any questions and answers.
Thank you, Dr. Tanya Meyer, ma'am, for that amazing talk that has been an eye-opener for us all. The questions that have been posted by delegates for ma'am will be sent across to her, and we will individually respond to each of the questions via email. Thank you, Dr. Vishwanath sir and Dr. Parinder Kumar sir for chairing this session.
Thank you. We will now have a brief inauguration ceremony, following which the scientific sessions will resume. So sit back and relax, dear delegates, and we'll see you soon.
A very good afternoon to our respected chief guest, eminent dignitaries, distinguished speakers, APSI members, and dear delegates. On behalf of the organizing committee, we wholeheartedly extend our warmest welcome to you all to this joyous occasion of PHONOCON 2022.
PHONOCON is the beloved brainchild of the Association of Phonosurgeons of India. Phonosurgery as a branch has seen widespread scientific discovery, technological advancements, and improved techniques over the years. To commemorate this, the Association of Phonosurgeons of India has been conducting this national level conference since 2003. And we, the Department of ENT of Kempegowda Institute of Medical Sciences, Bangalore, are delighted to be collaborating with them to celebrate their 17th annual Congress.
Without further ado, let us begin the inauguration ceremony by invoking the blessings of the Almighty with a melodious devotional song. Vignesha tava sharanam, Vigna vinashaka tava sharanam, Vignesha tava sharanam, Vigna vinashaka tava sharanam. ತಾಳ ತಂಬೂರಿ ಕೈಯೊಳಗೆ ವಿಠಲನ ಸ್ಮರಣೆ ಮನದೊಳಗೆ ತಾಳ ತಂಬೂರಿ ಕೈಯೊಳಗೆ ವಿಠಲನ ಸ್ಮರಣೆ ಮನದೊಳಗೆ ವಿಘ್ನೇಶ ತವ ಶರಣಂ ವಿಘ್ನ ವಿನಾಶಕ ತವ ಶರಣಂ ವಿಘ್ನೇಶ ತವ ಶರಣಂ ವಿಘ್ನ ವಿನಾಶಕ ತವ ಶರಣಂ ಲಂಬೋದರನೆ ಅಂಬಾಸುತನೆ ಮುನಿಜನ ಪ್ರಿಯನೇ ತವ ಶರಣಂ ಲಂಬೋದರನೆ ಅಂಬಾಸುತನೆ ಗುಣಿಜನ ಪ್ರಿಯನೇ ತವ ಶರಣಂ ವಿಘ್ನೇಶ ತವ ಶರಣಂ ವಿಘ್ನ ವಿನಾಶಕ ತವ ಶರಣಂ ವಿಘ್ನೇಶ ತವ ಶರಣಂ ವಿಘ್ನ ವಿನಾಶಕ ತವ ಶರಣಂ ವಿಘ್ನ ವಿನಾಶಕ ತವ ಶರಣಂ ವಿಘ್ನ ವಿನಾಶಕ ತವ ಶರಣಂ. Thank you, Dr. Bindya, for that beautiful rendition. We now request our respected chief guest, Dr. Ramchandra Sir, Dean and Principal of KIMS Bangalore, to light the ceremonial lamp and induct the celebration.
We request Dr. Jagannath Sir, Organizing Chairperson, to join Sir in lighting the lamp.
We request Dr. Sanjay Subaya Sir, Organizing Secretary, to join them.
We now call upon Dr. Smita S.G. Ma'am, Joint Organizing Secretary, to light the lamp.
We request the coordinators, Dr. Nirmala and Dr. Suhasini, to join them. Thank you, respected dignitaries. We request you to take your seats.
We would now like to call upon Dr. Jagannath Sir, Organizing Chairperson and Head of Department of ENT, KIMS Hospital, to welcome the gathering with a few words.
Good afternoon, respected Chief Guest Dr. Ramchandra, APSI team and dear delegates. On behalf of the Organizing Committee, I thank each and everyone for being with us here today. I would also like to thank the APSI team for giving KIMS an opportunity to host this prestigious event. It is with immense pride that I stand here today as the organizing chairperson for the National Conference PHONOCON 2022. In view of the ongoing COVID pandemic, we have had to plan for virtual conference. However, the organizing team member and the members of APSI have put in the best of their efforts to make sure that this virtual event is going to be effective and engaging as an offline conference. I hope all the delegates enjoy this conference just as much as we enjoyed organizing this. Thank you.
Thank you, sir. We now request Dr. Faninder Kumar Sir, Senior ENT Surgeon and Governing Council Member of APSI, to share his words of wisdom with the gathering.
Good afternoon, colleagues from India, and good evening, friends and faculty from abroad. The Association of Phonosurgeons of India, also called as APSI, is a professional society formed by about 10 ENT surgeons who have a special interest in voice disorders and their management. The association was formed initially during a national phonosurgery workshop in November 2003 held at Sri Satyasai Institute of ENT and Research Center for Voice Disorders at Guntur, Andhra Pradesh. Now APSC has got about 350 life members along with a good number of honorary members, both national and international. We are proud to say that APSI is probably the only specialty association which is having its chapters in the country. The primary aim of the association is to encourage education research in the field of voice disorders and their management, and also to initiate at least one voice clinic in every state of the country on non-profitable and non-political basis. The association is actively involved in training the upcoming ENT surgeons in the field of voice pathology and then phonosurgery. Actively involved in organizing the various phonosurgery workshops and conferences, including the hands-on training for both the ENT surgeons and speech-language pathologists across the length and breadth of the country. Currently, there are 4 centers conducting APC accredited fellowship programs in laryngology and then phonosurgery. The association officially recognized by the World Voice Consortium in 2010, and APSI also successfully organized World PHONOCON in association with the International Association of Phonosurgery in 2017. Recently, India chapter of Voice Foundation was inaugurated by Professor Robert Shuttleworth during our 15th National Workshop on Phonosurgery. Many luminaries in this field globally have contributed actively over the years in nurturing the association. The association has launched its official journal called the International Journal of Laryngology and Phonosurgery in year 2011, and later a textbook on phonosurgery in the year 2017. Today, we are organizing the 17th Annual Conference of the Association of Phonosurgeons of India, PHONOCON 2022 at Bangalore on a virtual platform. We are thankful to doyens in laryngology for sharing their experiences in PHONOCON 2022. Professor Stephen Gittels from United States, whom I met for the first time in 1999 at New Orleans during the Voice Surgery Symposium. When he first introduced the concept of phonomicrosurgery, I purchased the phonomicrosurgery instruments during the symposium and returned to India and soon started practicing it in the country. Other luminaries are Professor Andrews Miller from Germany, Professor Shigeru Hirano from Japan, and Professor Tenyu Mayer. I congratulate Organizing Chairman Dr. Jagannath, Organizing Secretary Dr. Sanjay Subbaya, and their entire team in making the PHONOCON 2022 a memorable event in the history of APSI. I am also thankful for giving me this opportunity. Long live APSI, Jai Hind.
Thank you for those encouraging words, sir. We now request Dr. Amitabh Roy Chowdhury, sir, President of APSI, to enlighten the gathering with a few words.
Good afternoon. It is indeed my proud privilege today to welcome you to PHONOCON 2022, the annual conference of the Association of Phonosurgeons of India, being conducted by Team Bangalore this year. As you have already heard, that Association of Phonosurgeons of India was born in 2003 November under the able leadership of the founding president, Dr. V. Phanendra Kumar, Vice President, Dr. Jaikumar R. Menon, and Honorary Secretary, Dr. K.K. Handa. Since then, we have been able to make considerable progress, and the association has grown leaps and bounds. We have a membership toll of 506 today, as of today, and we also run our prestigious journal, which is the International Journal of Phonosurgery and Laryngology, which was started in the year 2011, and now we are into the 12th year of publication, which is a well-accepted journal in our community. We also launched our official textbook, the EPSI textbook of laryngology, in World PHONOCON, organized by us in 2017 at Gurgaon. And this textbook has also found a good place, not only in the country, but also much beyond the confines of our country. Next, we have fellowship programs running in our association. EPSI, or the association, provides accredited fellowship in laryngology in 4 centers, which is accredited by our association. And throughout the year, we conduct educational activities, hands-on training session, and also an annual conference and a Meet PHONOCON, trying to generate interest amongst the budding otolaryngologists and also to continue imparting knowledge. Essentially, we would like to, or we have been doing, providing a platform for all the people in the country and the neighboring countries, especially the budding otolaryngologists and the laryngologists who have an interest, to come and present their work on laryngology. And the laryngology as a super specialty has grown so much that today we have 3 more super specialty in laryngology, like voice, airway, and swallowing. And it is my proud privilege today to also announce the fellowship in the last 2 years, because we could not have PHONOCON physically in last year, which is 2021. And therefore, if you allow me, I will just share my screen. Normally, these fellowship awards are awarded during the annual conference with the candidates physically present in the conference, but I would just name them. And so the first candidate to receive fellowship, which was she completed in 2021, Dr. Anjana John. She completed the requisite training from Dr. Jaikumar Institute of Laryngology, Thiruvananthapuram. Congratulations, Dr. Anjana, and we would have loved to hand over this certificate physically, but because of pandemic, we are just announcing this on this digital platform. The next candidate is Dr. Asitama Sarkar, also in 2021, who completed her requisite training from Bombay Hospital and Research Center, Mumbai, under the able mentorship of Dr. Nupur Nerurkar. Congratulations, Dr. Asitama. Again, the certificate will be sent to you. Dr. Shivani Gupta completed her fellowship very recently, again from Bombay Hospital and Research Center, Mumbai, under the able guidance of Dr. Nupur Nerurkar. Congratulations, Shivani, and we will again send you the certificate. So congratulations to all the fellowship awardee, and wish you good luck with your career in laryngology in our country and beyond. I would again congratulate the team PHONOCON 2022 for putting up such a great effort to make this conference a great success. And the hallmark of this conference has been that there has been close to 100 submissions on various award paper categories for oral and poster presentations. And that reflects the interest generated in the subject of laryngology amongst the otolaryngologists in the country. I would also welcome you to become a member of our association, where you can come and present your work, and you can also publish in our accredited journal. I would also welcome you to PHONOCON 2023, which is likely, at least planned to be conducted physically, a 3 days full conference with live surgery and hands-on training, cadaveric dissection, etc., under the able guidance of Dr. Jayakumar R. Menon in Thiruvananthapuram. And I would also like to thank our entire PHONOCON team, and especially our chief guest today, who has taken time off from his busy schedule to come and join us here. Recordings of the conference will be available for the delegates for next 2 months. So thank you very much, and I wish PHONOCON 2022 a great success.
Thank you, sir. That was truly eye-opening for all of us. We would like to request Dr. Unikrishnan Menon, sir, the Honorary Secretary of APSI, to instill us with his enlightening words.
Good afternoon to all of you. As part of the inaugural function, I am Dr. Unikrishnan Menon, the Honorary Secretary of APSI, presenting my report. So, it has been a tough couple of years for all concerned, including our individual doctors, ENT surgeons, laryngologists, the association, the academic activities. Everything has been a sort of standstill. But we are happy to be on the road to recovery. Especially now, we can say we are halfway on the road. We could not manage to have a physical PHONOCON as we had hoped for, but 2021, where we had to completely do away with PHONOCON, we are in a much better position now. We are actually having a PHONOCON, although virtual. So yeah, let's hope things improve further. So to begin at the beginning, and the beginning in this case was our last PHONOCON 2020 in Daman. So it was a great show put up by Dr. Alok Karulkar, Dr. Farida Wadia and team, and the efficient Surat team deserve all the appreciation and applause for a successful event. There were nearly 200 delegates, and we had the benefit of great faculty, useful workshops, and lovely hospitality entertainment. So thank you, Dr. Alok, Dr. Farida Madam, and all the Surat and Daman teams combined. So that is where we last met. Our last annual body meeting was there. The other number to note is 500 plus. As I speak, it's 506 or 7, and that's the latest strength of our association, APSI. And I'm also glad to add that many of the newer incumbents are all the youngsters. The one main reason being, as a part of writing the fellowship and the exam, they have to be part of APSI. So we have a lot of new young members now. So that's one really good thing. So we are 500 plus now. Academic activities. So we had quite a few in 2020, beginning with the Laryngology Connect in May, where nearly 800 delegates and from all over the country. Then 1st of November, Parindra Kumar sir organized a mid-PHONOCON, where there's a good attendance. And then in December, the Kerala chapter had 2 weekends virtual conference, pediatric glotology and neurolaryngology both. Attracted a niche audience and was well appreciated. So this is all that happened in 2020. And as you all know, the academic fatigue and webinar fatigue took over in 2021. There's not much of note directly related to APSI. But we were not in activities, the executive body. We would have discussions. We had actually had 5 executive body meetings roughly from August 2020 to December 2021. And the decision-making process regarding various aspects of the functioning of association have been going on. Now, some individual achievements, I thought we'll include this also. So this is by no means exhaustive, and I apologize for whoever names I've missed out. But definitely first on the list, and to have take some pride for all of us, is Dr. Nupur, who has achieved 2 firsts in India in being the international member of the American Bronchoesophageal Association and corresponding member of the American Laryngological Association. She's also first author of a publication in international journals, and she has been included in the scientific organic committees of 2 upcoming international conferences. Jayakumar sir, along with the fellows, have got 3 articles published related to arytenoid functioning, 2 in JLO and 1 in the European archives. Dr. Jayanti Amrita has an interesting article in investigation of pediatric dysphagia in the International Journal of Pediatric Otolaryngology. Dr. Anaga, an article on customized digestion in JLO. And one of mine, which is actually came in the e-version 2019, but the print version came in Jan 2021 on the voice problems and features. Then our own journal, IGOPL, fully appreciative Dr. Samitra for managing the vexing job of editor. This is all our support in every possible way. The editor's report would also be there in the AGM actually. Website, webmaster Anaga is doing well and looking forward to further FAQs, videos, etc. on the page. Laryngology fellowship programs have been going on successfully at some centers. And now last but not the least, here we are, the present, and that is PHONOCON 2022. So great show put up so far by Dr. Sanjay Subbaiah and the Bangalore team. So well done, Sanjay. And all the very best to all of you. Looking forward to memorable PHONOCON 2022. Thank you. Long live APSI.
We request Dr. Sanjay sir, Dr. Jagannath sir and Dr. Smita ma'am to kindly felicitate our chief guest, Dr. Ramchandra sir, our Dean and Principal.
Thank you. We request our dignitaries to take their seats. Thank you, sir. We now call upon our esteemed chief guest, Dr. Ramchandra sir, to address the gathering.
Very good afternoon to one and all present here. On behalf of the management of KIMS, Kempegowda Institute of Medical Sciences, I would like to thank the Association of Phonosurgeons of India for giving me an opportunity to host a national conference, PHONOCON 22, from the Department of ENT. We at KIMS always support such academic activities. We believe in provides a conducive platform for eminent stalwarts in the field to share their knowledge and experience with the young budding surgeons and doctors, which goes a long way in shaping the career. It's a great honor for me to be with you for this exciting occasion. I am delighted to have this opportunity to address the talented gathering of surgeons and speakers. I am happy to hear such an enthusiastic response from the delegates all over the country, and I wish this event be a great success. Thank you.
We conclude the inauguration ceremony with a vote of thanks by the organizing secretary, Dr. Sanjay Subbaiah sir.
A principal, Kempegowda Institute of Medical Sciences, my colleagues from the Department of ENT, Kempegowda Institute of Medical Sciences, ladies and gentlemen. Oh, what a journey it's been. After PHONOCON 2020, as I left Daman, I was excited and I was a little nervous. But what happened in the last 2 years, I was even in my wildest of dreams and expectations, I never anticipated this. PHONOCON 2021 became PHONOCON 2022. We fluctuated and vacillated between online, hybrid, online, and finally we settled down for online PHONOCON 2022. I thank APSI, the founders of APSI, for this wonderful platform, the office bearers of APSI for their rock-solid support behind the organizing team, the wonderful and highly experienced international and national faculty who shared their experiences and knowledge with us, the record-breaking more than 100 award papers, and more than 500 delegates who registered for this conference to make it a grand success. I would also like to thank the sponsors, Atmos India, Olympus India, Bangalore ENT Trust, and CIPLA for their sponsorship. Finally, I would like to thank Avyaya Management Services for this wonderful platform. I hope you enjoyed this conference and thank you all.
Welcome back to the scientific program. We have had a successful morning filled with such amazing and informative talks by so many reputed distinguished surgeons. We now move on to the next session. We have for you a series of surgical demonstrations going from the basics of pharyngeal surgery to advanced procedures, all being performed by stalwarts in the field. So grab some popcorn, but also a notebook to jot down the tips and tricks that these surgeons will disclose as they perform various procedures. Delegates are also requested to post their questions in the chat box, which will be addressed at the end of the surgical demonstration session. Please do put up all your questions in the chat box.
Good afternoon. At the outset, I would like to thank the organizing committee of the PHONOCON 2022 for giving me this opportunity to share my thoughts on this topic today, and also to kind of set the stage for the whole afternoon video session today. As we are going to be talking on most of the microlaryngoscopic procedure, as we know, the microlaryngoscopy forms the foundation of any procedures that we do, both for airway and for voice and even for swallowing for that matter. And I call this an art because this is a surgery which is not easy all the time. It's not always smooth sailing all the time, and therefore lots of nitty-gritties that we need to look at. And that's what I'm going to take you through in the next 25 minutes or so. Now, what are the challenges? Why are we discussing microlaryngoscopic surgery? Firstly, I think exposure can be a difficulty. Illumination to reach the correct area of our surgery can be challenging. Anatomic constraints are always there in all patients. Each patient is different. Pathology sometimes obstructs our view, both for intubation and for doing the surgery, and also for mapping a lesion that we are going to operate on. To add to the problem, we have the surgeon and the anesthetist are both working in the same area. They also want the airway. We also want on the airway. So ventilatory chest movement, sometimes when you suspend the laryngoscope on the chest, can affect the precision on the delicate structure that we operate on. Last but not the least is preventing post-extubation strain on the larynx, because you do not want the patient to cough and strain after a wonderful surgery and everything will fall apart. So you want the patient to wake up nice and steady and very smoothly. So why has MLS stood the test of time? Because, I mean, if we look at the history, we know that Kilian in 1910 performed the first suspension laryngoscopy, and it was Dr. Rosemary from Germany who visualized the larynx under microscope with a suspension with those days OPMI 1 microscope from Zeiss, and subsequently Kleinsässer in Germany again, and Jacko in US popularized this kind of surgery, and surgeons were very happy with such a controlled procedure where this airway was secured. There was magnification, so we could operate on delicate structure. Both hands were free because of suspension, and therefore precise surgery was possible. And later on, laser was also added to the armamentarium of microlaryngoscopy. Now, as we know, preparation is key to success in everything in life. And for microlaryngoscopy, it starts when the patient walks into the clinic. We want to watch at the gait of the patient, the neck of the patient, the way the patient is talking, if there is a torticollis, if there is a stiff neck, all those things. The nature and type of pathology is important as we do the laryngoscopy. Neck, mouth opening, tongue, cervical spine, airway, and finally, this kind of a patient, as you can see, there is trismus probably in this patient, is going to be difficult. Poor alignment of the teeth can make difficulty, but we can get away with that. But worst nightmare of a laryngologist is this kind of a patient of an ankylosing spondylitis. And for, at least for me, this is a total no-no for a microlaryngoscopic surgery. We have to find some other alternative for this kind of surgery. And last but not the least, pre-anesthesia workup. We do not want to operate on a patient who has been just recovering from an upper respiratory tract infection or who has been on blood thinner. So the vascularity of the vocal fold, affects the quality of surgery, and that needs to be taken into consideration. Again, this is a nightmare for us laryngologists because this patient has trismus and also a retruded mandible. So again, microlaryngoscopy is going to be very difficult in this patient. So coming to the basics of airway evaluation is that as we have said, trismus, status of mandible, tongue base, oropharynx, neck, and neck flexion. So a Mallampati score or the modified Mallampati score is good enough to assess, in the sense that if this kind of a score is there in a patient, is likely to have a successful smooth laryngoscopy, microlaryngoscopic exposure, and this is a bad patient, bad predictor. And this is an intraoperative scoring which actually helps in documentation but not for assessment. Now, one very important and simple way of predicting a difficult exposure is thyromental distance. As you can see, this is the distance. And if the thyromental distance is less than 6, then the intubation and rigid laryngoscopy, microlaryngoscopy is almost considered impossible in an adult patient. And it is very easy to measure this like we are doing in this patient here. We can also score the evaluation of difficulties and predictors of a good laryngoscopy by a score called Laryngoscore, which was published in the Laryngoscope in 2014. If anyone is interested, they can look into this. So all these points are scored, and including the interincisor gap, thyromental distance, and the degree of neck flexion and extension is measured in terms of angle. So overall total scoring system will predict a good, a bad, or mediocre situation. Anesthetic issues, very important. First of all, we must have a trained anesthetist. An anesthetist may be a fantastic cardiac anesthetic, but may not be a very good anesthetist for a microlaryngoscopy, because what we expect from these anesthetists, from our anesthetists, number one, we want an intubation which is atraumatic. Number two, we want a microlaryngeal tube, which I'm going to talk about. Number three, we want gentle and fully paralyzed intubation. We want to maintain the relaxation throughout. So these are the important things, and sometimes intermittent apnea has to be ordered for a airway evaluation in a child or something. So if we put a normal endotracheal tube in a difficult exposure larynx, then this scenario will be like this. We will not be able to get anywhere. But for example, this is a 7 size adult endotracheal tube with a cuff of good protection of the larynx. If we take a 5 size microlaryngeal tube, which will also have a low pressure, high volume cuff of the same size, giving good airway protection, yet adequate space for us to work, and there's the length of the tube is also more. So MLT is must for a good microlaryngoscopic exposure. Coming to the choice of laryngoscope, again, Klein-Sisser is the most widely practiced laryngoscope, at least in our country, and there are many sizes of Klein-Sisser we can choose, but we, from our practical experience, know that the largest size which is manufactured in the Western world is not generally required for most of our Indian population. So the two medium sizes are good enough. We can also have a Dido laryngoscope, which is similar, but this also has a little bit anterior beak. So it gives a little edge for anterior lesion, and that little gentle bend here gives a little space for the tongue to rest, and the chance of pressure on the tongue is less, in my opinion. We also have this Veda laryngoscope, which is a beautiful instrument in terms of, though it sounds and it looks extremely bulky, that it can be made longer and expanded anteriorly, proximally, distally. The blade slide will move from side to side, and also it can be expanded in that manner. So it's very good for supraglottic work primarily. So we need to choose, depending on the lesion, which size of the laryngoscope is required. This is the opening of the laryngoscope. So if there is an anterior commissural lesion, we must have a triangular shaped laryngoscope. If there is a general vocal fold mid-third lesion with just a roundish size is good enough. And if we need the supraglottic work to be done where all these structures have to be exposed, then we need VIDA. Coming to patient position, again, for microlaryngoscopic surgery today, most of the surgeons globally prefer a neutral position, which is nothing, no shoulder bag, no head ring. So the patient lies in supine position, and this usually gives a little bit of extension as we insert the laryngoscope, which I'll show you in a second. We can also do an extension flexion position, which is required for some difficult patients, and very rarely a flexion position where the flexion is at the neck and also at the atlanto-occipital joint. So these are the various positions, but in general, a neutral position is the best position for most of the non-difficult, non-challenging laryngoscopy. So coming to the steps of laryngoscopy, this is for the benefit of any junior budding otolaryngologist who may be watching this program. We need to first of all protect the upper jaw, and there can be most of the time today with modern dentistry support in the community, lots of people have caps and crowns and other even dental implants in the jaws. So upper jaw needs to be protected like this, as I have shown you. Then coming to laryngoscopy, this is a neutral position. As we can see, head is slightly extended and the scope slides between the tongue and the palate, and as we reach the uvula, we actually lift the tongue a little bit, taking care not to damage, and at this stage there will be a little bit of suction necessary, and therefore we can get a good view, and beyond that we slide in the laryngoscope, which I will also show you in the next. So as you saw in the previous image, I was showing use of the right hand by the surgeon at the beginning of the introduction, but for a difficult laryngoscope, the surgeon should be able to use both hands efficiently. For example, here, this was a difficult laryngoscopy, and you can see that I've taken the laryngoscope in my left hand now so that I can use my right hand to generally slide in the laryngoscope rather than pushing it and using my elbow as a force. So as we reach a tight area, instead of pushing, exerting pressure, as you can see, the right hand is using that sliding movement, and it is also trying to put pressure on the cricoid. So you should be able to use both your hands efficiently depending on the situation. Coming to suspension, again, suspension I think is necessary routinely, but once the surgeon has been able to expose the larynx, we depend on the assistant surgeon to fix the laryngoscope, making all the relevant screws and attachment correctly so that it does not snap in the middle of the surgery. And the assistant actually helps to stabilize the suspension depending on where you want to stabilize it. But after that, the surgeon actually takes over and then makes the final adjustment depending on what vision is required for which lesion, and sometimes the scope may have to be withdrawn a little bit, which I am going to show you later as well. Suspension can be placed either on the chest with a little bit of padding, heavy padding, but the problem is that this will have a small risk of cardiac tamponade, and also because a small ventilatory movement from the ventilation machine or bag will be transmitted to the operative site, which is not an ideal situation. We can also put the suspension on a Mayo's table, which is very ideal, but at times it is difficult, or we can put the suspension on a stand, as we can see here. There also, it is independent of the patient's body, and so thoracoabdominal movement is not transmitted into the operating field. What is the optimum exposure? Optimum exposure is This one, where we can see the vocal folds, we can see the tube, the cuff is well below the subglottis. We can see a little bit of the ventricle, ventricular band, and anterior commissure, and the mucosa above the soft tissue above the anterior commissure. This is our general optimum exposure for a good laryngoscopic surgery. Coming to the next stage, which is palpation. So when we do microlaryngoscopy, we must palpate using two forceps. This is like a bimanual palpation, just like we palpate in the neck or some other area. We are using two pair of forceps here to palpate to see whether there is a cystic change, how deep is the lesion, how much fibrotic is it, and how much is going to be my area of resection. Similarly, we can also confirm and find some new findings. For example, this was a vocal fold polyp, and when we palpate, we could see there is a mucosal bridge here, there are multiple sulci, and also polyps hidden in the sulci. So all the confirmatory findings will dictate what is the final plan of action for surgery. Hydrodissection is useful in the way of infiltration, and we prefer to infiltrate dilute solution of adrenaline in saline. And the effect of hydrodissection is such that it bloats up the lesion, and actually there is a little bit of plane created, as you will see here. The moment you do inject the saline and adrenaline, this plane is created, and this area I can put my knife or my laser beam, whatever. And in addition, if we are using laser, then laser energy, CO2 laser energy, will be cooled down in that water content in that plane, and the dissection is very effective and usually bloodless. Steps to ensure precision. It's very important. Once you have done this exposure, we must have the right instruments. Traditionally, we have always used cup microlaryngeal forceps in the past, but we are all drifting more towards holding the lesion with a heart-shaped forceps like this. This particular forceps is a Bushire forceps, which is my personal choice. And advantage of this forceps is that you can grasp the lesion along the longitudinal axis of the vocal fold, and therefore there is no chance of amputation or trauma by the forceps. And we also have full range of dissectors. If we have to use suction more often, so we must use the suction over the patties and not directly. And here you can see the heart-shaped forceps is holding the lesion just parallel to the long axis of the vocal fold. That is very important. At times, we do land up with situation where the polyp or some mass has been excised, but there's a little bit of tag left. So if we have the right instruments and proper control, we can actually then hold this tag. It is only possible with this kind of a grasping forceps like Bushire, that you hold it very gently and have sharp, small scissors to cut the tag, which will give you a good outcome in terms of very quick epithelialization. As you can see, this is the end result after the flap has been reposited. Coming to stability more, operating chair. Why do we need operating chair? Because the microscope light goes much beyond the microscope lens into the larynx or the vocal fold, and because of that the instruments are very long. So the moment you are holding these instruments with your hands hanging, actually there is bound to be some human shaking. And if you can rest your hand on the hand rest, then probably the stability is good, as you can see in this picture from the internet, that the surgeon is resting in the head and doing the surgery. Also, this is an indigenous way of doing it. If you do not have this operating chair, which we have done in some situations, you can actually use a headrest of the bed to support your head, or you can intubate the patient with the head here and then move the patient backwards, where you can see the surgeon is having a good stable hand rest. When things go wrong, what do we do? Things are going to go wrong according to Murphy's law in life. And there's no point scratching your head when things have gone wrong. So we should have a backup plan B and C. For example, if there is a failed intubation, we must resort to a fiber optic naso, oro, or laryngoscopic route, flexible route for intubation. Anesthetic video laryngoscope, if that has not been already used. Sometimes taking over from the anesthetist who is a friend and a good colleague, because change of hand does the trick sometimes without any scientific basis for that. And usually if you have a friend anesthetist, he doesn't mind. And at times we do have to accept that we cannot do this surgery now. So we cancel and optimize the patient and do it later. And at the same time, when we have a more instrumentations available, when we have more senior or more expert hands available. So that is something, because patients come first for all of us. At introduction of laryngoscope, we can have dental extraction, injury to the oral cavity, supraglottics, any injury, and finally, difficult exposure. Intubation was good, but you cannot expose the larynx. What do we do? Most of the time it is exposure lacking in the anterior part of the larynx, and we can either put pressure on the cricoid, which means lower border of the cricoid cartilage, or change the scope, as I showed you the range of scope, or change patient position. Like this was being done in a neutral position, there was exposure was bad. The moment this was done, like a flexion extension or extension flexion position, which flexion here and the extension here, and which usually gives rise to a better sometimes using an angled endoscope when the exposure is not possible in spite of all the methods, all the tricks tried. So we can take an angled endoscope and at least look into this, take a biopsy, do an amputation, but we cannot do a very precise microflap surgery or something like a cyst. And last but not the least, if we wait for some time, the larynx actually drops because of the relaxation after some time, about 15-20 minutes. Neck strapping. Again, we have to put pressure on the cricoid cartilage. And if we put pressure intermittently, that does not give the stable feel for the surgeon to work. Therefore, it is nice to fix the pressure on this roller bandage, as I can show you, and tie it to the table, which gives a good stable. Here you will see that this is a patient where nice intubation, but you are not able to expose the anterior part. Now the problem here are two. Number one, we are trying to put the cricoid pressure, but the larynx's anterior part is not getting exposed. Why? Because the scope is too far away. The scope needs to be withdrawn 1 or 2 millimeter and then put the cricoid pressure. As you can see, you will see a beautiful exposure. Withdraw the scope now and put the pressure, everything will fall. So you have exposure of the anterior commissure, both vocal folds, ventricles, ventricular band. So that is how it works when you put a neck strapping and tie down. Video laryngoscopic surgery. Just one word about this. When we use microscope, there is a lot of light which goes, it has to travel a long distance right up to through the laryngoscope to the vocal fold. And therefore, sometimes there is a lot of glare. And as you can see here, there's a lot of light glare, and some amount of light is lost as it reaches there. But if you have an endoscope which goes very close and it has a wide angle panoramic view, the same patient, when you insert an endoscope, you get a fantastic light dissipation everywhere with a panoramic view and all the minor details in a much better way. And this is the assembly of a micro video laryngoscope, where you can see a scope is attached into the slot here of the laryngoscope, which is a 15-degree scope, and you actually operate off the monitor rather than looking through the laryngoscope. Sometimes use of a telescope through the laryngoscope to evaluate the lesion and to evaluate more thoroughly what you want to do, and this is also good for documentation, for recording, etc. Intraoperative difficulties. Sometimes the lesions can be too large. Extent can't be marked. I'll show you. Sometimes a small lesion, but anterior limit is not reachable. A cyst may burst, which needs to be marsupialized if it is vallicular. If it is vocal fold cyst or intracaudal cyst, then there is no marsupialization. You have to do justice to the surgery, and therefore at least one wall needs to be controlled, and therefore you can gradually It will take time, but you will still be able to dissect the whole thing. For example, this is a very mass lesion, which is a polypoid lesion. But the moment you put the scope, you can't tell where to start because you do not know where it is attached to. But the development with this forceps that you do, the moment you push the polyp downwards into the subglottis, you can see there is a nice plane of dissection here, which you can start your dissection with. This is another small lesion, which actually you see is not getting exposed, but with again that cricoid pressure and a little bit of withdrawal of the scope, you are able to see. The basic principle is that if you cannot see this anterior part, you should not operate on this kind of lesion. You can at the most take a biopsy, but if you expose, you can actually see that beautifully it can be executed. If there is a large supraglottic lesion like this is a patient who was tracheostomized because of the airway problem and then now anesthetized for the supraglottic lesion. So with the scope, normal standard Klein-Sisel laryngoscope, you are not able to see the extent of the thing, and therefore for this kind of thing we will need a vidoscope which will help us to do the surgery efficiently. We need to check all these structures after the end of the surgery, and we must have the anesthetist extubating the patient when the patient is slightly deep, so the patient does not cough out the tube when he is awake, and therefore it also helps in prevention of laryngospasm. In laryngospasm prevention, we can either give topical lignocaine spray, we can give block from outside, we can also give a pyriform sinus block, which I can show you here. This is at the end of the surgery, we have exposed, this is the left side, left arytenoid through the laryngoscope, and this is pyriform sinus. So what we tend to do, we just take a cotton ball soaked in 4% adrenaline and leave in the pyriform sinus to block the superior laryngeal nerve, which is there in the wall of the pyriform sinus, and therefore leave it for 2 minutes, and usually it prevents laryngospasm. Post-op management, nothing much to talk about except for the fact that the voice rest is, it depends on the surgery you have done, but planned and gradual return to voicing is very important. You cannot just give voice rest for 3 days and on 4th day patient goes back to normal shouting. That is not working. So that has to be planned with voice therapy properly. So with this, generally we can achieve this kind of a result. Good exposure, good mapping of the lesion, good execution of the surgery, and finally a nice edge, there is no trauma. To get this, we need to do a thorough homework. We need to talk about the anesthetist issues with the anesthetist. We must have a range of laryngoscope, positioning and suspension. We have already discussed how to do. Judicious use of hand instrument or laser as it may be in your hand. We need to attend to the extubation issues. And finally, I believe that every patient is our teacher. We learn from each patient because they all are different. And eventually, I would like to conclude by saying that surgical knowledge depends on long practice and not from speculation. So we learn from our mistakes, we learn from our experience, we learn from our complications. As you have more and more complications, more and more difficulties, you graduate to become a more complete and a safe and a confident surgeon. Thank you very much for a patient hearing on this topic. Thank you very much. We are now going to show you a few videos on vocal fold polyp surgeries. Now, before I show you the surgeries, I would like to just touch on what polyps are. This is an intraoperative picture of a vocal fold polyp, which is on the right vocal fold, mid-third. Usually, polyps are unilateral and they arise due to phonotrauma, which can be acute in the background of a ectasia or anything on the vocal fold, or chronic phonotrauma. Size, shape, and locations are variable. As you can see, polyp can be right at the anterior part, it can be right at the posterior part, it can be in the superior lip, small polyp, it can be on the superior surface of the vocal fold, it can be in the inferior lip, and sometimes there is a contralateral contact lesion also available in case of polyps. They are either sessile or pedunculated, and they have been categorized into vascular or angiomatous polyps, fibrotic or myxoid polyps. They should be differentiated from cysts or SOL. SOL is easier and straightforward because polyps are usually smooth structure and does not bleed, and there is no fungation on the surface, whereas cysts are usually intracaudal or they can be superficial cyst as well on the vocal fold, but they usually have disturbed mucosal wave on stroboscopy, and polyps usually arise from the superficial part of the lamina propria, and therefore the mucosal waves are not as much affected unless there is a surrounding mucosal congestion. So in a traditional polypectomy, what we used to do is just take a pair of scissors and cut the polyp. In the process, we did not used to have so much of good control, and therefore this usually results in a crater like this, and this crater heals with fibrosis because we do not have any control whether our instrument or dissector or scissors would go beyond the mucosal layer, beyond the intermediate lamina propria, and therefore they are likely to stimulate the fibroblast and there will be fibrosis. Once the fibrosis happens in this area, we are unlikely to get a mucosal wave, and in spite of a good surgery, we may have significant hoarseness because of lack of mucosal wave. Therefore, this concept of microflap surgery has evolved, and essentially microflap does not always translate to elevation of flap and then reposition of flap. But yes, elevation of a flap and dissecting at the layer where from the polyp or the lesion is arising. Most of the time the dissection happens in the Rinke space or the superficial lamina propria, and therefore we have a dissection and we avoid damage to the intermediate and deeper layer, which prevents stimulation of fibroblast, and therefore hopefully no scar formation. And therefore this is a case of a polyp which is on the right vocal fold, and as you can see, the medial margin of the right vocal fold is actually formed by the polyp, and here we will need to elevate a mucosal flap to go into the layer, but then again we may not be able to save. So this is the surgery of that polyp with cold steel. As you can see, microlaryngoscopically exposed polyp. It is forming the medial boundary itself of the vocal fold or the medial edge of the vocal fold, and therefore first of all what we need to do, or what we tend to do, is infiltrate much lateral to the lateral extent of the polyp, which actually balloons up the polyp, and therefore there is a space like I have told you in the previous talk. And once that is attained, we use a very sharp knife, and this is called actually mini microflap, which means we create a flap just lateral to the lesion with a very sharp knife. And now I'm taking my upward cutting scissors, which is also sharp. This not only cuts but also dissects, trying to find the plane inside, and the moment you snap a little bit more, you can actually see the superficial space of the lamina propria, which is the Rinke space, and you can see the intermediate layer of the lamina propria, which is actually the outer part or medial part of the vocal ligament. And most of the polyps and our cysts are actually dissected, or we do need to dissect them from this layer. And with a very controlled dissector, we can dissect, and we can see this is the margin of the polyp, and nicely dissected without any bleeding, without any tethering of the mucosa. and we continue to dissect after this. And now we take a pair of scissors to cut the lower or the posterior end and therefore release a little bit more of the polyp, yet remaining in the same plane as we were. It is at this stage that we have to be a little bit careful about not disturbing the lower lip of the phonation. With a little bit of patty pressure, we can identify the lower part of the mucosa of the glottis or the vocal fold. This is not actually infraglottic mucosa, but it is actually the lower lip of phonation. And therefore, the phonation actually starts at the lower lip. And so if we can preserve the lower lip, we can have a good phonation early in the postoperative period, because this is where the phonation or the cycle or the mucosal wave cycle starts. And very carefully, we resect the polyp, trying to preserve as much epithelium as we can. And there is no reason to be much worried about this epithelial loss, because this loss of epithelium usually will epithelialize very soon, because there is no tethering of the mucosa, and eventually the patients will have a very good vocal outcome and also resumption of mucosal wave. And as you can see, the last part of the polyp is being resected in a very controlled and sharp dissection with a pair of scissors. And as you can see here, that this is complete now, and the epithelial loss will, this is a post-operative, immediate 7 days post-op, and you can see the right vocal fold with a little bit of edema. And 6 weeks, you can see clearly that there is significant amount of mucosal wave, and more importantly, it is symmetrical mucosal wave, and there is no phonatory gap, and most of the time the patients will be very happy and satisfied. But this has to be followed up with a good and prolonged voice therapy, because the phonatory habit needs to be retrained to this patient, otherwise they will not have a long-term outcome. Coming to laser vocal fold polyp removal, which, as you can see, this is a case where there is an angiomatous polyp. We can see the angiomatous polyp here, and CO2 is a very good tool for, CO2 laser is a very good tool for these polyp. And as you can see that there's an angiomatous polyp here, and there are lots of feeding vessels onto the polyp, and we call them feeders. They may be drainers also, but if you believe in that philosophy, that there is a school of thought which I belong to, and we believe that if these feeding vessels can be cauterized or laserized or laser vaporized, then if these vessels are closed, the chance of recurrence of these angiomatous polyp, because they are thought to be precursors of this polyp, and therefore this is a spectra big image, and then we again inject, just like we showed you in our earlier section. There is a blanching in the whole area, and first of all we laserize this feeding vessels, which, as I said, will lead to lack of recurrence or minimizing the recurrence. And as we go further, we will keep on doing this laserizing of the feeding vessel before we embark onto the surgery proper. And as you can see, we are doing it. And finally, we come, and again, this is like a mini microflap. You go just lateral to the lesion. The advantage of laser is that the penetration is very less, because if you take a knife here, you are likely to go and penetrate one of the vessels or micro vessels, which can bleed. But with laser, we can still control it without causing much problem. And once the principle is again the same, you want to go into the rinky space, as most of these lesions are in the rinky space. And once that vocal ligament, the shiny vocal ligament is exposed, we grasp the polyp, and it is better to cut a larger area of the polyp which is forming, because after the cauterization or laser vaporization, the polyp has shrunken. So actually it was much wider and longer. So essentially it's just peeling it off with lasers and polyp being held with a pair of forceps, just like the one I showed you with the cold steel. The principle is same. Only thing with laser, we probably have a little bit more control, and the time of surgery is also reduced to some extent. So as you can see, it is nicely being peeled off, and the penetration is very low. Important thing to note that the laser tube and the cuff is protected with a wet cotton here. And once we do that, again, that is the polyp which was there. We remove the cotton patty after the laser is being kept on the off mode, and we tend to wipe with a wet cotton again, because some carbon actually forms on the laserized area, and that can form carbon granuloma, which can cause delay the epithelial lesion. And once we finish the surgery, we can see this is how it was before the surgery, at the beginning of the surgery, and this is how it looks in the end. And therefore, the patient will have to be scoped. That immediate, this is the pre-op scope, as you can see, right vocal fold polyp, angiomatous polyp. And this is just 2 weeks post-op. As you can see, mucosal waves are beginning to appear, and the mucosal gap or the phonatory gap is also closed. I will show you another larger polyp again with laser, just to show that with these angiomatous polyp, CO2 laser with a microlaryngoscopic surgery has a little bit of edge, in the sense, generally, if you want to do this surgery, this kind of a very angry looking angiomatous polyp with a pair of scissors and cold steel, it is absolutely fine to do that. But then it's at times it bleeds, and then you tend to lose your plane. So again, infiltration going much lateral to the lesion is very useful. And after infiltration, again, we use the laser beam, the Accublade system of the CO2 laser system, for making nothing but a cut like we would have done with a knife. And we can go very close, because even if there is a little bit of bleeding, we can again control the bleeding in a defocus mode. And then once we do that, we would be able to use a dissector or some instrument to find out the plane. Here, the patty will serve as a dissector, and as you can see, we are not using any instrument, and this is what is the vocal ligament. And once the vocal ligament is exposed, our dissection becomes much easier. We just peel off the polyp from the vocal ligament, and as you can see, the beam shape has been changed to a straight one now because we are working along the longitudinal axis of the vocal fold, and therefore with this newly changed straight beam, we can actually complete our surgery, again taking care not taking any unnecessary bit of mucosa, but again the same principle. The medial margin of the vocal fold here is formed by the polyp itself, and there is no question of elevating a flap and putting it back. So this epithelial loss will heal very fast usually, and generally I showed you the previous two cases that the mucosal wave returns very fast if you use proper dissection method, either with cold steel or laser. It doesn't matter. It's entirely the surgeon's choice whether you use laser or cold steel. But the principle is that you dissect it off the vocal ligament, stay away from the vocal ligament, and that's how you can get a very good result of this polyp. So essentially, polyp surgery is very simple, but we just need to abide by the principle that the surgery, and with the laser you have the advantage that little bit of what we call is dog ear, and this is what was before surgery and this is at the end of the surgery. And like other cases, I have shown you how the vocal fold heals very nicely. So I would like to conclude by saying that a sharp knife, whether it's laser or cold steel, is nothing without a sharp eye. So we must know the principle of surgery, and if we know the principle of surgery, whether we use laser, scissors, dissector, it doesn't really matter as long as we pay respect to the multi-layered structure and we do a complete excision, and we also put a lot of stress on voice care after the surgery, because these are results of chronic phonotrauma, and if you do not look after voice supervised by a qualified voice therapist, then these patients are likely to come back with a very early recurrence. With that, I would like to thank all of you for joining us today and for a patient hearing. Thank you very much.
Hello, I'm Dr. Nupur Kapoor Nerurkar, and I would like to thank the organizing team of PHONOCON 2022 and Dr. Sanjay Subaya in particular for asking me to take this video session on glottic cysts and keratosis. So I would be showing 5 videos of glottic cysts first. One would be the subepithelial mucus retention cyst, followed by an epidermoid cyst in a child, followed by a hemorrhagic cyst. And then we're going to see a short video of ligamentous cyst, where the cyst is attached onto the vocal fold ligament, followed by an open cyst. The second part of my talk, of course, would be on keratosis. So before we see the videos, actually, I would like to share this excellent classification of histopathology of glottic cysts, which was published in the year 2000. This is the Koren classification, where Schwero and Koren have classified mucus retention cysts as type A and type B. In type A, the respiratory epithelium does not have a cilia. In type B, there is cilia on the respiratory epithelium. And the epidermoid cysts have been classified by them as type C and type D. In type C, one does have the capsule of stratified squamous epithelium, but the typical keratin is not seen within the cyst. This particular picture has been taken from our publication in the Laryngoscope on an article of a 10-year study of the etiopathogenesis of cysts with a study of seromucinous glands in the vocal fold. And the type D cyst is your typical epidermoid cyst, where you've got stratified squamous epithelium capsule and the typical keratinization and keratin debris within the cyst. So what are the surgical steps of glottic subepithelial cysts? And regardless of which type of cyst it is, the steps remain more or less the same. So let's just have a quick look at these. A palpation of the cyst with a blunt palpator is essential, especially to get an idea as to the lateral extent of the cyst, where one would want to be taking the incision, what is known as the epithelial cordotomy. Whether you want to do a subepithelial infiltration with saline adrenaline or not, especially in cysts, is your surgical preference, because with the small cysts in particular, sometimes one can completely lose the margins of the cyst and the cyst may disappear. So it's a decision the surgeon has to take. Following this, incision is made just bang on the lateral edge of the cyst, which is your mini microflap incision. This could be done with the laser or, of course, cold steel instruments. And then we perform a blunt dissection of the cyst from the overlying epithelium and the cyst from the underlying bed, which is typically the superficial lamina propria, sometimes even a ligament if it's attached to the ligament. And which one you would do first is something, again, which you decide case by case, I feel, really, and we'll discuss it in the videos. And then we would almost always see anterior and posterior thick fibrotic bands, which should ideally be cut with sharp scissors or a laser, some sharp instrument. We have referred to this appearance of a cyst with the fibrotic bands as a pearl on a string, and in fact, we published it in our association journal. And then you want the ideal complete removal of the cyst. In total, of course, would be wonderful, but either way, you would want to have the entire cyst wall removed so that there is no chance of recurrence. As far as possible, you want to preserve the overlying epithelium, as much of it as is possible. So let's see a quick video first of a left subepithelial mucus retention cyst. There's a small contact lesion on the right vocal fold also. We see that there's a laser endotracheal tube in situ. This is under higher magnification now that we are seeing the cyst on the left vocal fold in the striking zone area. This is the picture with Spectra A light, with one of the light options in the SPICE camera. In this case, we are doing a subepithelial infiltration using saline adrenaline 1 in 10,000. Now we see the red light, the Henny beam of the CO2 laser, which is being used in a scanning system. So you have an acu blade, and we're making an incision just on the lateral edge of the cyst. Now, this incision, which is the epithelial cordotomy, is always made quite generously and almost always should be slightly longer than what you feel the extent of the cyst is. And now, in this case, we are separating with a blunt microflap elevator the cyst from its bed. And once we have separated it, it's lying in the superficial lamina propria, it's not attached to the ligament. We are now holding the epithelium with a crocodile forceps with my right hand, and the acu blade is being used to cut that posterior fibrotic band, which we spoke about earlier. So the cyst retracts anteriorly. So similarly, when you cut the anterior fibrotic band, the cyst retracts posteriorly. And you could do either one of the cuts first. Currently, what we see is the acu blade being used to separate the cyst from the overlying epithelium, but because the cyst has now been kind of held by the forceps, we're able to do this excision of the infraglottic epithelium effectively with the CO2 laser acu blade. Once the cyst has been completely excised, we can inspect the bed, and if there are any blood vessels, if the cyst had not come out totally and there were any suspicious areas, we could laserize it, and then we put the infraglottic epithelium back on the medial vibrating edge. And this is the final view of the left vocal fold. Whether you're going to do something about the reactive lesion on the right side is a decision you can take after palpation. Now let's move ahead to a small child, 12-year-old child, who's got a epidermoid cyst, which is a really large one of the right vocal fold. It's pretty vascular. This is the Spectra A picture showing the vascularity. We always put in subglottic patties because we know the laser cuff is not laser proof or laser safe. Now you see there's a focal pit and a complete mucosal bridge of the left vocal fold. So this patient really has the entire family, so to speak, because there's a cyst, there's a sulcus or a focal pit, and there's a mucosal bridge. Again, we're performing the epithelial cordotomy with the CO2 laser acu blade. Again, it's a very generous incision, more anterior to what you feel is the anterior extent, more posterior to what you feel is the posterior extent of the cyst. Having made this epithelial cordotomy, the blunt microflap elevator is being used to elevate the epithelium overlying the cyst. And we also very often use cotton balls, which are small cotton pledgets made into a ball soaked in saline adrenaline. And we do a lot of our dissection with these cotton balls. Of course, we never leave it in situ. So here we see the microflap elevator, which is a blunt elevator separating the overlying epithelium. Whenever there are blood vessels, as you see now, the blood vessels keep the epithelium sometimes tethered down, and they can bleed, of course, during this elevation. So we try to do as complete an elevation of the overlying epithelium as possible. And now we are cutting the anterior fibrotic band. Here, the acu blade has been made shorter. Earlier, it was 1 millimeter in length. Now it is 0.5 millimeter in length, because we're not cutting parallel to, but perpendicular to the vocal fold length because the anterior fibrotic band has to be cut effectively. And we are separating a little bit of the epithelium. Now we are separating the cyst from the bed, which is the superficial lamina propria. So you want to hold the cyst wall or some fibrotic attachment over the cyst and medially rotate it so that you get that traction, which is so useful when you're doing laser surgery because it allows for better cutting. But if you hold the cyst too tightly, then of course it would rupture the cyst. So it's a kind of tricky situation where you can use cotton balls to do the retraction like I am doing right now so that you don't rupture the cyst. So you either hold some fibrotic attachment or use cotton balls. And we got to the posterior fibrotic band now. So we're cutting the posterior fibrotic band. We're separating the rest of the cyst from the bed. There's no attachment to the ligament in this case. And once the separation has taken place, what we do is inspect the area, laserize any blood vessels if you want, and then reposit the flap so that the medial vibrating edge is covered and there's no raw area. This is the final look of the patient after surgery. We move on now to a patient who's got not only a cyst on the right vocal fold, which is a hemorrhagic, a lot of vascularity, varices over it, a little yellowish appearance, maybe because of resolving a subepithelial hemorrhage and hemosiderin, and you've got a hemorrhagic polyp on the left vocal fold also. So of course you have to operate on both the lesions. And this is again the spectra A appearance of the patient, spectra B appearance, palpation to get an idea as to the lateral extent of the cyst. You're trying to make a decision mentally as to which side you're operating on first, where your incisions or epithelial chordotomies are going to lie. Is there any sulcus? Is there any mucosal bridge associated with these particular findings? Now we're performing the subepithelial infiltration on the left vocal fold. You saw that there was no donut effect. Now what we're doing right now is we're laserizing all the feeding blood vessels, which are into the hemorrhagic polyp. So maybe there's a role in, recurrence not taking place if you've killed off the blood supply. And also during surgery, it may help you. There may be less bleeding during surgery. Excuse me. So now over here, the difference is when you're operating on a polyp, there are no anterior posterior fibrotic bands, there's no well-formed capsule. So what is our aim of surgery? The aim is to remain as superficial as possible. The aim is also to have the infraglottic epithelium at the end of surgery cover the medial vibrating edge so that there's no raw area. In this particular patient, we're going to be operating on both the sides. So you don't want any chance of an anterior glottic web formation. This is the epithelium, which is the infraglottic epithelium, which will sort of cover the medial vibrating edge. And that's what we're having a look at the infraglottic surface of the vocal fold and laserizing the varices, which are on the infraglottic surface of the vocal fold. So this is an advantage with the laser, which I think with the cold steel may be very tedious because you can laserize any of the dilated blood vessels or the feeding blood vessels that you want. Now we are starting our surgery of the right vocal fold cyst. So we're making that mini microflap incision, the epithelial chordotomy. And having done that, we're holding the epithelium with a heart shape or a Boucher forceps. With my left hand, of course, I'm holding this epithelial flap, not the cyst. And with my right hand, I'm separating the cyst from the underlying superficial lamina propria. Now, the AccuBlade is being used to cut the anterior fibrotic band. Also, we're separating the cyst from the overlying epithelium a little bit. So we're creating that niche or space anteriorly, which will allow the cyst to kind of retract posteriorly. Over here, you see a little bit of the vocal ligament. You see the vocal ligament over there, and we are doing a little bit of dissection with the cotton ball, as I mentioned earlier to you. Sometimes you can separate the cyst from the overlying epithelium with a laser, though you have to be a little careful, meticulous at this point, because of course you can rupture the cyst at this point also. And if you rupture it at this point and it's not been separated from the bed and it's a mucus retention cyst, then it could, the cyst wall can kind of just disappear in front of your eyes and become very then kind of messy because you don't know what is the cyst wall and what is the lamina propria. Here we're using a cotton ball after having cut the posterior fibrotic band. So we do a lot of this combination of using cotton balls for dissection along with the AccuBlade, along with the blunt dissector. It's only towards the end of the surgery that we tend to hold some kind of tissue which is attached onto the cyst as far as possible. So here we're teasing the cyst anteriorly, pushing it anteriorly after cutting the posterior fibrotic band. And then you can use the microflap elevator pointing upward because it can be rotated by 360 degrees. So you can use it pointing upward when you're pushing the cyst up. You can use it pointing downward when you're moving the cyst down. When you have a good control on the cyst, where you can see the separation from the bed and from the epithelium, then you're more confident that even when it ruptures or if it ruptures, you'll be able to remove it completely. Almost 30% of cysts in my hand tend to pop open. But the idea is to make sure that you have a good control over, the extent, and you know exactly where the extent is, so that even if it leaks open, as you can see anteriorly, there's gelatinous material coming out, you're still confident that you're going to be able to take it out completely because you have the margins well identified. So the advantage of separating the cyst from the bed first is that even if it opens up, it's been separated from the bed, and then you can remove it with the overlying epithelium even, because the epithelium will grow back. Unlike SLP and ligament, the epithelium does grow back. But if you lost where the cyst wall is, then the chance of the recurrence, of course, becomes much higher. So now we're holding the cyst, the remnant of the cyst, with the heart shape or Boucher forceps, and with the AccuBlade, we are separating the anterior remnant of the cyst so that we have a complete removal. We're laserizing any blood vessels which may be quite dilated. And now we're using a cotton ball to reposit the infraglottic epithelium. So this is the post-operative picture of the patient where there isn't much loss of epithelium on either side. So we'll come now to the ligamentous cyst. So there's a cyst on the right side. We don't know from before that's a ligamentous cyst. By ligamentous cyst, we mean attached onto the ligament at some particular point. We see a classical subepithelial bulge. We palpate the medial and lateral sort of extent. We always palpate to look for sulci and mucosal bridges because, as we've mentioned, that's part of a family. I like to make the incisions with the AccuBlade laser, but that doesn't mean we can't make an incision with a sickle knife and extend it maybe with an upward scissors. Definitely one can do that. One can do the entire surgery very effectively with cold instruments. It's just that I personally have become comfortable with the laser, so I'm showing you most of the steps with the laser. That's what I'm comfortable with, but one can do everything effectively with cold instruments. Having made the epithelial cordotomy, and you'll always see it made generously, if you make it very small, there's no way you're going to be able to get to the anterior and posterior fibrotic bands. And also one doesn't typically need to, at the end of surgery, glue this flap back on or suture it. It falls nicely into position because it's more like a linear cut. So we see over here, there is some bleeding posteriorly, which is taking place despite the fact that I had used a laser for the incision. And now what we see is with the hemostatic cotton pledget, we're trying to control that bleeding and also dissect out the cyst. We're cutting the posterior fibrotic band over here. And as always, you'll see the cyst sort of retract anteriorly as you cut the posterior fibrotic band, and the opposite in the other case. Again, the microflap elevator is being used to tease the cyst and push it in an upward direction. And this cyst I'm showing because now you will see the attachment of the cyst onto the ligament. So when cysts are attached, this is the anterior dissection, of course. When cysts are attached onto the ligament, then I feel there's a great advantage in using the laser because you can get a nice cut with the laser as any lesion gets a deeper and deeper extent into the vocal fold. So here you see the cyst attached exactly onto the ligament at this point, and the heli beam is cutting the cyst away from the ligament. So it's actually cutting into the ligament at that point, and we get the possibility, therefore, of the release of the cyst once it's been cut from the ligament. Now, of course, you just separate it from the rest of the attachments as always. And we see over here what we are holding is a fibrotic tissue which is attached onto the cyst, with which we are able to effectively medially pull the cyst. Because as we give more retraction during laser surgery, you're able to cut the tissues more effectively. Another point I'd like you all to appreciate is with this scanning system, it's such a char-free surgery. You haven't seen me really clean repeatedly any char. So when you're using the scanning system, the char is really minimal. So that's a great advantage when you're doing phonomicrosurgery. I think to do phonomicrosurgery with a laser system, which causes a lot of charring, is really a disservice to the patient, because you can do a much better job than just with cold steel. So it's important to use very efficient lasers. Now we reposit the epithelium back on, and that's the end of our surgery. We will now move on to the final type of cyst which I want to show you, which is the open cyst. So what we mean by an open cyst over here, we see on the left focal fold there appears to be a focal pit with epithelial debris or keratin within it, and this can be called as an open cyst. There also is a subepithelial bulge on the right vocal fold, and that also will be addressed in the surgery. So we'll see at the beginning of the surgery itself that when you take this microflap elevator, you will be able to palpate the edges of the open cyst or the focal pit. And having done that, then we are laserizing all the epithelial debris, which is within this sort of open cyst or focal pit. That was a laryngeal wash. On the right side, there was an incomplete mucosal bridge. There's a little bit of a subepithelial bulge present also, which was a fibrotic nodule. Having excised both the lesions in this particular case of open cyst, we prefer to just suture the epithelial edges. The idea is just so that because there was an open cyst, we don't want the chance of epithelial debris once again sort of filling it up. You can also use fibrin glue, but usually edge-to-edge approximation is a little better with suturing than with fibrin glue. Whenever we suture in the vocal folds, healing does take much longer, so that's something to keep in mind. And now for the second part of my talk, which is a video demonstration of surgery in the case of keratosis. So what you see on the left-hand side of your screen is histopathologically keratosis over the stratified squamous epithelium. But almost always keratosis is present with a varying degree of dysplasia. So one could have keratosis with mild to moderate dysplasia, as you see over here in this image on the right-hand side. And here on the image on the left-hand side bottom, this is keratosis with carcinoma in situ. And finally, we have over here keratosis with invasive carcinoma. Now, depending on what the histopathology is, your surgery would change because in keratosis with invasive cancer, we would do a type 2 podectomy, at least. With the carcinoma in situ, we would do a type 1. But if it's keratosis or keratosis with mild moderate dysplasia, you would just be excising the keratosis. So I'm going to take you through just one particular patient, and there I think is quite a bit to sort of discuss in this particular patient, because it's that very typical difficult scenario where you've got a patient who's got this, to begin with, it is leukoplakia till you have a diagnosis at the anterior commissure, right vocal fold, left vocal fold. So how are we going to tackle this patient? So we haven't operated, so we don't know if it's keratosis. That's a histopathological diagnosis. Stroboscopy shows us that the mucosal wave on the left vocal fold is much better than on the right vocal fold. So we do have the information that we have a better mucosal wave on the left vocal fold. We can see that the leukoplakia appears to be thin on the left vocal fold. So the surgical plan that we made for this particular patient is we are going to do a stage surgery where we're going to operate on the right vocal fold first, and then after at least a gap of 6 weeks, go to the left side. So let's go to the surgery of the right vocal fold as we planned. So this is under anesthesia, of course. We see here with the spectra A light, we're doing a palpation to see, and the right vocal fold is firm in appearance. And we're trying to kind of get an idea of the infraglottic extension of the keratosis, and also palpate the left vocal fold to see how firm is that. So as I mentioned earlier, our decision is to operate on the right vocal fold. We're performing now a subepithelial infiltration with 1 in 10,000 saline adrenaline. So many advantages in this particular patient to do this. You get an idea as to whether you have a donut effect or not. You have an idea, you have an increase in the SLP, so it works as a buffer when you're using the laser. Of course, hemostasis, you can get a bit of medialization. Now we are using, once again, the CO2 laser with the scanning system. So you see the AccuBlade is being used to excise just this leukoplakia first. So our plan is to remove the disease, which we see under magnification, to remove the leukoplakia, and we send it for frozen histopathology. We have already counseled the patient, and the patient has agreed and consented to the fact that depending on what the frozen histopathology tells us, we can make a decision as to what kind of margins we want to remove for this particular patient. For example, if the frozen is just keratosis with no dysplasia, or with mild moderate dysplasia, we're just going to be removing whatever appears to be the abnormal pathology. However, if there was a carcinoma in situ, we would plan to do type 1 cordectomy and so forth. So like I mentioned earlier, we use a lot of these cotton balls soaked in hemostatic solution, which is the same 1 in 10,000 saline adrenaline, which we use when we are doing the infiltration. And not only does this provide for hemostasis, it allows for good retraction without breaking the tissue which you're holding, which is what was happening when I was using the Boucher forceps. So at all times over here, I'm keeping the ligament under view. The leukoplakia or the pathology is not infiltrating the ligament. And we had an indication of that with the infiltration itself, and the whole lesion came up without a donut sign. And this particular patient, we are using a didolaryngoscope to get, because it was a difficult exposure, and seeing the anterior commissure was a little bit challenging. But you do realize in these patients, after about 20 minutes of general anesthesia and the pressure over the cricothyroid membrane with a bandage, there is a little bit of laryngeal drop which takes place, and the exposure does with time definitely improve. So there is prudence in being patient. So as you're progressing with the surgery, in these cases, always start obviously from posteriorly till you get a better and better exposure possibly of the anterior commissure. And of course, sometimes you may want to withdraw the scope a little bit, bring it to the false vocal fold level, and give more pressure possible to get out the most anterior most pathology also, which is happening as we speak. Repositioning the scope and, giving more pressures, and then also holding the tissue and pulling it downward, sometimes using a cotton ball to pull it downward so that we can get a better exposure of the anterior attachment and the anterior pathology. So we send that large bit of tissue for frozen, and typically in our institute, it takes us about 20 minutes to get a report of the frozen histopathology. We have an accuracy of about 95%, which matches, I think, with most international standards. Now, in this particular patient, the histopathology was with carcinoma in situ. In which case, then one wants to do is with the laser itself, laserize the superficial lamina propria and go as anterior as posterior so that you can achieve a classical sort of type 1 corticectomy. You also want about 1 millimeter margins in the periphery to be excised. So it's important not to forget about that infraglottic epithelium when we are operating, because you need to take margins all around, not only the superior one, which is easy to see. In this particular patient, the depth would not be the ligament, it's just the superficial lamina propria. So you take the Henny beam and you're sort of just laserizing all the SLP. Of course, we know superficial lamina propria is not going to grow back. It has a very poor propensity to regenerate. But when a patient does have a carcinoma in situ, you have to be that aggressive. So we do typically wait for 4 to 6 weeks and try to get the best possible healing of the right vocal fold before we move into the left vocal fold. Here, what we are laserizing, as I mentioned to you earlier, were the peripheral margins. But there is another way also to approach such a patient. One could operate on both the right and the left vocal folds, in which case, unless you did something about it, you would land up with a big web. So what can one do about it is take the patient up under general anesthesia after 7 to 10 days and clean all the slough which is developing at the anterior commissure. And you may have to do this once or twice or even thrice so that the web does not develop, or at least it's a very small web. That would be the second way of tackling it. I don't think anyone would really think of excising both the side lesions and putting a keel in this kind of a patient, because you want good healing. And sometimes when you're introducing a foreign body like a keel, then that itself may cause the formation of polyps, etc. So I would definitely choose one of these two options. Either operate only on one side first and then the second side, which is the stage surgery, which is what we do, or operate on both sides, but then keep cleaning the slough. This is a laryngeal wash, which we're giving at the end of surgery. We do that almost always to clean any char or cotton fibrils, because we use so much of that cotton. And now I'd like to share with you how this patient appeared a month after surgery. And though we had in our eyes removed the entire right vocal fold keratosis with the margins, because it was keratosis with CNC2, we saw that there was a keratotic horn present at the right vocal fold near the anterior commissure, besides the left vocal fold lesion, which we had anyway left for a second sitting, which kind of confused things a bit for us, because now are we going to go in and operate only on the left side, or also only operate on this keratotic horn on the right side, or operate on both the sides? So we did take the patient up for surgery after about 2 months of the first surgery. And we had already sort of in detail counseled and discussed with the patient that we'd first remove the right keratotic horn, which you can see, but just with a sort of cold steel and very superficially. And we sent that in first for frozen. It was large enough a piece, thankfully, to get a frozen report, which was just plain keratosis. Here we are palpating the left vocal fold and also palpating the right vocal fold to see, how much is the scarring, etc. We're seeing that the infraglottic disease actually on the left vocal fold is thicker and more than the disease on the superior surface. Sometimes it's difficult to evaluate the infraglottic disease with stroboscopy. So now, once again, we are performing a subepithelial infiltration of the left vocal fold. The entire leukoplakic lesion is coming up. We're also performing an infiltration anteriorly of the right vocal fold. As I mentioned to you, we make a decision to remove that keratotic horn with just cold steel and stay very superficially. And we did get a frozen saying that this had no dysplasia in it. So following that, we operate on the left vocal fold, and we've discussed with the patient that if there is a web formation or too much slough at the anterior commissure, we clean that slough off with the saline patties 7 to 10 days after surgery. When you use the Spectra A light during surgery, it's very interesting because you can get a sort of idea of the vascularity of the lesion and the type of vessels and whether there is any intraepithelial papillary capillary loop pattern. What happens is the red light of the Henny beam, of course, becomes a white light because it's becomes transparent because now you're using a blue and green light only. But that's only the image on the monitor, which you're seeing through the microscope. You still see the red light. Here, once again, we are elevating the leukoplakic lesion with a microflap elevator away from the superficial lamina propria. As compared to the right vocal fold surgery, this does seem to be more superficial. The lamina propria seems to be healthier. So we are trying to stay as superficial as we can. We excise this strip of, I'll call it leukoplakia for now, because we haven't sent it for pathology and we send it for frozen. And on this left vocal fold, the lesion, the frozen report comes back as a keratosis with mild dysplasia, which kind of fits in with the stroboscopy picture also, where there was a better mucosal wave. Now, this is the lesion which is present more on the infraglottic epithelium. And in this particular case, we're using cold steel to perform not only the cut, but also the dissection in the SLP. So we're elevating, sort of dissecting and cutting with sharp scissors pointing to the right-hand side. And then we are using the CO2 laser to laserize abnormal looking epithelium and blood vessels on the infraglottic epithelium and now near the anterior commissure. So one can have a combination of instruments if they are at your disposal. You can use laser, you can use scissors. In the case of papilloma, you can use microdebriders. So laryngology is very instrument heavy speciality, of course. This is laser ablation and not laser excision, which is being performed currently, where we're just ablating the lesion. So we're not going to be sending this pathology, obviously, for any kind of histopathology. And once again, we can keep using the Spectra A as and when we want to during surgery. If you have any doubt as to where the thin leukoplakia still exists or does not exist, and if you want to be checking for any kind of papillary capillary loop patterns, I'm going to move this along a little bit. So finally, we put the didolaryngoscope in again because we want to make sure that we have removed as much of the anterior commissure disease and we don't have any surprise leukoplakia or keratosis during postoperative stroboscopy. So we do as effective a clearance or laserization as possible of the anterior commissure. You can see that the dido is placed at the level more or less of the false vocal folds. And what I would like to share with you then is the postoperative stroboscopy of this patient, because I was quite sufficiently confident that we've taken out all the disease. So when we see the patient 2 weeks later, it's interesting, good mucosal waves on both the vocal folds, good healing, but we've got keratotic lesion at the anterior commissure again, on the right side and the left side. Very frustrating situation. Was it left behind during surgery? Did it just recur so quickly? There's also a very tiny sort of hemorrhagic polyp or varix on the left vocal fold. It's frustrating when you see this, but this is the truth with keratosis. It keeps coming back. And I think it's important to counsel the patients that this is a disease they should expect to see coming back again and again. So almost like how you'd counsel a papilloma patient. So we did treat the patient just with conservative measures because the voice was good. The histopathology we had already taken care of, and we knew that, the left side was not carcinoma in situ. And so we gave hydration, increased hydration. We also did start some steam. We gave proton pump inhibitors and alginate and relaxation therapy to the patient. And it's quite interesting because sometimes we don't know what are the healing factors at play, because within a month, the keratotic lesion of the anterior commissure just disappeared. I haven't done any surgery whatsoever. So in healing, I think there are so many factors at play. There are the healing factors post-operatively at play, and then there's the body itself with a combination of elements which decides how to heal. So I think the learning lessons with keratosis is that, first of all, histopathology needs to decide the type of surgery that you are going to perform. I don't think we should ever be shy to stage surgery or to keep going in again to make sure we do a good job with the best vocal outcomes, no web formation, and not very bad scarring. But we need to tell the patient that there is an unpredictability related to keratosis as far as the recurrence and resolution is concerned. They should know that upfront, so that it doesn't become a nuisance to explain to them post-operatively. So I counsel the patients in the beginning, almost like the way I would counsel a papilloma patient. And of course, we try to use collaborative tools of narrowband imaging, stroboscopy, spectra, frozen, subepithelial technique, magnification, all to help you in making decisions, really. But at the end of the day, it is the long-term follow-up which is extremely important in terms of managing patients of keratosis. And with that, I'd like to thank you for giving me this opportunity to take a talk.
Hello everyone, I'm Dr. Anaka Joshi, and first and foremost, I would like to congratulate the organizers of this wonderful workshop, and thank you for inviting me to this PHONOCON 2022. So I'll be speaking on injection laryngoplasty. Vocal fold injections can be deep vocal fold injections, which are actually called as injection laryngoplasty, where the biomaterials are injected into the lateral aspect of the thyroarytenoid muscle. This way, or superficial vocal fold injections, where the biomaterials are injected into the subepithelial space. Injection laryngoplasty basically is done for glottal insufficiency. That is, when there is a significant glottal gap or insufficient closure of the vocal folds, and patients typically suffer from a weak or breathy voice due to the escape of air through this glottal opening. So the indications for injection laryngoplasty could be vocal fold immobility, that is primarily vocal fold paralysis or paresis, where the patient has dysphonia or aspiration, vocal fatigue, sometimes complete aphonia in severe cases. It can also be done for vocal fold atrophy or soft tissue deficiency due to either denervation, whether in case of vocal fold paralysis or paresis, or in presbylarynges, that is age-related changes where there is a spindle-shaped glottic gap, or vocal fold scars or sulcus vocalis, as we've seen in this case. The patient here presents with dysphonia, which is more of roughness as well as breathiness. On cases of tissue loss, in cases of ablation, ablative or destructive vocal fold procedures. Sometimes you have done a thyroplasty, type 1 thyroplasty, but there is still a glottis glottic insufficiency, this can be augmented by injection laryngoplasty. So in cases of vocal fold immobility, you can start with voice therapy. There are also temporary procedures, that is injection laryngoplasty, or you can do permanent procedures, that is injection laryngoplasty with permanent materials or laryngeal framework surgery. So when you have unilateral vocal fold paralysis, and if the patient presents early, if the patient has aspiration or desires to have a better voice or voice restoration, or is a voice professional, you will do injection laryngoplasty with temporary biomaterials. But if the patient does not have any aspiration or does not have any dysphonia or does not desire or refuses for any early medialization procedures, then you can opt the patient or give the patient voice therapy for at least 3 months. If there is no improvement despite voice therapy for 3 months, you can offer the patient type 1 thyroplasty with or without arytenoid rotation. But if the patient presents to you late, that is, say 6 months to more than a year, or in spite of optimum speech therapy, there is no improvement, or the temporary medialization has worn off, or patient has reversal of the improvement that he has seen after temporary medialization, you would do type 1 thyroplasty with or without arytenoid reduction. What are the advantages of early medialization? So you definitely have an improved ability to cough, as well as there is absence of aspiration immediately on injection laryngoplasty. There is improved speech and voice, especially in cases of voice professionals who require immediate restoration of their voices. Patient can enjoy the rehabilitation with an improved vocal function while still waiting for any recovery to happen. Also, what tends to happen is that the arytenoid slides down over the cricoid, and so they are in a much lateral and lower position. So this gives a suboptimal results when you do a thyroplasty later on. This sagging of the arytenoids is prevented when you do an early medialization procedure. Also, it allows for the vocal fold to be in a more medial position, that is medial position during the synkinetic reinnervation. It can also prevent reversible, the poorly reversible compensatory hyperfunction that may happen. There is many of the reports, publications have mentioned that there is a reduced need for permanent medialization in patients in whom you injected early, that is within 6 months of the paralysis, as compared to those who have received the injection 6 months or more after the onset of unilateral vocal fold paralysis. So let us see the technique of injection laryngoplasty. Where do I actually inject? So if you draw a horizontal line at the tip of the anterior tip of the vocal process, and another line at the level of that is over subarcuate line, you have to inject just lateral and anterior to the intersection of these two lines. Another injection can be given in the membranous vocal fold along the superior arcuate line. This injection should be at a depth of 3.3 to 5 millimeter. Injection into the ring case space is to be avoided, and 15 to 30% of overcorrection is always recommended. Topical anesthesia can be given in the form of 4% lignocaine nebulization, or you can give what is called as a laryngeal gargle. That is, you drip 4% lignocaine over the larynx while the patient is phonating. So this can be either dripped by an abdomen cannula or a curved laryngeal curved suction tip And the assistant provides with the dynamic exposure with the fiber optic laryngoscope. So I prefer the thyrohyoid method, that is the transcutaneous thyrohyoid method. So in this, first of all, you mark the various points on the neck, that is the thyroid notch, the lower border of the thyroid cartilage, cricoid cartilage, and the cricoid cartilage and the hyoid bone. Once this is marked, the preloaded syringe is taken. A 25 gauge needle is bent at two places, at 45 degrees, once at the hub, and another 45 degrees again at around 1.5 centimeters from the tip of the needle. So effectively, the tip of the needle is now at right angles to the syringe. When this is done, the needle is inserted at the thyroid notch, just above the thyroid notch, and the needle tip you'll see emerging through the petiole of the epiglottis. So you can see the needle has emerged and you inject into the exact spot where you want to inject. So that is the beauty of this procedure, is that you can localize exactly where you want to inject, and you can without any hindrance in the visualization. You can see that the vocal fold has started pumping up. And this is, if there is a very large glottic gap, patient may need another 1 cc of injection. But generally 1 ml of the injectable material is sufficient enough for medialization. So that's the thyroid notch we inject. So this was a patient with vocal fold paralysis. As you can see, that there is a very large glottic gap, and this is her laryngoscopic picture after injection. You can see that there is complete closure of the phonatory gap. This was a voice.
शकुंतला जैन 6 महीने से तकलीफ है 1 2 3 4 5 6 7 8 9 10 11 12 13
And this is the voice immediately
मेरा
after.
नाम शकुंतला है 1 2 3 4 5 6 7 8 9 10 11 12 13 14 15 16 17.
You can see that this is a complete restoration and improvement of the voice immediately on table. There are other approaches for injection laryngoplasty. That is a transthyroid cartilage approach, that is you inject or pierce through the thyroid cartilage. It's a very effective procedure. Also, it can prevent, especially during the COVID time, to prevent any aerosolization, which will be there in the other procedures. So needle is passed through the thyroid cartilage at the level of the vocal fold, and you can see the movement of the needle at the site by looking through the fiber optic laryngoscope. Sometimes when in elderly patients, it is difficult to penetrate through the thyroid cartilage, especially when it is ossified. The cricoid thyroid technique, where the needle is pierced from underneath the lower border of the thyroid cartilage, and it is inserted upwards and laterally into the thyroid muscle. The disadvantage of this technique is that you cannot see the tip of the needle. It completely goes submucosally. And then there is a transoral approach, where the patient protrudes its tongue out, and a specially designed cannula is required, and under fiber optic guidance, you can inject into the inject for medialization. The problem with this technique is that you need more of the injectable material because the cannula is longer. So you need more of the material, and sometimes it's very cumbersome for the patient. If the patient is really not cooperative, then you can do a transoral laryngoscopic method. But the patient has to be taken under general anesthesia. Of course, it's easy to perform because you have a very good exposure, but the amount of medialization which is required cannot be judged because the patient is under anesthesia. And more material is required because it will occupy the entire length of the cannula. Advantages and disadvantages of the thyrohyoid approach, which I prefer, is basically it combines the percutaneous approach with the direct visualization of the needle placement within the lumen. The trajectory is easily reproducible in patients with favorable anatomy, and you have a precise localization and visualization of the needle tip, and so you can optimally control the amount of injectable material. Now, there are various kinds of injectable materials. So some are temporary, some are long-lasting. So amongst the temporary injectable materials, the preferred is the hyaluronic acid, which comes in the trade name of Restylane or Hyloform or Juvederm. The longer-lasting injection substances, the preferred material is autologous fat. Teflon is, of course, out of question because it causes Teflon granuloma and it's no longer used. Radius is not available with us, so what is preferred is the autologous fat. The advantages of hyaluronic acid is just excellent biocompatibility. It can be injected through a very small needle, or even a 25 gauge needle is enough for injecting it. It can be used as an office procedure, and it most closely matches with the viscoelastic properties of the true vocal folds. There is no granuloma formation, and there's hardly any migration at the injected site. Does not require any allergen testing, which may before any administration, as against other materials like bovine collagen or the collagen materials. And there are hyaluronic acid is also available in a larger particle size, which is more durable than the smaller particle size. So it can persist from say as long as 6 months or longer as well. Now, the temporary injection material and hyaluronic acid is basically used for cases with focal fold paralysis. But what do we do for patients with sulcus vocalis or scarring or presbyopia? In such cases, you require bilateral injection. There is no chance of spontaneous recovery. Hence, you need some material which will last for a longer time. There is many a times, especially in scarring and sulcus, there is loss of superficial lamina propria, as well as a phonatory gap. So not only do you want to close the phonatory gap, you want to also reconstruct the superficial lamina propria. So the preferred technique for this is fat augmentation with fat injection, laryngoplasty of the vocal folds. So fat injection laryngoplasty, the technique is different than injection laryngoplasty for hyaluronic acid. First, we'll learn how to harvest the autologous fat. So there are various methods to do that as well. So you can either aspirate the fat by liposuction, or you can excise the fat and dice it into small, very small, tiny, mince it into small, tiny pieces, or excise and implant it. This is especially done in sulcus cases. So actually, fat is where in such a scenario, the fat is more viable than when you do it by injection or by liposuction. So liposuction, you can either use the abdominal fat or you can use thigh fat. So the injection, the liposuction needle is used and a steady suction is applied to the syringe, and the fat is harvested. Once the fat is harvested, you need to separate the various layers of fat and the serum and blood. So either you can place it for some period of time, or you can separate the various layers by a handheld centrifuge. Once it is separated, then it's loaded in syringes. For excision and dicing, the fat is obtained from the lower abdomen just below the umbilicus, and around say 2-3 centimeter of fat is taken and it is minced into very tiny pieces, either using scissors or knife, and fat is then thoroughly mixed with and rinsed with vinegar lactate solution to separate the remaining blood and the fatty acid and cellular debris, and then it is loaded into syringes. Either you can use a pruning syringe, or you can attach a scalp pin over your normal syringe. And you generally need a 18-gauge scalp pin because the fat is cannot be injected through a very thin needle. So fat is first injected into the middle third of the vocal fold at a depth of 1 to 2 millimeter, and also another injection is made at the vocal process. So this will expose the larynx with a microlaryngoscope. In this case, I'm using an 18-gauge scalp pin. You hold the scalp pin with the forceps and you inject into the middle third. You always over inject so that the vocal fold absolutely comes to the midline, or it can even cross the midline. There is no fear of stridor as long as at least one vocal fold can be abducted. So overcorrection is required by almost 50% because, as you know, fat tends to get absorbed. This was the case of sulcus vocalis, where fat is injected not only to augment the vocal fold, but also to even out the sulcus. So there is no harm if the fat goes into the subepithelial or the rhinge space also. So this was the case of sulcus vocalis, where you can see on vocal voice analysis, there is improvement in all the parameters. The voice is typically hoarse, very high pitched. This after injecting fat. Advantage of fat laryngoplasty is that it has excellent biocompatibility. It's inexpressive of, you have ample amount of fat in every individual. It's obtained easily in ample quantity, most similar in viscosity to the lamina propria, and although 30 to 40% is absorbed, but what remains is going to be permanent. Hence, overcorrection is required. It does not disturb the vocal fold vibration, and even when injected into the superficial layer, lamina propria. There are certain disadvantages. That one we have already discussed, is that there is a risk of reabsorption. The degree of absorption cannot be predicted. So you cannot predict what would be your outcome or how much of fat would be reabsorbed. And it requires a longer time for harvesting. There is a need for general anesthesia and a need for a skin incision, or if you are harvesting by implantation. It cannot be injected transcutaneously because you require a very thick bone needle, and hence general anesthesia is required. It is feasible for glottic gap of up to 33 millimeter, and after which the insufficiency becomes very difficult to correct. So you cannot inject fat for a very larger glottic gap. Now, which injectable should I use? You have a variety of injectable materials, right from hyaluronic acid that we've seen, Teflon, which is no longer used. So let us white it out. Then you have gel foam, which lasts for just 1 month or 1.5 months. Bovine collagen, autologous collagen, Symetra, calcium hydroxyapatite, and carboxymethyl cellulose, they are not available here in India. So what we have for temporary, we have the hyaluronic acid, which is an excellent injection for temporary medialization. as we have seen, it has very good compatibility, and it lasts, the effect lasts for at least 3 months, but it can last for 6 months to a year also. And you have PAT, which is permanent, and it has excellent biocompatibility, and we have already seen its advantages. So fat and hyaluronic acid could be the preferred injecting materials. Are there any contraindications for injection laryngoplasty? If you have fixed arytenoids, that is where there is the glottic chink is limited, or if there is severe scarring, it's very difficult to medialize those vocal folds. If there is excessive hyperfunction or a very high degree of phonatory gap, which is more than 3 millimeters. Injection laryngoplasty advantages will be, yes, it's very cost effective, minimally invasive. It can be done transorally or percutaneously, can be done under local anesthesia, hence can be performed in patients with comorbidities as well. So as a patient can be injected as soon as the next day of surgery, even with patients with severe cardiac comorbidities. Can be done as an office procedure. It's temporary due to absorption of the injected material, and hence it can very well work as a trial before you think of doing permanent external medialization procedures. You can always re-inject if required. So take-home message would be early medialization immediately restores the patient's voice and all the swallowing problems while still allowing for spontaneous recovery of function. Injection laryngoplasty is a minimally invasive procedure and can be carried out as an OPD procedure as well. Transcutaneous procedures, and especially transthyrohyoid, which I prefer, gives excellent visualization and precision, and all transcutaneous approaches are well tolerated. Hyaluronic acid is a preferred material for temporary medialization, and fat for permanent medialization, especially in cases of sulcus or scarring, repressed diaphragm, where bilateral medialization is required. Fat can be as an excellent graft or injectable biomaterial with excellent biocompatibility. Although 30 to 40% is absorbed, but what remains is permanent, and hence overcorrection is required. Thank you so much. Thank you so much. Thank you so much.
Good evening. Greetings to all. It is very nice to be in PHONOCON once again. It's almost 20 years since this has been going on. Today, I have been asked to show a video of Kashima procedure. You know, abductor cord paralysis is a very common problem, sometimes misdiagnosed. Some of these children are treated as asthma, but once a ENT surgeon or a laryngologist does a fiber optic laryngoscopy, we are able to diagnose them. Now, first, let me tell you about this patient. In between, we can elaborate the discussion. This is a case of bilateral abductor cord paralysis. For more than 6 months, there has not been any recovery, and patient has a mild to moderate stridor. So if you see, you are seeing a laryngoscopic view, you are seeing this catheter. So most of our laryngeal surgeries for last 3.5 years, we are using jet ventilation. We got Icutonics jet ventilator, and this really gives you the space. You have the full airway for yourself. Except when there is some chest condition or any other contraindication for jet, you are able to work with the jet. Especially in lesions like, say, laryngeal papillomas, where you need the airway is very scanty and you need the full airway. A tube is very cumbersome. Tube blocks a lot of things. and you have to change. Now here, what we are doing is a Kashima procedure, which is a disjunction of the vocal process to the vocal cord. We've started with the carbon dioxide luminous laser beam. You can see this beam, our laser has a echo blade and a scanner. And we have started, palpated the vocal process of the arytenoid and started going laterally. The power setting is normally about 10 watts. We like to keep it in the repeat mode. And there is a smoke evacuator in the laryngoscope. Hand also, you can use a small suction for retraction also. Now, as the cutting goes on, see, from time historical, abductor cord paralysis has seen a lot of surgeries, different variety of surgeries. Initially, external retinoidectomies were being done. Then there were suture lateralizations, which were also fairly common. But today, whosoever has a laser does a laser, either Kashima procedure or a Kashima with a partial retinoidectomy. It is a fairly simple procedure, consistent results, and no external scar. And you can do bilateral procedure also. This patient, in fact, we are going to do a bilateral procedure. So as we do a disjunction of the cord and the vocal process, you see the cord getting retracted anteriorly. This is a small patty which is being used to give traction and also to remove the char. Any laser surgery, there is always formation of some good amount of char, which should be removed. Otherwise, char is inflammable and you can have fire and all. And as you know, during laser surgery, the FiO2 is less than 30 and there is no nitrous being used. Remember, with jet, sometimes there is some excursion of the vocal cords. So you have to get used to working with jet. Here, it doesn't matter much, but if you are doing things like polyps or things on the vibratory edge, surgeries on the vibratory edge, then there may be a bit of a difference. So slowly. Now the commonest mistake is to stop here. You think the Kashima is complete when you just given a lateral cut on the true cord. No, Kashima is not complete. In fact, what we do is we give a cut on the false cord also. So it gives you a bigger three-dimensional aperture. And especially if you are just doing one side. And sometimes on both sides also, in this case, we are going to give the false cord cut on both the sides. Now this area, you will have the vocal process. So if you have planned not to do a partial retinoidectomy, avoid exposing the vocal process. Because wherever there is exposed cartilage, there will be healing with granulations. And once the granulations form, it takes a few laryngoscopies, few other sittings. So you can see the beam. Now, this is the false cord incision being extended. You see the posterior, this is a laryngoscope which focuses posteriorly. Good to have either a Klein-Sasser one, which is jet black, or something which is wide and gives you a good exposure. Now, we go more laterally. Now here, your question will be, what is the lateral limit of this incision? So the lateral limit is the thyroid cartilage, or till a vessel comes. There is a very consistent vessel which comes and starts bleeding. It will come here also. And as soon as it starts bleeding, you know, you've almost reached the lateral limit. And this vessel can't be coagulated with laser. You need a Bouvier cautery. So always in any laser laryngeal surgery, we have a bovie cautery with us. And you see the slight bit of bleed has started. And we now expect the bleed to become more. So now see the bleed. So don't worry, just put in a patty, wait for a few seconds, and then we need to use a bovie to coagulate this. The other slight disadvantage of the jet is there is no, unlike endotracheal tube, there is no cuff. So you have to learn to work without a cuff and do adequate suction. Though seldom we've had a problem. So you see what happens is sometimes the vessel gets cut and gets retracted. So you have to struggle to catch or coagulate both the ends. So here we have been able to coagulate at least one end, the other is still there. Yeah, so that also gets coagulated. This is almost an unedited video. As I was told by the organizing team that unedited videos. So let us see, sometimes you to struggle, spend about 1-2 minutes. I have not edited the bleeding. I could have just shown the last clip, but just to show, sometimes you have to struggle. And we've cauterized, still some part is bleeding, so no problem. So what actually happens is, it is easier to coagulate this with the endoscope. So you may have to shift from the microscope, which you were using while using the laser, and shift to the endoscope for some time just to coagulate. Now, if we were to combine, say, partial arytenoidectomy with this, we will go slightly posteriorly. The trick there is to preserve as much mucosa as you can. You don't try to leave any part of the exposed cartilage. So with experience, you can learn to give laryngeal sutures also and cover the mucosa. Even if you don't or are not able to give the laryngeal sutures, you can just drape the mucosa. You lift a flap, take out the cartilage. You can lift a flap using the laser also, elevate the mucosa, take out the part of the cartilage and put it back. So that way it is fairly helpful, but only vocal process needs to be taken out. Now, another common mistake sometimes is, especially if you are doing the partial arytenoidectomy, we tend to use the laser beam in the say interarytenoid area. Don't do that. You will cause posterior glottic stenosis. So the cut has to be very clear. First, disjunction of the vocal process. If you're doing the false chord, then go to the false chord. Go laterally till the thyroid cartilage. Don't go in this direction. The mistake is here, and a Lindholm chord retractor is sometimes fairly helpful. It stretches the cords, gives you more space to use the laser, and the cutting is much better. So here we start the second side. Here also we've decided we do both the true and the false cord. Now, some lasers have suction evacuators. They are also useful, but probably the most practical way is have your laryngoscope, have a laryngoscope for laser with a suction evacuator. Some evacuators come with a laser machine, but far easier to use one with a built-in laryngoscope. Otherwise, you have to have an assistant who's there continuously holding a suction. Now you see what length of the laser beam. Now length, normally we will keep about 2.5 to 3. It is better to keep slightly longer. And layer by layer, in the repeat mode, the caudal tissue, the false cord, are being cut. Now, why is this? Now, the other question is this always a permanent procedure? Yes, it is. So you only do this procedure if you are sure the cord function will not come back. In adults, you can wait till 6 months, slightly longer in children, maybe up till a year. If you want to do a temporary procedure, what I will prefer is a suture lateralization. And in suture lateralization also, sometimes you can do a permanent procedure by giving a cut along the length of the cord and then doing the suture. And for doing suture lateralization, there are several techniques, including putting into spinal needles above, railroading a thread through that and tying. Or if you have Lichtenberger needle carrier, that's a very useful instrument, which was developed by Professor Lichtenberger. And advantage is you are able to put the threads from inside the larynx and tie outside. So the knot comes outside. So here we see we are progressing. Cord disjunction has already been done. And now onto the false cord. So in children, there are several interesting procedures which have come for umbilical cord paralysis, including a posterior cricoid split. Now, there are several series in Europe and West where they do a posterior cricoid split, which is fairly logical, and people have got good results, consistent results. But my take is anybody with a laser should preferably do these procedures only. So we continue going laterally. Now true cord is already been the transverse incision given. We are going on to the false cord.
No.
Yeah, Dr. Jayakumar, I can. Yeah. So now going laterally. Now there's a breeder which has come again. So we will struggle again on this side also. No problem. Seeing real-time complications makes you better. So again, here also I have not edited the bleeding portion. You use a suction to press and then use a Bouvier cautery. I have seen a few laryngologists use clips also. They use clips for this sort of a thing. I've seen them use clips for mucosal flaps. If you raise mucosal flaps, do a submucosal dissection maybe of cartilage or tissues, and then you use clips. You need a longer clip applicator, but it works fine. But my question has always been, what happens to those clips? And their explanation is that they don't do any harm. They don't do any damage. So you can see our adequate chink is coming in picture. Because if you do unilateral, especially without the incision on Lindholm cord retractor being applied, to further give a better view, and here I'm doing it to stop the bleeding. There is some bleeding which has happened for some time. So if you do one side, the chances of symptoms coming back are about 15 to 20%. So it's a sure shot if you do both the sides. Only problem is initially there may be some aspiration, coughing, if not frank aspiration, some coughing. So patient has to be counseled in the pre-op regarding that, and also swallow therapy. So here we stop the bleeding. Now you can see the aperture. I think it is fairly clear. It's a reasonable aperture, and this is a patient done about 6 months back, and we did not have a problem with her. And as everything is a disjunction posteriorly, vocal process and vocal cord, the vibrating edge is fairly all right. So voice change will be there, but it is negligible. What I tell my patients is, if normal voice is 10, you expect around 7 or to 8 after abductor cord paralysis surgery, especially the Kashima procedure. And our choice of any procedure in Kashima is, in abductor cord paralysis, is Kashima with or without partial arytenoidectomy, unless it is a temporary paralysis where we will do suture lateralization, or in case it's a failed Kashima, but that has really happened. Maybe one case where we had to resort to external arytenoidectomy. Otherwise, this is a failed. So I will stop here. Thank you very much.
I am Dr. Phanindra Kumar. I would like to speak on the thyroplasty type 1. Thyroplasty type 1 is a surgical technique for medialization of vocal fold designed primarily for correction of glottic insufficiency and for restoration of voice. It was described for the first time by Professor Ishiki from Japan, and later it was popularized in the United States as medialization laryngoplasty by Professor Hoffman and Professor Isaacson. There are several implants are used in thyroplasty type 1, but the commonest implant is silicone because of its easy availability and easy to carve and low cost. So all these factors made it the commonest implant used in thyroplasty type 1. What are the indications for thyroplasty type 1? Or the commonest indication is a paralytic dysphonia, that is glottic insufficiency due to unilateral vocal fold paralysis. Sometimes it is combined with another technique called arytenoid adduction technique. The other indications are presbyphonia, vocal atrophy, and sulcus vocalis, and sometimes post-surgical glottal defects. The anesthesia commonly and most commonly is the local anesthesia, rarely under general anesthesia. The advantage of local anesthesia is the voice can be monitored during the surgical procedure on the operating table. Now, what are the steps? Now, let us look at the position of the patient during the this TheraPlast type 1. The position of patient is supine with the head in neutral position and no extension and no flexion, because it may alter the voice while monitoring the voice on the operating table. Now, coming to the important steps of TheraPlast type 1, the following steps are followed. Number 1, marking of the TheraPlast window and making a TheraPlast window. 2, opening of the TheraPlast window. 3, proper fixation of the silicone implant in the TheraPlast window. Fourth one is monitoring the voice by speaking to the patient and by doing what is called the maximum phonation duration techniques, and also by observing the vocal folds by flexible laryngoscopy. Actually, the successful operation of the TheraPlast type 1 depends upon exactly how we make the TheraPlast window and also how we fix the silicone implant in the TheraPlast window. Now, before going actually for surgical procedure, I would like to demonstrate you on a goat larynx about how you can make or mark and make a TheraPlast window. Let us proceed.
How to mark the TheraPlast window? That is very important. So for that, usually you take a ruler measure the distance from superior thyroid notch to inferior thyroid notch. About 30 millimeters. So have note that take half distance, then you take landmark either from superior thyroid notch or from inferior thyroid notch. You can see now, I am putting this again, this very important landmark here. So I made a marking here. This is the midline mark, that is, I measured the distance of 15 millimeters from the inferior thyroid notch to the center of the thyroid lamina, and then coming posteriorly made another marking here, that is 5 millimeters here. I come back posteriorly. This is very important, because this is important because so you have to make, if you go above this level anteriorly, you will injure the Broyles ligament and it will damage the vocal fold. So to avoid that, we have come back 5 millimeters posteriorly. So we have made this very important. Now again, so from this point, see this is inferior border. You can see this is inferior border. First in inferior border, and this is the anterior landmark. I have made it out. So again, you have taken half the distance from the inferior border to this marking. So that means how much it will come? 7.5 millimeters. We have got 15 millimeters from here to here, from thyroid notch to and this midpoint, and half the distance becomes again 7.5 millimeters. This is 7.5 millimeters. So that means we have taken half the distance again. This is 15 millimeters and 7.5 millimeters is the half the distance. So this is called half to half rule of Pico, right? Then you can join these two. This becomes the anterior border of the window. You can join these two like this. You can join like this. These two points. So you are 2 millimeters or 3 millimeters above from the inferior border. This is very important. Inferior border. So this is the anterior margin of the window. TheraPlast window made. Now we have to go posteriorly, and this one. Usually posteriorly it will be about 10 to 12 millimeters in females and about 13 to 15 millimeters in males. So we are going posteriorly and make another mark, say 30 millimeters. Now these two points you have to join like this. These 2 points join. Now watch carefully. You can see this is inferior border and this is inferior margin of the window. See what I made it very important. the inferior marginal window should be always parallel to the inferior part of the thyroid lamina. That is very important. It is important. And you have to leave 2 to 3 millimeters above this inferior border. That is also very important. So this is very good. So again, the anterior most portion parallelly you make at the same level, you make another marking here. So join these two lines. There is posterior border you can make like this, join these two, and also the superior border you can make join these two. So you got a thyroplasty window. That is the thyroplasty window got. So this is the anterior margin of the thyroplasty window, and this is the inferior border of the thyroplasty window, this posterior border and the superior border. So you can see
after marking and making of the thyroplasty window, the next step is opening of the window. The window is opened by cutting the window all around along its margins, that is inferior, posterior, superior and anterior. The window is cut either with a sharp knife if the cartilage is very thin, as in younger individuals, or sometimes it may need a drill and a burrs, both cutting burrs and diamond burr of 2 mm size. After opening the window, the next thing is fixation of the silicone implant, introduction and fixation of silicone implant. The silicone implant taken from a silicone block and the thickness of the required thickness depends upon the amount of glottic gap, and then it is fixed in the thyroplasty window, and it is just pushed medially so that the paralyzed cord will be medialized and the normal cord will touch the paralyzed cord, the glottic gap is closed and the voice is registered immediately. And most important thing is the fixation of silicone implant, to fix it in such a way that it should be remain permanently in the window. There are 3 methods. The first method was suturing of the implant to the edges of the window, which was originally described by Professor Ishiki. The next method is to make flanges in the silicone implant, and then to undermine the edges of the window and tuck the flanges underneath the edges to fix it up. This was described by Professor Kaufman from United States. Both these procedures we have practiced for about more than 10 years, and both are time consuming, and sometimes we find some problems like rejection of the implant, lateralization or migration of the implant in some cases. So later we designed another technique called as sandwich thyroplasty technique, where the implant is sandwiched between the inner pericardium and outer cartilage part of the window, and it is firmly fixed in the window. I would like to show you that in the surgical video.
Patient of post-thyroidectomy with a scar on the neck. We are injecting 1% Zolacane with 1 lakh adrenaline, and just parallel to the previous scar, we might find the marking of incision. Then we will make an incision of about 4 to 5 centimeters, starting from the midline towards laterally, and then we will expose the thyroid lamina on the parallel side. At this level, what we do, we make a window, a rectangular window exactly at the level of the vocal fold, and then we remove the core-like cartilage of the window by burring out with a burrs. Then after removing the cartilage, we expose the inner pericardium at the level of the parallel vocal fold. And this is the inner pericardium you can find there. Then we introduce this elastic implant and push this inner pericardium inside so that the parallel cord will go medially. The normal cord will touch the parallel cord.
7B Theraplasty innovative technique designed for simplifying the fixation of silicone implant in the theraplasty window without any sutures or flanges. After marking theraplasty window by half to half roll of Kaufman, the margins of the window are cut with a sharp knife along its borders, first the perichondrium and then the cartilage. In cases of calcified cartilages or elderly people, the window is cut along its margins with auto drill using cutting burrs and diamond burrs of 2 mm size without damaging the inner perichondrium. After completing the cutting, the cut portion of the cartilage is elevated superiorly from the window, fractured at the superior margin, and left as a hinged door at the superior margin of the window. The internal perichondrium is freed along its inferior border to have good flexibility when you introduce the implant into the window and for medialization of the vocal fold. After freeing the inferior border, silicone implant of required thickness taken from silicone block is introduced to the window. Then the hinged door is brought onto the implant and closing the window. The hinged door, now you can see that we'll bring the hinged door onto the implant and close it like that, so that the implant is fixed firmly in the window without any need for flanges, which are time consuming as well. After test one, they're excellent, and most of the patients will have more than 90% excellent results. They well experienced hands.
I am V.N. Raju. I come from Montreal. Voice disorder since my childhood. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Today is 27th November 2005.
V.N. Raju from Montreal. During my childhood, my left vocal cord got paralyzed. I got it operated by Dr. V. Fanindra Kumar at Guntur. After the surgery, my voice is better. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 25th December 2005.
Good afternoon. How I do pediatric tracheostomy? This is the Bible for a pediatric airway surgeon, written by Professor Philip Monier. He's dedicated this book to all the children who have endured the nightmare of living with a tracheostomy cannula and to the family members who have gone through frightening experiences while caring for them at home. So, pediatric tracheostomy is very, very important to reduce this nightmare for the family. So how I do pediatric tracheostomy? This is one of my recent pediatric tracheostomy. I have I am presenting this. This is an unedited video. We always infiltrate with 2% xylocaine with adrenaline and then make horizontal incision just below the lower border of the cricoid cartilage. I always mark the hyoid bone, which is very prominent in children. Sometimes it is very difficult for us to feel the thyroid cartilage, but most of the time we'll be able to feel cricoid cartilage. So once I made the incision, I'll deepen it with the monopolar cautery incision just below the lower border. And I'll buzz the whatever bleeding to keep the field very clean so that we can follow layer by layer. And finally, we'll be able to do a surgery like any other neck surgery, which is clean, and all the structures will be seen and preserved. Pediatric tracheostomy is not like adult tracheostomy. You just can't just go into it and put a hole and insert a cannula. Here, I remove the subcutaneous fat so that when I do the maturation suture later, this will be easier and nicely we can close the tracheostoma later on. Then I take the bipolar cautery, which is like a magic wand for me. I use this throughout the surgery to buzz, cut, and elevate the layers, retract the strap muscles for everything, so that I can make the field clean so that I know where I am working. Now I'm going back to monopolar cautery so that I can go to the subplatysmal plane. I generally make a little wider incision so that I can see all the structures. And anyway, we're going to close it. So it doesn't matter whether you're putting a little longer incision or shorter incision. Here, I'm able to see the anterior jugular vein, which is very prominent. I don't want to injure that vein. So I'm going to ligate that vein. So the hemostat is inserted underneath. And double-layered silk suture is passed and cut so that you can ligate up and down of that vein and then cut it. Sometimes you may encounter multiple anterior jugular veins, which may be very prominent. You can ligate every single vessel and cut it so that you will have a clear field. And also you won't have any erosion later on and will give a nagging bleeding in immediate postoperative period. Now I'm going back to bipolar cautery. I usually have a very short, fine bipolar cautery probe so that I can divide the fascia in the midline so that I can retract strap muscles both sides. The trick of a good successful tracheostomy is sticking to the midline always. Not only for tracheostomy, for any laryngotracheal reconstruction, it should be the good practice to just be in the midline, divide the fascia and retract strap muscles laterally. If you make accidental injury to the strap muscles, then there will be nagging bleeding, and it is very difficult for us to follow the plane later on. So we have to be in the midline always. Once you are in the midline, there won't be any problem of injuring any adjacent vessels or any vital structures. And once you are going deeper to the strap muscles are retracted both sides. The first thing what we will encounter is thyroid isthmus. So we need to be a little careful in identifying the structure and not injuring it. Once you see the lower border of the isthmus, then you can go little below, cauterize that soft tissue there and retract the thyroid if you want up, or sometimes if you want to do a high tracheostomy, you can divide the isthmus, ligate it, or just buzz it with bipolar cautery, and you can go up, do a window in the upper tracheal rings for high tracheostomies. So that's why we always have to do a pre-tracheostomy endoscopy to see the lumen and decide what you are going to do, whether it is a high tracheostomy or low tracheostomy or mid tracheostomy. I would like to do a low tracheostomy most of the time. That will be safer in case if we want to do a double stage procedures later on, like double stage reconstructive procedures or partial laryngotracheal resection and anastomosis. For all those things, if you do a little low tracheostomy, then that will be very convenient for us to put a laryngeal mold or stent above. In case if we are decided to do a single stage procedure, whether it is a laryngotracheal reconstruction or partial cricotracheal resection, then it is prudent to do a high tracheostomy, maybe in the second ring or even in the first ring, so that we can include that in the future reconstruction, so that it will be a single stage procedure and you can intubate from above. That will act like a stent, and once the stent is removed, then the patient will be not having any stoma. So here I've decided to little low tracheostomy, not very low. So once the thyroid isthmus is retracted up, I'm able to see the fourth and fifth tracheal ring. So I'm inserting the needle in between fourth and fifth tracheal ring and inject a little bit of Zalcan. You can see the air bubble coming out. So that means I am right on the anterior tracheal wall. So once I have decided to do a window in the intercartilaginous space between the 4th and 5th tracheal ring, I can use the 15 blade to make a horizontal incision. Some people would like to do a vertical incision between the 4th and 5th tracheal rings. In that situation, you can take stay sutures both sides and make a vertical incision. Most of my tracheostomies will be horizontal incision. I would enumerate the advantages later on in my talk. The horizontal incision over the vertical incision. I'm careful not to make the horizontal incision in the tracheal rings. So this incision is being made in intercartilaginous space. Once I have done that, I take 30 or 40 vicryl suture and suture the cut end of the cartilage with the lower skin. So now I'm taking a bite in 5th tracheal ring. This is a submucosal bite. I'm careful not to run the needle in the lumen so that will be a foreign body later on. So this is a submucosal, and now the lower skin is brought to the anterior wall of the cut edge, and I'm keeping this as a stay suture till the end of my surgery. So this will act like a control of the airway. So whenever I have a problem, I can just pull this up so that the airway is with me all the time throughout the surgery. Now I know how much of the window I'm going to create, because I'm going to do a vertical cut on one tracheal ring. Here, in this case, it is going to be on the 5th tracheal ring, both sides, so that I can create a lower flap that is going to be a lower yoke flap. The advantage of having a lower flap is the tracheostomy tube will be sitting over it, so it won't hang down further. So this is the advantage over the vertical cut. In case we are doing a vertical cut between the 4th and 5th anterior wall of the tracheal ring, then the tracheostomy tube will be hanging down, damaging the lower healthy tracheal ring. So in case if you are going to do a reconstruction or partial cricotracheal resection anastomosis, then you will be losing one healthy tracheal ring unnecessarily. It is very vital to keep all the healthy rings for the future reconstruction. Now I'm measuring the tracheostoma size so that I would not make a bigger window. So I just want exactly the size of the tracheostomy tube so that I can do a maturation sutures all around So the opening will be just enough for inserting my tracheostomy tube. So I'm starting to do a maturation sutures. So the maturation sutures are bringing the skin to the anterior tracheal wall where I have created the window, so that I will have a complete cover of the tracheostoma by skin all around. So that means there is no raw area left, and the whole tracheostoma is completely covered by skin. I'm taking 2 sutures in the lower flap what I have created. So the cartilage is being sutured to the lower skin. So this is absorbed suture. You can use either 3 or 4 Okrek Weichel. So this is the 3rd suture I'm making in the lower flap. You can see I'm taking a submucosal suture so that there's nothing going into the lumen. I'm able to completely bring the lower skin to the cut cartilage. So the tracheostomy tube will just sit over it and preserve the lower tracheal rings. And another good advantage is when you're closing it, if you're doing a surgical suture, just release that lower 3 sutures and bring the lower cartilaginous flap back into the window and do the vertical 3 sutures with the upper cut edge of the cartilage so that it will be completely closed later on when you want to decannulate. Now I am taking a upper suture. So this is going to be complete multiple sutures made for maturation of the skin towards the anterior window. So that means the end of the surgery, you will have a complete tract of tracheostoma There are many advantages of doing maturation suture because when you insert the tracheostomy tube, it is very easier for you to insert and there won't be any false passage. And the chances of accidental extubation is very less. Even if there is an accidental extubation, then reinsertion will be easier so that you can avoid false passage. Because it is completely covering the raw area, the postoperative bleeding will be minimized. The superior skin now is covering the isthmus of the thyroid so that the friction of the upper part of the soft tissues with the tracheostomy tube will be minimized so that post-operative bleeding from the blood vessels of the thyroid gland will be very, very less. Another advantage is anybody can remove the tracheostomy tube and reinsert. Even the first tube change can be done by the residents or staff nurses in the ICU without the need for an ENT surgeon. And you can do tube change as early as 3 to 5 days so that the post-operative stay in the ICU will be minimized and the cost will be reduced considerably. And also, you can teach the parents early how to do the tube change, and they can go home early, and in case of any emergency, they can reinsert the tube. In case of tube block, they can remove the tube and put a new tube, and they'll be taught all the resuscitation maneuvers so that the child will be with safe hands at home also. You need to be careful in retracting all the strap muscles away from your sutures while doing maturation suture so that you will have a complete covering of the tracheostoma. So the post-operative dreaded complication of granulation tissue formation will be very much reduced. And another advantage is suprastomal collapse is very common in children after tracheostomy, but it is less common with maturation sutures. Now I'm doing lateral sutures of the skin, just approximate with a close knot. And all these sutures are made with absorbed sutures, so you don't have to remove it. The only problem with the maturation suture is you may have to do a surgical decannulation later on. Even if you do a medical decannulation, some of the children will come back with tracheocutaneous fistula, and then you will have to excise the fistula and close the neck wound. But the advantage would be you can also revise the ugly scar which is formed by tracheostomy, and we can give a decent skin crease scar after surgical decannulation. So now the stoma is completely formed and it is completely covered. Now the endotracheal tube is being pulled up, kept just above the suprastomal region, and I'm inserting the tracheostomy tube, which is going in nicely without much problem, and I'm moving the obturator. I'm still keeping the lower stay suture so that in case there is any problem, I can just pull the tracheal wall anteriorly so the airway will be in control. At this stage, I remove all the drapes. And check for the chest rise. Here you can see the chest rise. And also, you can ask your anesthetist to auscultate the chest to know both lungs are being ventilated. Sometimes, if the tracheostomy tube is a little long, or if you are doing a low tracheostomy tube can go into the right main bronchus and you will have one lung ventilation. So once you are sure that both lungs are being ventilated, then this is the time you can remove the lower stay suture and tie the strap around the neck. Keep one finger inside so that you won't tie it very tightly. And I keep a loose knot till I'm very sure that the neck is not being compressed. I don't make any sutures with the skin and flange of the tracheostomy tube. I just put a sofa tool. You have to be careful in not putting the cut edge towards the stoma so that you will prevent the fibers get into the lumen and give a foreign body reaction later on. To keep this for a day, the next day it can be removed and normal gauze dressing can be done in the ICU. I always keep the child in ICU till the first tube change, till the parents are being taught about the tube change and resuscitation, and then send them home. A good tracheostomy can prevent complications, and early decannulation is based on the good prevention of tracheostomy related complications and the surgery of the primary problem, either with laryngotracheal reconstruction or partial grecotracheal resection anastomosis. By doing a good tracheostomy, we are reducing the burden of the family and the healthcare system. We all join together to do a proper tracheostomy in children to reduce the burden of the society. Thank you very much. No question, nothing.
Myself, Dr. Vishwajit Gogoi. Firstly, I would like to thank FC and organizing committee of PHONOCON 2020, especially Dr. Sanjay Shubhya sir for giving me the opportunity to share our experience on recurrent laryngeal papillomatosis in the surgical video sessions. In our limited experience, since we have been dealing with recurrent laryngeal papillomatosis in the mostly younger age group, so today I am going to present on surgical approach to juvenile onset recurrent laryngeal papillomatosis. And before the surgical video demonstration, let me give a brief overview of the disease recurrent respiratory papillomatosis. The causative agent is a human papilloma virus, and the strains 6 and 11 is mostly involved in RRP, and 11 being the more aggressive form. It is also most common laryngeal tumor in children. According to the age of onset, it is divided into juvenile onset and adult onset. Those juvenile onset up to 5 years, but many consider it up to adolescence. Juvenile onset recurrent laryngeal papillomatosis is mainly by vertical transmission, while adult onset is by horizontal route. Along with the viral genotyping, histopathological examination is must to rule out malignancy and also malignant transformation. Let also understand the pathogenesis. HPV enters through a bridge in the mucosa or epithelium. The HPV DNA integrates in the transitional epithelium of basal layer, causes an immune regression leading to HPV DNA integrated cell division and multiplication. These cells then immigrate to upper layer and produce virine, causing induction of wart-like lesion. These wart-like lesions are pathognomonic finding during laryngoscopy. RRP may involve any subsite of the respiratory tract. This most common site of involvement is glottis, more than 90%. It may be a single lesion or it may be multiple lesions, but if you can appreciate it assert that high incidence multifocal lesions also primarily involve the glottis. Regarding the clinical presentation, this includes dysphonia, hoarseness. Sometimes they may present with a respiratory distress with a respiratory or a biphasic stridor. They may comes in the interoperative interval also. The child may comes with a tracheostomy also, and also with a distal involvement like pulmonary extension. Regarding investigation, a transnasal flexible laryngoscopy with a lidocaine spray is the ideal for diagnosis of laryngeal papillomatosis lesions. We use 2.8 mm outer diameter bronchoscope for pediatric age group. We don't sedate the child. If NBI is available, then it gives add-on details of the vascular pattern of the lesions and also give the information regarding malignant transformation. Regarding reporting, two grading systems available, the more elaborate and score-bound Darkey and Cotra grading system. It's based on 25 anatomical subsites, and it's good for predict interval between the surgery. And more simpler Dickers grading system. Here, as you see, there's a grade 1 is a sessile growth of unifocal or multifocal, grade 2 exophytic unifocal, but it's grade 3 exophytic multifocal lesions. We basically use Dickers grading system in our reporting. Surgical debulking with the aim of relief symptoms is the mainstay of treatment for recurrent laryngeal papillomatosis. The surgical excision can be undertaken by cold instrument, microdebrider, carbon dioxide laser, and coagulation also. The laryngeal blade, tricut, and skimmer is very useful tools for saving of all the papillomatosis lesion by the microdebrider technique. Carbon dioxide laser is also very excellent tools for papilloma excision, but I have no experience in pediatric age group. Along with the surgical debulking efforts are there to establish biologic as a adjuvant therapy for recurrent laryngeal papillomatosis. The antiviral cytophobia used by many centers, but we use bevacizumab in our center as an adjuvant with a surgical debridement. There is also a study in Australia. They have found that after implementation of SPP quadrivalent vaccine for all females between the age group of 12 to 26 during 2007 and 2009, the RAP reported cases declined from 0.16 in 1 lakh to 0.02 in 1 lakh in 2016. So definitely the SPV vaccination has a great role in SPV viral prevention. Now let's move to today's case. He's a 3-year-old male child born by spontaneous vaginal delivery, presented with a dysphonia and respiratory difficulty. He had these symptoms for the last 1 year, but with a progression since last 3 months, with no associated history of cough, cold, and fever. We did the transnasal fiber optic laryngoscopy, and I can appreciate here he had a polyp originated from the left vocal cord involving anterior commissure and also subglottis. So it is basically a multifocal exophytic kind of lesion with a Dickers grade 3. During the TNFL examination, we also look for the feasibility with our anesthesia colleague. We can call it a joint team review for the anesthetic feasibility. And we here can appreciate that he had an optimal posterior glottic space for intubation. Then after anesthetic feasibility, baby was prepared under general anesthesia. And after pre-oxygenation, pre-medication and nebulization, we should not try for too much of bag and wax. This child was induced with inhalation agent sevoflurane, and 2.5 outer diameter endotracheal tube was used for the tracheal intubation. Here, atracheotomy is used as a muscle relaxant for proper relaxation and maintained with oxygen and nitrous oxide. Now let's move to the surgery profile. VLS or MLS setup is ideal for a surgical excision in adult papilloma cases. We have also started pediatric cases with a MLS system, but for younger children like aged less than 2 or 3 years, there is no VLS system, and the issue with the MLS system, it is a less working space for the debrider and gobleter. Basically, it is a less lateral space for the instrumentation. So that's why we have developed our own armamentarium. Basically, this is a kind of a jugaad. You can appreciate in the first videograph, the very angle microdebrider blade provided very handy to save off the fronts of the papilloma. The same microdebrider blade we are using for sinus surgery. It has an adequate length for pediatric age group, less than 5 years, but not sufficient for adult. For adult, we have to take a laryngeal saver blade like schema or tricut blade. And the second videograph, you can appreciate the pediatric Macintosh straight blade available in the various sizes. It's a very good replacement for the ideal Farson laryngoscope. It provides good lateral working space for both endoscope and for the saver blade. That's how we can engage our endoscope. We prefer to use nowadays 5 mm laparoscope for better visualization and also for better depth perception. In recent edition, in our improvisation bag, where it is small size arthroscopic cutting shaver blades, we found it extremely useful for more delicate shaving areas which demand more precision. After intubation, we try to document the findings by rigid telescope. Strauss Spice camera also provide a kind of NVA settings to actually visualize the typical loop vascular pattern of the respiratory papilloma. For reference, I want to quote the article published by European Laryngeal Society, where Frederick G. Dickers also a co-author. Here it is very well mentioned that the development of the perpendicular vascular changes, which can be appreciated by high resolution camera or by NVI or by autofluorescence technique, the interepithelial papillary capillary loops Some residual papilloma is noted in the subglottic area. Now here I want to highlight another point. Here we are using 5 mm 15 degree rigid endoscope. Basically we are changing from 4 mm nasal endoscope to 5 mm 15 degree laparoscope, which gives excellent wide exposure and also the depth perception. So as we showed that there is a tiny papillomas lesion in the subglottic area, which is a rare challenging part of the surgery. Here you can appreciate this part. I am trying to exercise the utmost caution and precision, always keeping the cutting portion of the silver blade in visualization. Sometimes we can take the anesthesiologist for off the tube debridement, which in other we can call is as a apnea technique or off tube technique. Lawyer is fine, and the SIL is follow up after 2 weeks. This is his genotyping report with HPV 11, and now this time we go for bevacizumab intralesional injection. But before that, we can have a few tiny lesions. giving me the opportunity. Thank you so much. Thank you.
Good evening, everyone. At the outset, I would like to thank the organizing committee of PHONOCON 2022 for giving me this invitation and opportunity to present. It's an absolute honor and privilege to talk among such a gathering of esteemed seniors and colleagues. For airway surgery, I strongly feel there are certain basic requirements that are needed to be an airway surgeon. We need to have a good understanding of airway anatomy. There needs to be a good experience with using a flexible bronchoscope as well as rigid bronchoscopes and endoscopes. A good understanding of the pediatric and the adult airway anesthesia. Apart from that, dexterity with both endoscopic and open surgery is required. Moreover, they need to be having a good anticipation, dedication, innovation, perseverance, and above all, humility should be there. As in the other fields of surgery, even in airway surgery, we have progressed from open surgery to minimal invasive to endoscopic surgery, where the basic focus is on improving the cosmosis as well as minimizing the morbidity, but yet not compromising on the final outcomes. Again, as in any other field of surgery, the basics principles remains the same. There need to be a good case selection, which is applicable for both open and endoscopic surgery. We should know our anatomy well. For endoscopic, we should know anatomy inside out, and for open, we should know anatomy very well outside in. Again, respecting the tissue and the mucosa is paramount, preserving the blood supply, and most importantly, not causing any irreversible damage while doing any procedure. So the basic concept when we do a laryngotracheal framework surgery, and especially deciding whether we do open or endoscopic, is we need to see whether the cartilage framework is intact. If it is intact, we can do both open and endoscopic surgery. If the cartilage framework is poor and there's a destruction there, only open surgery should be done. Again, it is important to understand when not to do endoscopic surgery, especially more so when we see this picture on the right side, when already the trachea is fibrosed. We cannot do an endoscopic surgery because whatever lumen we may create, it's not going to be sufficient enough. Balloon dilatation, it has less risk, but if it is not working, then probably we should consider doing an open surgery. So, coming to the candidacy for the endoscopic management, there are certain absolute indications like grade 1 or 2 stenosis, we should do endoscopic surgery. Soft stenosis, most importantly, we should do endoscopic surgery. In certain condition of autoimmune conditions like vaginals, we should go for an endoscopic surgery. But there are some relative indications as well, where there is a grade 3 stenosis, which is a soft and early recent onset. We can still go ahead with doing an endoscopic surgery. In certain cases of distal tracheal stenosis, some cases where patient is refusing open surgery, when there is a long segment which is unsuitable for open surgery, we can try doing an endoscopic surgery. As a temporizing measure to stabilize the patient or to make the patient fit for an open surgery later, we can go ahead and do endoscopic procedures as well. But again, we need to see all the risk involved in doing either the open or the endoscopy, and always keep the patient safety of the utmost importance. So this is going to be my first case, where as a 1-year-old girl child without any history of intubation presenting to us with stridor. So whenever we take the child for a assessment, we go with the preparation that we may need to do simultaneously any treatment for if any kind of stenosis there, need to release it and open the airway. So when we examine this child under anesthesia, we start with a bag and mask ventilation, and after giving the choline, we saw this web, thin web. So the basic idea is to release the web. Usually we prefer taking a Mercedes-Benz kind of an incision to release the web. Initially you saw the web release with a sickle, and now with the microlaryngoscopic scissors. Patient is, we are exposing this larynx using an anesthesia laryngoscope, and myself using an endoscope in one hand and this scissors on the another hand. Once we have achieved a little bit of a opening in this, we introduce a airway balloon and inflate it with saline. We can use an inflation device, or we can just use a 20 ml syringe also to inflate this. And now we have achieved sufficient airway. Intermittently, if the saturation drops, since it's going to be a case because it's a 1-year-old child, the saturation may drop very fast. We may do a intermittent bag and mask ventilation. So what we are doing over here is an intermittent apnea technique. After this, we are sizing the airway by using an endotracheal tube. Still, we are not able to place the tube properly. So again, we are using a one size bigger balloon to dilate the airway further. So in this case, we have used the cold steel and balloon only because it's a thin wave and a short segment stenosis and a 1-year-old child. We don't want to create much of a collateral damage also. After this, we are just ensuring hemostasis with the help of adrenaline pledgets. The rest of the airway looks to be good. This is the scopy of the child after 7 days. Normally we do a follow-up scopy, and now you see the airway is well mucosalized. Normally we do follow-up scopy at the interval of 2 to 3 weeks, but in this case the child was from a faraway place, so they wanted to go home early. So we just did this in 7 days. And by looking at the airway, which was quite satisfactory, we didn't feel the need to do it again. So we can say what are the really important determinants of success in endoscopic management. So most importantly, apart from this grading of stenosis from grade 1, grade 2, grade 3, grade 4, it is more important whether the stenosis is soft or hard. If it's a short segment or a long segment, it's an early or recent onset versus a late onset stenosis. So usually soft stenosis, short segment stenosis, and early recent onset stenosis do well with the endoscopic management. Still at times endoscopic methods can be used to avoid tracheostomy or prevent tracheostomy for a certain period of time, avoid complex surgeries, avoid open surgeries where success cannot be guaranteed. It's my second case of subglottic stenosis. It's again a 1-year-old child. We had a surgery for some liver issues. After that, he was in ICU for a few days, intubated. He failed extubation, and on failed extubation, we took him for an airway assessment. So this was the picture on the airway assessment where he was having a soft stenosis at the subglottis. Since at that time the airway balloon was not available, we thought of dilating it with the help of a coblation. Coblation is a radio frequency device which uses a plasma ablation technique. The best part about the coblation is the heat generated is around 40 to 60 degrees centigrade. So there's a minimal collateral damage. When you compare with the laser, there around 300 degrees centigrade heat is generated, and with the cautery around 600 degrees centigrade. So this is the minimum heat generating instrument, and it is a 4-in-1 tool which is having ablation as well as suction, irrigation and coagulation also. But again, like any other powered instrument, we have to be very careful. We have to see what we are doing, because if we just go ahead with it may end up damaging the trachea, the tracheal rings also. So we have to be very careful while using such instruments. Again, the patient is under scoline and a bag and mask ventilation, intermittent apnea technique. That's why we use the anesthesia laryngoscope for exposure, and two-handed technique, one hand using holding the endoscope, and other hand using the instrument. The main advantage of using this method is that whenever the child desaturates, we can quickly do a bag and mask ventilation, and whenever the lumen is sufficient, even we can put in an endotracheal tube also and ventilate the child. Once we are quite sure about the dilatation, we can again use now either a balloon. If remaining dilatation which is not yet achieved, it can a balloon can be used as an adjunct in these situations. So now a balloon is introduced and inflated with saline. The sizing of the balloon is also very important. So in the trachea or the subglottis, whatever size endotracheal tube for that age can be used, plus 2 millimeters should be the size of the balloon. And for larynx, whatever endotracheal tube the child will take or the patient will take, plus 1 for the larynx. Usually it is kept for 30 seconds to 60 seconds, whatever the patient is tolerating, because we need to keep a watch on the saturation also. If the saturation drops below 30, we need to take it out and again ventilate the patient and put it again back. It is very important to achieve hemostasis after this. Usually adrenaline platelet is good enough to do that. After that, we usually apply local steroids. Either we try to infiltrate also in 4 quadrants. As apart from that, we apply locally steroid cream also, which certainly helps in faster mucosalization. Since this child was done during the lockdown period, we were not able to follow up the child with the endoscopic assessment soon after. But this is how child's father has sent us the video of him happily walking around. So just a note on a balloon dilatation. Balloon, it's ultimately a tool, usually very useful for short segment and a soft stenosis, usually works in combination or as an adjunct. Sometimes it can be used in patients who are open surgery is contraindicated or refusing open surgery, or there's a high morbidity associated with the open surgery. A definite contraindication is in cases of the congenital stenosis or wherever there is a loss of cartilaginous framework of the trachea. We cannot dilate a fibrotic tracheal segment with a balloon because it may just burst it open. Again, it needs to be used with the caution in distal tracheal stenosis, and very important to use the appropriate size balloon. You cannot use a bigger size balloon in a smaller trachea, because otherwise it will just burst open the trachea. So it works on the principle of a radial force. There is no longitudinal shearing force associated with balloon dilatation, and it is the most important thing which is again generated interest and application of endoscopic management in laryngotracheal stenosis after the open surgery. Reduced risk in distal airway dilatation, and usually we keep it for like 1 to 2 minutes or whatever the saturation oxygen saturation permits. Whenever the saturation falls below 90%, we can again remove it and ventilate the patient and again put it back. So again, this is one of the balloon company sizing chart, where the balloon size is like shown over here, and how much saline needs to be put in that, and how much should be the maximum pressure. This is the pressure device which we associate to the balloon, and very important to follow this chart and do the pressure accordingly. Again, a small note on coagulation. It's a 4-in-1 rule, as I discussed earlier. Very importantly, less heat is generated, so because of that, less fibrosis. And again, since there is a suction irrigation also available, it is easy to use. Whenever any hemostasis is required, it can effectively do the coagulation also. But again, it cannot be used in heart stenosis, congenital stenosis, or a long stenosis, and slightly bulky as compared to the lasers. So coming to our third case, it's a 5-year-old girl child who is a diagnosed case of a vaginous on treatment, comes to us with a progressive respiratory distress. So this was the child when then presented to us. You can see the supraesternal retractions happening. Child was maintaining oxygen and saturation with the oxygen support. So this was the picture on airway assessment. Now you see this child is not completely under. This is normally what we do. We just take the child or the patient on sevoflurane and not paralyze the patient, and have a look once, okay, what exactly is the picture inside, and then again after that we will go in with better preparation after paralyzing the patient, okay, what we have in mind, okay, how we plan to dilate. So in this case, it was more than our expectation, the kind of a lumen what we are seeing. It is surprising the child was able to breathe with such a small lumen also. But again, as we can see, it's a soft stenosis. So the plan is going to be dilating it with the help of the cold steel and doing a balloon dilatation. So now the child is paralyzed. And now we will use cold steel, a sickle, to dilate or take a release cuts on the stenosis. It's important to take these cuts, then only we will be able to kind of facilitate a balloon placement in that area. And again, it helps in achieving the sizable lumen faster, so that we can ventilate better. So initially we use a very small size balloon. It's a 5 mm balloon, just to achieve a little better airway. Sometimes we need to use a progressive sizes of the balloon. Like now, at least we have a sufficient airway if required to ventilate the child. Again, some more release incision on either sides. So in these cases, it's important to see if you are able to manage the child without tracheostomy or not. It depends on the understanding between the anesthetist and the surgeon. It is depends on the kind of experience the airway team has. If they are able to kind of manage it quickly and they have good assistants, so they have everything in place, then we are able to avoid a tracheostomy, and which is really very important. Now what we are doing is a infiltration of Kinacot usually tried to be done in 4 quadrants, but many a times it's not possible to angulate the needle down. But whatever is possible, we try to do that. Steroids really help a lot in healing faster, and it's a kind of a good studies have been done where they show that only a serial application of steroid helps in maintaining the stenosis, or rather sometimes it kind of improves the stenosis also. So now we are sizing the airway using a rigid bronchoscope, how much airway lumen has been achieved, which was we thought of using one more balloon a size bigger to have a age appropriate tracheal lumen for that age of. The best suggestion is by the using the anesthetist endotracheal tube for that age, what should be used, and using that outer diameter of that tube plus 2 mm side beside the balloon. Now there is a good lumen that we have achieved over here, and the rest of the airway looked fine. The inspissated secretions which she was not able to cough it out. And again we apply a little bit of a steroid cream in the end. So this is the child's airway assessment after 2 weeks. Now you see this is little, it's still inflamed, but the stenosis is healed very well. Still the secretions are inspissated secretions are still seen over here, but overall it's quite a satisfactory lumen. And we keep the child under follow-up after this assessment also. And a very good way of clinically assessing the child is going to be asking the parents if any stridor is there, or are they having any exertion while walking around, doing any strenuous kind of activity. In adult patient, what we can ask is ask them to go up 2 or 3 flights of stairs and see if any retractions are happening, or they are having any stridor on doing such an activity. That can also give us a good idea when to take the patient for a repeat airway assessment in case we are anticipating any restenosis. So it's very important to plan, prepare, and then perform. So for that, it's very paramount importance that we need to have a team huddle before starting any airway procedure, where we need to have a discussion with the anesthetist, the scrub nurse, our surgeon assistant, whoever is there. So they know very well what instruments are going to be required, if there is going to be stenosis, what all equipment is going to be required, who is going to handle what. So they need to have a plan ready. Always it's good to have a plan B and C also ready. At times we are not able to manage or open up the stenosis. In that situation, what we are going to do? So if a coblation is not working, then we need to do a balloon, or we need to do a rigid bronchoscopic dilatation or anything else. Similarly, always we need to keep tracheostomy standby. Whatever we are doing, we don't know when we need to do a tracheostomy, because if we are not able to ventilate, we need to do a tracheostomy if the child is not getting ventilated well. There should not be any issues doing a tracheostomy if you feel that you are not able to achieve ventilation, because the patient safety is of the paramount importance. Again, a small note on anesthesia. We can make the patient prepare by using appropriate local topical anesthesia and nerve blocks also in adult patient. Usually we begin with the inhalational anesthesia in form of sevoflurane. Apart from that, we do give propofol also with the adequate pain relief by fentanyl. And after, once we are ready, we paralyze the patient initially with scoline, and we look down the airway using a rigid endoscopes. And if required, if we are able to manage well, we can use if the procedure is going to last for a few minutes to 5 to 10 minutes, then we can use atracurium also. Again, during this time of anesthesia, how we are going to manage the patient ventilation? Either we can use intermittent apnea by bag and mask, or we can some cases use a Thrive, which is a high frequency nasal cannulation oxygenation, or sometimes rare cases we can do ECMO or a bypass also. Apart from that, whenever it's permitted, we can, if there's a good lumen, we can use a intubation also or a tracheostomy. So this is my last case of subglottis stenosis. It's almost 90% stenosis. Patient is already having a tracheostomy. So we actually thought of taking the patient for a open surgery, but there's quite a bit of an infection around the tracheostomy. So we just postponed the open surgery for that. But when we were doing this assessment, we realized it's a very thin stenosis and a soft stenosis, which happened actually, which progressed to such a limit after the tracheostomy. The tracheostomy was done few weeks before only, and this was the video, the assessment video from the tracheostoma down to the carina. So we just thought of opening it up with a coagulation, and as anticipated, it was a thin stenosis, not a very thick web of stenosis here. It's important to preserve the posterior tracheal wall, which contains the trachealis muscle, which helps in the mucociliary clearance basically. So this is what we were able to manage and achieve in the first sitting, and it was quite satisfactory. And as you can see below, there was a tracheostomy tube down. So we just sort of like we will keep the child on tracheostomy, and we applied steroid ointment, and we infiltrated with the intralesional steroid also with Kinacort. And we thought of like reassessing the patient after 3 to 4 weeks. So this was a scopy of this 12-year-old boy only after 3 weeks. As you can see, this is healed really very well. Very good mucosalization happening, but there are few strands of areas which were still keeping the lumen narrow. So again, we did the second sitting of whatever was bulging into the trachea. So this is the third scopy after again 3 more weeks. So after this, agar a rigid bronchoscope was used to size the airway, ki what is if the age appropriate bronchoscope can be passed through the trachea. And this was the final scopy for further after 3 more weeks. The child has already been decannulated, and this is the airways, well mucosalized after. So it's almost took 3 sittings and almost 3 to 4 months of time when we have achieved this kind of airway. Again, it's kind of a rarely happens ki such beautiful mucosalization has happened, and we were able to open this with the help of the coabulator, almost 90% stenosis which was there. So what we can say is always prevention is better than cure. So always try to prevent trauma to airway. Repeat assessment and follow-scopy should be done as a rule. Whenever we are operating a case with the endoscopic method, we should again do a follow-up scopy so as to see and prevent any restenosis. Antibiotics and anti-reflux medication should be given for optimization pre and post the procedure. Adjuncts in form of steroid play a very important role in healing. So the take-home message is the case selection is the key. Soft stenosis, early stenosis, short segment stenosis usually do well with endoscopic management. We have to plan and prepare well for all anticipated situations. Teamwork is the way to go. We need to use our tools wisely. Either if we are using laser, cold steel, balloon, coagulation, every tool has a place and it should be used wisely. Endoscopic management is certainly with low morbidity and definitely a promising modality for the future. And we should not shy away from doing open surgery at an appropriate time if required and if we see the endoscopic management is not really working well for the patient. Thank you so much for patient listening. I'm open to any questions. Thank you.
Thank you, sir. That was such a wonderful session that we've just had. We thank all the distinguished faculty whose meticulous surgical demonstrations are sure to help us all budding surgeons in understanding and improving their skills. We have a few questions for a few delegates here. One is to Dr. Arpit Sharma, sir, and there are a few to Dr. Nupur Nerurkar, ma'am. Arpit, sir, okay, there are a few questions for Nupur, ma'am. First one, ma'am, how long does it take for the epithelium to regenerate following polyp excision?
So typically the regeneration takes about 4 to 6 weeks. It also depends on how much of raw area was created. So if an epithelial cordotomy was made and then the entire epithelium was reposited, of course, healing would be a bit faster. But even with secondary intention, it takes about 6 weeks for the healing. So when we are doing a staged surgery, for example, we'd wait for around 6 weeks to go to the other side.
Thank you. How to differentiate all 5 types of vocal cord cysts, ma'am, from your talk?
Okay, so the thing is that primarily you've got the mucus retention cysts and the epidermoid cysts. This is what is seen more commonly. Of course, it's a histopathological diagnosis. And as I mentioned, the current classification can further classify them as A, B, and C, D. But simply put, mucus retention cysts appear more translucent. The borders are not so clearly well defined. Epidermoid cysts appear more yellowish or whitish, as though filled up with something like a toothpaste or like a cholesteatoma, and the margins are very clearly defined. Typically, the epidermoid cysts one does see in the younger age group because a lot of them are congenital. But that's not necessary. And mucus retention cysts typically happen in phonotraumatic individuals. But again, this is just a generalization. So that is for the mucus retention and epidermoid. And of course, we confirm that with histopathology. A hemorrhagic cyst would, it's difficult sometimes to identify a hemorrhagic cyst from a polyp. And a lot of my fellows, when they're training, ask me that, why are you calling this a cyst and not a polyp before surgery? So the best way I can explain it is really if the lesion is tethered down by the epithelium and it appears very spherical, whereas a polyp is more loose and pedunculated kind of. Again, it's during surgery that you look for the capsule and the anterior posterior fibrotic bands, which would confirm that this is a hemorrhagic cyst and not a polyp. And then a ligamentous cyst is always something you'll identify during surgery because the mucosal wave in any cyst is going to be poor. In polyps, the mucosal wave is pretty good. In cysts, it is very poor because there's a capsule. So, it's not that a ligamentous cyst will give you a worse mucosal wave necessarily. So when you're doing the surgery, you see the base attached onto the ligament, and so you know it's a ligamentous cyst. And finally, we come to the 5th type, which is the open cyst. Now, Boucher has described this actually as a focal pit filled up with keratin debris. Basically, the idea is that there is a depression in the vocal fold, which is filled up with keratinous debris. So whether you call it an open cyst or a type 3 Boucher kind of focal pit, the idea is that when you just go in for palpation, you will get free edges. You've not done any epithelial cordotomy, you will get edges. And inside those edges, there's a pocket filled up with debris. So it's something which you will typically confirm during surgery. So that's, I guess, how you will identify the 5 cysts.
Thank you. Ma'am, and there's one more, ma'am, for you. Apart from laser, can any other modality be used for glottic cysts, like coagulator or harmonic scalpel?
I think cold steel is a wonderful tool to use for cysts. It's really wonderful. And before I was so comfortable with the laser, I was simply using cold steel. And when you use cold steel, you need to make sure that your instrument tips, they are not 3 millimeters, which the old scope, the instruments were. They should be 1 millimeter tips. So the sickle knife, the hardship forceps, the elevator, all of them should be very fine instruments, and the scissors should be sharp. They should be really nice cutting instruments for the anterior posterior fibrotic bands. So cold steel, I think, is a fantastic option. I'll tell you why, because when you're using coblation, there are just 2 types of wands available to you. And even the thinner wand, really, it's not an ideal wand to make an incision with. When you're using, let's say, an AccuBlade system, your incision, if you keep the depth at 1, it's 250 microns. So you have to buzz it 3 times to actually cut through the thickness of the epithelium. With a sickle, of course, you're cutting through the whole thickness and you tether it upwards and continue with the upward scissors. But with a coblation, you can't achieve that kind of finesse at all. And the harmonic scalpel is the same. So those are good instruments for, let's say, you have a hemangioma of the larynx, when, because CO2 lasers can't get more than 0.5 millimeter. But I don't think those are instruments which are very useful for this kind of finesse work. Arpit showed us how they can be used so effectively in subglottic stenosis. Biswajit showed us that, you can use the debriders, etc., so well in papillomas. But I don't think that's the instrument you'd want to use necessarily for a cyst.
Thank you very much, ma'am. Thank you so much.
Thank you.
Thank you. We have one question to Arpit sir. Sir, the question for you is, how do you decide the number for boogie dilatation for thin and short segment stenosis? Is there any formula? Please let us know, sir.
Can you repeat the question, please?
Yes, sir. Yes, sir. How do you decide the number for the boogie dilatation for thin and short segment stenosis? If there's any formula that you apply, sir?
Again, I will reiterate the same thing. Best suggestion to use over here is use the size of the endotracheal tube the patient will take in. But again, off late, I have not used bougies because problem is the initial part is thinner, but the distal part, it becomes tend to be a thicker part. And whether you're guiding the bougie down, it may go and hit anywhere down. So we have to be very sure where the bougie is pointing downwards, because the stenosis is high up only. But when you're inserting the bougie down, it may go hit anywhere, and you have to be very sure where it is. So though it is a very time-tested method of dilatation, but we have to be very careful with the bougie thing. So that's why I have not used bougie in last 6 years or so. But again, if at all the patient is having a subglottic stenosis with a tracheostomy, what we can do is we can pass the other end of the bougie through the tracheostoma and then dilate it to and fro like this. Or otherwise, and we go for a serial dilatation. We use a smaller size bougie first and then go for a bigger size in a progressive dilatation.
Okay, sir. Thank you, sir.
Thank you, sir. Thank you for to all the distinguished faculty for clarifying our doubts and helping us understand the subject better. We will now move on to the presentations for the Senior Consultant Award. So delegates, kindly sit back and enjoy the show.
Thank you.
A very good evening to all. I'm here to talk about a study on the prevalence of arytenoid adduction asymmetry in normophonic subjects, which was conducted in our department last year. And the objectives of the study were to find out the incidence and severity of arytenoid adduction asymmetry in normophonic speakers, and to identify its demographic characteristics. It was done as a retrospective observational clinical study, and it was practically difficult to get adequate number of normophonic subjects to do a flexible laryngoscopic examination of the larynx. So we went to the medical records and collected the videos of those patients who presented to us with problems while singing, but they never had any voice problem while speaking. So from that collection, we excluded those with age less than 18 years and those above 45 years and those with any chronic inflammatory disease, or those with previous history of irradiation or neck trauma, and those who ever had any speaking voice problem, and those who had signs of vocal cord palsy in the video, like unilateral false chord adduction or asymmetric ventricle or phonetic gap. So after all these exclusions, we got 347 normophonic subjects, and we analyzed the video, but in initial segment where the patient was doing a sustained phonation of the vowel E at a comfortable pitch and loudness, not while the patient was singing. So from that initial segment of the video, laryngoscopic video, we selected static scopy images at the time of maximum adduction and with the least obstructed view of the larynx, so that we can clearly see corniculate cuneiform vocal cords up to the anterior commissure. And these static scopy images were reviewed by two trained laryngologists separately, and we analyzed the adduction asymmetry of arytenoid and graded the asymmetry. So this is the normal laryngeal inlet, the corniculate and the cuneiform cartilage with no asymmetry of the arytenoid complex. This is grade 1 asymmetry, where the corniculate of one side cross over and come to touch the posterior aspect of the cuneiform of opposite side. In grade 2 asymmetry, corniculate is touching the middle aspect of the opposite cuneiform. In grade 3 asymmetry, corniculate is touching the anterior aspect of opposite cuneiform. So this was the data sheet, which was filled separately by two laryngologists. The data sheet included the details of the patient, the age, sex, and the side of asymmetry, the grading of asymmetry. So after the statistical analysis with the SPSS version 20 using chi-square test and ISA test, p-value of less than 0.05% was taken as significant. Among the 347 subjects, 36.4% had adduction asymmetry of the arytenoid while phonating, and among that, 76.4% had right-sided adduction asymmetry of the arytenoid, and male to female ratio was 1.06:1. So this is a bar diagram from the statistical analysis, where you can clearly see the right side was significantly more than left, and among the both right-sided group and left-sided group, males were more than females. So among those with asymmetry, this 60.3% had grade 1 asymmetry, 34.9% had grade 2 asymmetry, and 4.8% had grade 3 asymmetry. So grade 1 asymmetry was more common in the right side, while grade 2 asymmetry was more common in the left side, and grade 3 was also more common in the right side. And grade 2 asymmetry was more common in females, and grade 1 asymmetry was more common in females. Sorry, grade 1 asymmetry, grade 2 asymmetry was more common in males, and grade 1 asymmetry was more common in females, and while grade 3 did not vary much among the gender. This is a comparison with other studies on arytenoid adduction asymmetry. You can see that right side was more than left in many of the studies, and sex ratio was almost 1:1 in most of the studies, which was similar to our study. And the incidence of the asymmetry in our study was 36.4, but in various other studies it varied. It can vary depending whether the patient was normophonic or dysphonic. If the patient is dysphonic, the incidence will be more. And if the patient is age also matters. Like if the as the age increases, the incidence also increases. In our study, the mean age was 35 years. To conclude, arytenoid adduction asymmetry or overriding arytenoid is prevalent in more than 1/3 of the normophonic population, and it shows significant right-sided predominance. And in the absence of any voice complaint or imperfect glottic closure. It can be taken as physiological or innocent. The prevalence of arytenoid adduction asymmetry or AAA did not differ significantly with gender. Majority of the subjects with adduction asymmetry had only mild asymmetry, and it is important to have a normative data regarding the same, as it helps to differentiate from the compensatory mechanism in various vocal cord pathologies like vocal cord palsy, Ringis face lesions, vocal cord paresis, early glottic carcinoma, etc. So these are my references, and thank you for giving me this opportunity to present the paper.
Good day, ladies and gentlemen. Today's my topic is are PPIs enough to treat laryngopharynx reflex disease? Laryngopharynx reflex disease is the retrograde flow of the stomach contents to the larynx and the pharynx. If the retrograde flow of stomach contents is limited to the esophagus, we call it as a GERD. Various theories have been put forward to explain the laryngopharynx reflex disease, such as physiological barrier theory, where the laxity of the lower esophageal sphincter has been explained, the acid theory, acid reflex has been explained, and the recent papers point the culprit as the pepsin. Pepsin reaches the larynx and pharynx as an aerosol after its secretion from the stomach. There, at laryngeal and hypopharyngeal cells, endocytose pepsin, and this causes the cell damage, giving rise to laryngoscopic findings. The present day management involves the dietary changes, the behavioral changes, where we ask the patient to not to use the tight clothes, and medicines. Present day medicines, we use PPIs twice a day for 4 to 6 weeks initially, and the treatment continues for many years in most of the patients. But PPI acts indirectly on pepsin. It's not the direct treatment. PPIs decrease the acid secretion and increase the pH. Hence, in the absence of the acid, pepsin is inactive. But recently, sudden cardiac arrest and renal damages have been implicated to the excessive use of the antacids, especially PPIs. The only drug which acts directly on the pepsin is HIV inhibitor, Fosamaprevir, which is in the phase 3 trial. In India, we use the time-tested zero soda after suffering from acidity. Probably the jeera for the pepsin, soda for the acid. With this concept, we continued this study using the ajwain and jeera in one group and only PPIs in another group. Aim to compare the outcome of managing LPR with PPIs alone and in combination with the jeera and ajwain. This is the jeera and this is the ajwain. Methodology. A prospective study of 30 patients who visited the ENT outpatient department of our tertiary care center with symptoms of laryngeal endoscopic findings of laryngopharyngeal infections were selected. The 30 patients divided into 2 groups. Manage on group A, manage with the PPIs alone. We give the BD dosage of the PPI. Basically, and Group B, PPIs and JIRA and adjuvant were given. Scoring system developed by Velasquez were employed, reflex symptom index for subjective assessment, reflex finding score based on laryngeal endoscopy examination for the objective assessment. And the findings were charted. The method of consumption in a group B is they used to pantoprazole 40 mg BD doses we used to give, and in both groups, but in a group B, we were asked the patients to consume half teaspoon of the jeera and adjuvant mixture in equal quantity. This powder should be boiled in a glass of water and it should be consumed twice daily before food for a period of 3 months. Patients were followed up after 7 days, 15 days, 30 days, and 90 days. In the results, you can see a group A and group B reflex symptom index. The group B patients showing a better outcome. But in a reflex finding score using the laryngoscopic examination, we didn't find such a big difference in both groups. Better symptomatic relief has been observed in our study in group B patients when we compare just with PPIs and combination of PPIs with JIRA and adjuvant. The present study, as I earlier told, is basically we tried something new, newer dietary modifications which have an impact on the pepsin. Dietary cumin, that is a JIRA, may lowers the pancreatic lysate activity. It also enhances the pancreatic trypsin, chymotrypsin, and amylase activity. This may help in degradation of the pepsin early. The adjuvant decreases the volume of gastric secretions and increase the pH of the gastric secretions. The management of the LPR should be the wholesome. We should not be targeting only the acid part. We should definitely target it as a pepsin and acid part to get the better outcome. There's a better symptomatic relief in combination therapy. But our study is a small group study. A need of larger study population is required. These are references. Thank you.
Respected members of jury and delegates of PHONOCON 2022, my name is Dr. Mukundan Subramanian, and my study is on standardized endoscopic swallowing evaluation for tracheostomy decannulation, SE-SETD, in patients with severe acquired brain injury and disorders of consciousness. A brief background. Acquired brain injury refers to postnatal cerebral damage, and a Glasgow Coma score of less than or equal to 8 can be considered as severe acquired brain injury. A disorder of consciousness is a state where consciousness has been affected by brain injury. The main disorders of consciousness are coma, vegetative state, and minimally conscious state. The correct timing and approach for removal of tracheostomy tube is a critical issue in these patients. Severe dysphagia and associated insufficient airway protection are the main reasons for delayed decannulation of tracheostomy. However, prolonged presence of tracheostomy tube can cause complications, delay rehabilitation, lead to longer hospital stay, and overall higher costs. Decannulation has the potential to decrease morbidity, improve quality of life, as well as responsiveness in patients with SABI. Traditionally, tracheostomy decannulation in critically ill neurological patients were left to expert opinion and institutional protocols, which often included a clinical swallowing evaluation or modified Evans blue dye test. Very often just trial and error. And in fact, even nowadays, most places, patients are sent home with a tracheostomy tube in situ. Tobias Warnecke et al. In 2013 introduced a standardized step-by-step objective measure for readiness for decannulation, which essentially includes evaluation of 1, secretion management, 2, spontaneous swallowing, and 3, laryngeal sensation. Now, this is a pilot study which I have done essentially to examine the feasibility of performing SESCTD in patients with severe acquired brain injury and disorders of consciousness. All the examinations were part of the procedure for tracheostomy decannulation, and informed consent was obtained from the patient's skin. This study was done from December 2020 to December 2021. All tracheostomies were done by the same surgeon, and critically ill neurological patients who were completely weaned off from mechanical ventilation and had no active infection or hemodynamic instability were included in this study. Patients with past history of dysphagia were excluded. After deflating the tracheal cuff, the extent and localization of salivary pooling is assessed. If massive pooling or silent aspiration is visible, the investigation is stopped at this point. If not, then the number of spontaneously occurring swallows is rated for at least 2 minutes. If there's more than 1 efficient swallow per minute, the investigation proceeds, and laryngeal sensibility and cough reflex are tested by gently touching the aryepiglottic fold region with the tip of the endoscope. If no motor reaction can be obtained, a critical sensory disturbance must be assumed and decannulation should be postponed. The decannulation protocol, which is followed, includes cuff deflation and cannula occlusion to evaluate permeability to upper airway. If the patient had stridor or absence of airflow at the upper airway, then the patient was decannulated. Results of the study: 22 patients with a GCS of 3 to 8 underwent tracheostomy from December 2020 to December 2021. There were 18 males and 4 females. Majority had severe head injury, and the major indication for doing tracheostomy was prolonged ventilatory support. This is the abridged master chart, which I will just break down now. Out of 22 patients, 6 were decannulated the first time they were seen post weaning off from mechanical ventilation. 16 were not decannulated. 8 of them had their tubes removed in a period of 1 to 2 weeks after the initial assessment. 8 patients were sent home with a tracheostomy, as 6 of them had massive pooling of saliva and 2 of them had an asensate larynx. So 63% of patients could be decannulated from this group. Statistical analysis were performed using SPSS 26.0 software. Decannulation was more successful in patients with shorter total duration of mechanical ventilation and shorter periods of tracheostomy. Patients with a GCS of less than 6 could not be decannulated. There was no difference in decannulation success with respect to age, gender, or the primary diagnosis. Hence, to conclude, decannulation is an essential step for rehabilitation. This is a pilot study done by a single surgeon for assessing feasibility. SCACTD is a standardized diagnostic procedure which can be used in the critically ill neurological patient. In my study, SCACTD has shown a promising result of nearly 63% decannulation with the protocol followed. Patients with better GCS scores and shorter duration of mechanical ventilation have a more successful decannulation. However, there is a need for further research using randomized controlled trials and multi-center studies. Improved patient responsiveness and nutritional management after tube removal must also be included in further studies. These are my literature which I've cited. Thank you very much.
Good evening, respected judges and my dear friends. Myself, Dr. Preeti Hazare, presentation number SC04, and my topic for today's presentation is clinical utility of narrow band imaging for laryngeal lesion, a cross-sectional study. The narrow band imaging is an advanced adjunctive tool to white light imaging system that applies optic digital methods to enhance endoscopic image and improves the visualization of mucosal surface architecture and microvascular pattern. It works like a biologic endoscopy by evaluating the neoangiogenetic behavior of targeted lesion, thus helps in a clearer distinction between benign and malignant lesion, helps in targeting biopsies, for predicting the risk of invasive cancers and identification of residual neoplasia in a skull. Though it is not so popular in the field of ENT, but it is widely used with other endoscopists like gastroenterologists and chest physicians for early identification and grading of various lesions. Coming to the basic principles of NBI. When a white light hits the surface of the mucosa, as it contains all the colors which are absorbed, there is no contrast image or reflection is created. When NBI filter is applied in the xenon lamp, which contains blue and green colors, which has got a wavelength of 450 to 550 in between, it has got a greater penetration in the mucosal and submucosal surface. So these waves are absorbed by the hemoglobin and they are reflected back in the form of different colors like brown and cyan colors. So the blue color is absorbed by mucosal capillaries and green color by submucosal vessels, and they represent as brown and cyan color. So this morphology of the vessels are used as a base for the progression of the lesion from the benign to the inflammatory or to the malignant transformation. This is called as neoangiogenesis. So this base was used that is the intraepithelial capillary loop. IPCL was the base for diagnosing the malignant changes in any of the lesion. This grading system was discovered by Ni et al. Into 5 types. So grade 1, 2, and 3 will not show the intraepithelial papillary loops, which are almost invisible in 1 to 3 grade. But from grade 4 to grade 5, this appears like a dot, which is suggestive of neoangiogenesis in the form of different patterns of dot, which may be irregular, tortuous, or like a speckle. So, keeping this base, we have done the objective to evaluate clinical utility of narrowband imaging as compared to white light imaging alone in the diagnosis of various laryngeal lesions. So the study was done at Tertiary Care Center over a period of 2 years. 76 patients were enrolled and the type was cross-sectional study. All patients with suspected laryngeal lesion above 18 years were included, except previously operated patients were excluded. And analysis was done using SPS 22 software for the sensitivity and specificity of the study. So the methodology, And after endoscopic evaluation with conventional white light under local anesthesia, the lesions were identified as for the color change, that is whether it is leukoplakia or demarcated red lesion, and mucosal surface irregularity, that is growth, protrusion or ulcers. NBI was performed immediately with the switch of the button, and all saved images were graded later as per the B classification. Further, patients who underwent a microlaryngoscopic excision biopsy for various lesions where histopathological correlation was done. Also, we have taken the detailed history of associated comorbidities and tried to correlate with the various NBI grading pattern. So the results were plotted in the form of pie chart, tables, diagrams, and graph. So maximum cases were male around 60%. Further, as per the Ni et al., type 2 cases were seen with 46% for later than type 1, which was shown as 18%, and type 3 and type 4 were 13 and 10, and others were shown as normal. So the result correlation of endoscopic findings with IPCL staging, majority of patients presented with benign lesion in our study, 46 were type 2, 18.4 type 1, 13 type 3, and 10% in type 4 pattern, 13% in type 5 pattern. So patients with lesion having malignant potential like leukoplakia demonstrated 100%. So you can see in this diagram the number of patients and their type as per the Ni classification. The cases were commonly granuloma, polyp, nodule, laryngitis, etc. Further, this comparison of endoscopic image with the NBI image, like in different types. So in type 1, they were normal or tubercular laryngitis or post-commercial hypertrophy. Type 2, buccal cord nodule, buccal cord granuloma, and laryngitis. Type 3, with the early polyp formation or polyp with dysplastic changes and laryngeal papillomatosis. Type 4 and type 5 were significantly leukoplakia or carcinoma in situ or proper growth like adenocarcinoma or squamous cell carcinoma. So total of 31 patients underwent microlaryngoscopic excision and their HPR further were correlated as per the different Ni classification. Here, the squamous cell carcinoma and polyp with dysplasia was found to have significant p-value. So the sensitivity and specificity of our study was found to be 84.9 and 81.90 respectively with 95% confidence interval. So further, the association between different comorbidities and NBI, it shows the habits which were commonly involved was the chronic smoking, which is seen in 56%, and voice abuse and history of smoking were other common, followed by GRT and voice overuse. So to conclude, NBI with HDTV monitor has greater sensitivity and specificity than traditional white light alone, and its clinical utility is proved in our study. It is non-invasive, cost-effective, with high versatility and easy to use, and thus can play a role in optical imaging and biopsy. There was a high consistency between NBI classification and our pathological results, but NBI endoscopy alone has some limitation. It cannot completely replace pathological examination. So its main role is in lesions like leukoplakia or carcinoma situ, which may show varying degrees of neoangiogenesis activity. NBI acts as a screening tool for all this lesion. On vast literature search, there is a significant lack of data from the Indian scenario. Current studies suggest that it should be routinely performed as a standard of care in the near future, at least in referral centers. Far from being the panacea of early head and neck squamous cell carcinoma detection, we foresee NBI as a useful tool in the future pre, intra, and post-operative endoscopic workup of neoplastic lesions of the larynx. There is a learning curve associated with interpreting NBI images, and this is a limitation of our study and a drawback in our study. So more high quality studies are needed to further confirm the diagnostic value of NBI endoscopy in laryngeal tissues. Thank you.
Hello, good morning. Today I'll be presenting an insight into tubeless ventilation Thrive in upper airway surgeries. Thrive, that is transnasal humidifier rapid insufflation ventilatory exchange, a novel non-invasive oxidation technique. Recent introduction of apneic oxidation technique has been reliable method of maintaining oxygenation during short airway procedure, and one such excellent procedure is Thrive. This specified equipment delivers continuous warm and humidified 100% oxygen at a high flow rate via nasal cannula and maintains CPAP and ventilation of carbon dioxide. The benefits of using Thrive is it is a non-invasive nature, ease of administration, provides an uninterrupted surgical field, prolonged safe apneic window, low risk of barotrauma compared to conventional jet ventilation, and prevents endotracheal tube related airway injury to the airway injury. The objective of this study was to determine the operative time, total anesthesia time, safety of the Thrive in upper airway surgeries, to compare the safety and efficacy of usage of Thrive on different upper airway procedures, to assess the surgeon's satisfaction and patient's post-operative comfort. It was an observational study among patients undergoing upper airway surgeries with Thrive. Data was collected to a detailed pro forma and statistical analysis was done. Surgeon satisfaction was evaluated by one surgeon, was recorded in the score of 1 to 10. 0 to 2 was very bad, 2 to 4 bad, 4 to 6 medium, 6 to 8 good, 8 to 10 was excellent. This is the pro forma where age, sex, BMI, ASA class, smoking, all other comorbidities were recorded, and these were the things domains were recorded. Type of surgery, operation time, total anesthetic time, mean pre of SpO2, induction phase mean SpO2 during SpO2 during surgery, post-operative period, any episodes of desaturation and any complications were noted, and end tidal CO2 was also noted, and surgeon satisfaction was recorded, and post-op patient comfort was also recorded, and these were our results. We had done 18 cases of MLE, 6 cases of direct laryngoscopy and biopsy, 4 cases of tracheostomy, and 4 cases of balloon dilatation for subglottic stenosis. And here then 4 cases of balloon dilation was done for subglottic stenosis. 3 were female and 1 was male, and the age group of these patients were 20 to 35 years. There were no associated comorbidities. All patients were ASA class 1, and this in this diagram we can see it is easy for us to do balloon dilation when there is no interventional problem. Oxidation is maintained, we get suitable time without any obstruction in the airway, so that easily balloon dilatation can be done. And in this table we can see the mean age for microlaryngeal exchange was 33 years, direct laryngoscopy was 51, tracheostomy 63, and balloon dilation was 23. And most of the ASA physical status scoring was 1 to 2 for microlaryngeal excision, and balloon dilation all were 1, and only in direct laryngoscopy biopsy and tracheostomy where there were comorbidities were more. There were class 2 4 cases was there, and class 3 2, and in tracheostomy also class 3 and class 4 patients were there. And the mean operation time for microlaryngeal surgery was 25 to 27 minutes. Direct laryngoscopy was 18 to 20 minutes. Tracheostomy 15 to 18 minutes. And for balloon dilatation 28 to 30 minutes. The pre-op SpO2 during surgery and post-op, all patients had no problem. All maintained SpO2, and even end tidal carbon dioxide was normal, and post-op SpO2 was also normal. In this, tracheostomy is a very benefit while using Thrive, because most of the time we do emergency tracheostomy for stridor, because oxygenation is maintained. The surgeon can do tracheostomy without any thinking of desaturation. Desaturation was defined as SpO2 90 or less than 90 patient. No patients in our study had desaturation episode during the surgery. No complications were noted. Surgeon satisfaction was in between 8 to 10 score. The post-operatively patient comfort was noted in all patients. The Thrive technique allows for optic oxygenation, and high flow nasal oxygen dependent on the physiological phenomena of aventilatory mass flow, reduces the pharyngeal dead space, increases the fraction of oxygen and carbon dioxide in alveoli, reduction of airway resistance and work of breathing, and improvement in lung compliance. It also provides humidified oxygen, prevents drying of tracheobronchial mucosa, maintaining mucociliary clearance, and reduces airway trauma, usually which was caused by conventional jet ventilation. Then coming to review of literature, Rakesh et al. Presented 16 patients who underwent surgery for upper airway obstruction He had reported no episodes of desaturation and no complications. Young as reported 23 patients undergoing MLA using TRIVE, and the mean operation time was 12 to 16 minutes, and total anesthesia time was about 25 to 30 minutes. And all these were correlated with our studies. Lasita et al. Reported an emergency tracheostomy from 61-year-old patient with supraglottic tumor. The patient underwent successful emergency tracheostomy without any desaturation. All this correlated with our studies. Several studies have demonstrated that TRIVE allows enough time for short procedure with reported apnea time ranging from 18 to 65 minutes. This has extended the application of TRIVE beyond simple using it for pre-oxidation. As TRIVE cannot completely provide a secure airway, it is always mandated to keep the operating theatre equipped with necessary requirements for alternative rescue oxygen procedure. The anesthesia team should be ready to intubate the patient. Endotracheal tube, CMAP, fiber optic, everything should be ready. If there is a desaturation, they should be able to intubate the patient immediately. Conclusion is that TRIVE with appropriate safety precautions can be tried in patients undergoing a range of laryngeal procedures of short duration. Absence of endotracheal tube gives a better view of the pathology with uninterrupted surgical field. All patients in the study maintain stable vital parameters throughout the surgery. The initial results with the use of TRIVE as per our study and other studies are definitely encouraging in both adult and pediatric age group with varied airway pathologies. Limitations are hypercapnia, a valid concern. Monitoring of end-tidal carbon dioxide throughout the procedure is difficult and it is still under trial. These are my references. Thank you.
Thank you all, respected faculty, for your presentations. We have come for the end of the day, and we thank our sponsors for this conference by Olympus, who have been the pioneer in innovative technologies in endoscopy and laparoscopy. Atmos, which expands the creative palette for vocal artists and creators. Cipla Inspira, who have ensured access to quality and affordable medicines. Bangalore ENT Trust for being a huge part of this conference. And of course, last but not the least, Avyaya for compiling and for a seamless transition and projection of the entire event. Thank you one and all. Over to Dr. Smita ma'am for the conclusion.
Oh, it was an exquisite bundle of paper presentations. I'm sure the judges will have a tough time selecting the best paper. Now we come to the end of today's sessions. I hope it has catered to all in the group, starting from the postgraduates to the budding laryngologists to the stalwarts. Let's retrieve for tonight and join back tomorrow morning for a fresh start. Thank you.
Venu, you can stop for live stream.